Prashant, shall we start?
We are live, sir.
Okay. Namaste. Good morning to all our delegates who have joined us today. It was a very
audio.
No, sir.
Vijay, we are not able to hear you. Is it with me or with others as well? No. Audio. Morning, Madhu.
Adul sir, morning.
Am I audible now?
Yes, sir.
Namaste. Good morning to all the faculty members and all the delegates who have joined. Yesterday we had a very
Sir, you are not audible.
You are not audible. Why don't you try without the headphones? I think once you, without the headphones, it was better because we are talking informally, no?
Yeah, am I audible now?
Great.
Okay. Thank you for joining today also, and I welcome all the faculty members and the delegates today's second day of our event, and definitely we are going to have a fruitful discussions again because of all the faculty that has been involved very actively in discussing each other. And now today the meeting starts with the first program. It's a symposium on vitamins and micronutrient replacement in diabetes therapy. How useful it is, whether you have any natural sources or we need to go for pharmaceutical preparations, and also we'll have a balanced view about that. To chair the session today, we have Professor S. Venkatraman, who is the senior most diabetologist in city of Chennai. He's a consultant in Apollo Hospital and as well as Surya Hospital. And Dr. Dhanamitran, again a senior diabetologist from Chennai. And Dr. Anbu Chelvan is a physician come diabetologist from Kanjipuram. So over to you, sir.
Thanks, Vijay. Good morning. Yeah, it was a nice evening yesterday, and I hope the delegates had lot of useful information and insights into the various aspects of diabetes we have discussed. Now, to get back to the subject of today's morning, first topic. We as diabetologists, as well as metabolic physicians, I think the terminology which Professor Moses, MGP Moses always used to coin, we always focus on diet. When we focus on diet, a lot of importance is given for the macronutrients, but I'm sure all of you will agree that when it comes to the micronutrients, excepting in certain situations like anemia, or iron deficiency, or calcium deficiency, wherein you do introduce the mineral in question, but otherwise, as a general policy, to identify the fact that patients could be equally deficient in the micronutrient and mineral aspect as well. I think this perception is, in my opinion, sadly lacking. Number one. Having said that, you always say that if you encourage your patients to have a good amount of fiber in the form of fruits and vegetables, then you can have a good stores of vitamins and minerals, which is natural. Is it so? Do the population across, irrespective of socioeconomic status, do consume the required amount of the fruits and vegetables? And I come to the main point. Even if they consume, are they assured of the mineral content which is expected to be delivered out of consumption of these natural sources? I think this is a point which we want to deliberate, because we did this program a couple of times. I was thoroughly impressed. On the other side of the coin, I think you always have a lot of our prescriptions, most of us, with a B complex or a multimineral. And some of us have a tendency to criticize, is it to promote the industry that we are incorporating a pharmaceutical preparation when the same could be derived from natural sources? So initially, when you formulated the program, Anand, Krishna, and I, of course, with Dr. GVK's sanction, we wanted to have it as a debate. Then we decided it should not be a debate, because a debate, probably if Aishwarya or Nandita, one of them are able to powerfully convey their impressions, I think the message may not be. But even for cushioning that, we did have a person to have a concise view in the form of Jayashree. Today is not International Women's Day, but International Women Diabetologists and Endocrinologists Day. So the three speakers are women. And now I hand over the podium to my good friends and co-chairpersons, Dr. Dhanmitriyan and Dr. Anbuselvam, to introduce the three speakers sequentially and take forward the discussion. And I'll come back at the end of the discussion after Jayashree gives her inputs. Yes. Now over to you, Dhanmitriyan and Anbuselvam, for conducting the meeting.
Thank you, sir. This is Anbuselvan. Let me introduce the speaker, Aishwarya. She did MBBS from NTR University and MD General Medicine from Alluri Sitharama Raju Academy of Medical Sciences, the same NTR University. And she participated in many national and international conferences. She's an efficient endocrinologist going to enlighten us. Doctor, the virtual platform is yours. The stage is yours, Dr. Aishwarya.
There is some feedback. Can Prashant request everybody to mute themselves except
Yes, sir.
the speaker and the
Yes,
chat?
sir. Yes, sir.
Oh, yes, sorry, I was on mute. So thank you all the chairpersons for the warm welcome and brief introduction about the topic. And I would also like to thank Dr. GVK sir for giving me this wonderful opportunity to present on this platform, meet all the experts here. So let me start today's 3D 2020 session with vitamins and micronutrient replacement in diabetes through natural resources. I'm not able to change my slide.
I think if you can double click and then change, it should be possible, as I was understood.
Place your cursor over the PowerPoint screen and touch it.
Oh, thank you, thank you.
Yeah.
So why are micronutrients so important that we are discussing as a major topic today? Traditionally, nutritional management of diabetic patients has concentrated mainly on micronutrient intake. However, the recent evidence has shown that micronutrient intake is also important, especially when they are the essential cofactors in glucose metabolic pathways, pancreatic beta cell function, and in the insulin signaling cascade. So the changes in these micronutrient levels are found to have a negative impact on the glucose homeostasis, insulin sensitivity, and sometimes can also lead to complications such as neuropathies. So this study dates back to 1950s, done by Dr. Arshad D. et al. And they found that in patients with diabetes, there is a deficiency and reduced plasma levels of the trace elements such as zinc, chromium, calcium, magnesium, and also the vitamins, the important vitamins such as B12, vitamin D, C, and E. And why is this so? So when we see that the nutrient intake, when the nutrient intake of these micronutrients is reduced, it can lead to increase in the oxidative stress at the level of the liver, pancreas, and the muscles, resulting in insulin resistance and diabetes. And one more important pathogenesis for this is that in patients with type 2 diabetes mellitus, due to hyperglycemia, they experience polyuria and excessive sweating. So this in turn results to increased loss of fluids from our body and also the increase in the Oxidative stress results in increased metabolic demand for the micronutrients. So these two together lead to reduced plasma levels of micronutrients, which in turn have a role in the beta cell function and in turn can lead to type 2 diabetes mellitus. So let me start with the most sought after vitamin, that is the vitamin D. So more majorly, the studies have shown that vitamin D deficiency is associated with beta cell dysfunction and insulin resistance. It was also observed that vitamin D supplementation can improve the insulin secretion and reduce the insulin resistance in type 2 diabetes individuals as well as non-diabetic subjects. And a meta-analysis of large observational studies concluded that a relative consistent association was found between the low vitamin D status, calcium or dietary intake, and the prevalence of type 2 diabetes mellitus. So what are the few mechanisms for this is that vitamin D receptors are found in all the insulin responsive tissues and the pancreatic beta cells where they play a major role in the calcium homeostasis as well as the reactive oxygen species. And these VDRs are also found on many immune cells which may have a role to suppress the immune reactions and may be linked to the incidence of type 1 diabetes mellitus. Also plays a role in decreasing the inflammatory responses, and also deficiency can lead to disrupting in the proper insulin signaling. Also, the clear associations have been observed between vitamin D deficiency and GDM. So what does the guidelines recommend? The ACE and ACE guidelines recommend to check serum 25 hydroxy vitamin D levels, especially in people who are at risk for vitamin D deficiency. That is the elderly patients, malnourished, institutionalized, or those with osteopenia or osteoporosis. And added to that, the patients who are known to have insufficient sunlight exposure, skin pigmentation, or older age should also increase their vitamin D intake from the fortified foods or the supplements to at least 800 to 1000 international units daily. The ADA recommends not to take vitamin D supplementations unless they are deficient, and the RDA for people who are less than 70 years is 600 international units per day, and more than 70 years is 800 international units per day. So when we come to the natural resources of vitamin D, most of the seafoods are high sources of vitamin D: cod liver oil, mackerel, sardines, tuna, and eggs and beef liver. So when we keep this aside, the most important natural source of vitamin D is the sunlight. So when we are exposed to sunlight at a wavelength of 290 to 315 nanometers wavelength, most probably around the time of 11 a.m. to 3 p.m. in a bathing suit, so that most of the body surface area is exposed to sunlight, leads to, for about 20 minutes, causes slight pinkness. When this is observed, it is almost equivalent to approximately 20,000 international units intake of vitamin D. Then moving on to the next important vitamin, the vitamin B12. This is an essential micronutrient required for optimal hematopoietic, neurocognitive, and cardiovascular function. Also demonstrated to be highly prevalent. The deficiency of this vitamin was found to be highly prevalent among patients with type 1 and type 2 diabetes. Type 2 diabetes, the reasons could be due to inadequate intake, vegan diets, and the metformin-induced B12 deficiency. Then moving on to the type 1 diabetes, the B12 deficiency could be due to pernicious anemia, autoantibodies to the intrinsic factors type 1, type 2, and the parietal cell antibodies. The most important thing in this is that this vitamin is found mostly only in animal products. So the vegan diets are deficient of this vitamin. Then it is said that people with diabetes need more than the RDA for vitamin B12 to prevent a deficiency, especially if they are taking metformin. However, no studies show that taking B12 improves glucose control. But correcting a B12 deficiency helps in ameliorating the negative side effects of this deficiency, such as the anemia deficiency, dementia, weakness, confusion, tingling, and numbness. Again, the ACE-ACA guidelines recommend to annually check the vitamin B12 levels for anyone who is more than 60 years of age taking metformin or has any symptoms or history of deficiency. If B12 deficient, you need to treat the patient with 1000 micrograms per day of oral B12 and also encourage the patients to eat a diet rich in vitamin B12. The ADA recommends periodic testing of vitamin B12 levels in patients who are on metformin, particularly with anemia or peripheral neuropathy. So these are the sources which are high in B12. Most of the meats, ham, trout, eggs, chicken breast, salmon, and non-fat plain Greek yogurt. Moving on to the lesser known vitamins, the vitamin C, which we all know that plays an important role in the immune function, wound healing, and the blood vascular integrity. It also has the same transport mechanism as that of the glucose, and people with diabetes have found to have lower blood levels of vitamin C. And due to the lower levels of vitamin C, the chronic low-grade inflammation from the oxidative stress has been associated with insulin resistance. So let's see a few studies with dietary vitamin C intake. It was found that the vitamin C intake was significantly associated with reduced risk of type 2 diabetes mellitus. Its effect on the type 2 diabetes was mediated by inhibiting or ameliorating the oxidative stress, which was measured in terms of AOC, and insulin resistance measured in the quantitatively and qualitatively in terms of HOMA-IR. So again, the guidelines ACE, ACE, and ADA do not recommend the supplementation of vitamin C, and the ACE and ACE recommend just to meet the RDA, and it's better to get vitamin C from the diet. The RDA is 75 milligrams per day for women and 90 milligrams per day for men. And we all know that most of the fruits, the guava, blackcurrant, strawberries, oranges, and they are very high source, have very high sources of vitamin C. And apart from that, a few vegetables also are rich in vitamin C. Then vitamin E, it is a known powerful antioxidant, and diabetes causes increased oxidative stress. So this vitamin may play an important role in reducing the oxidative stress. In the recent past, increased vitamin D intake was associated with decreased cardiovascular risk. However, the recent study, the meta-analysis showed that the high dosage vitamin E supplementation may increase the all-cause mortality. This was found at the high dosage intake around more than 400 international units per day of vitamin E supplementation. Then the ADA does not advise supplementation with vitamin E, and even the ACE and ACA guidelines do not advise or recommend the supplementation of vitamin E due to the possible increased risk of prostate cancer and the all-cause mortality. The recommended RTA meets are net, that is sufficient, that is 15 milligrams per day. So these are the foods which are rich in vitamin E: the almonds, avocados, kiwi fruits, spinach, broccoli, and shrimp. And thiamine, the prevalence of thiamine deficiency has been reported in about 17 to 79% of the diabetic patients. And thiamine supplementation has also shown to improve the risk and severity of the type 2 diabetes mellitus. So the intervention studies have been consistent and showed that therapeutic supplementation of thiamine decreased the urinary albumin excretion and also helped in reversing the microalbuminuria in type 2 diabetes mellitus. The RDA is 1.1 to 1.7 milligrams per day. Then these are the foods which are rich and the natural sources rich in thiamine: the seafoods, the meats, and the nuts, peanuts, Brazil nuts, and the vegetables, Brussels sprouts, cabbage, oatmeal, oranges, and pecans. Then moving on to the trace elements, zinc. Zinc levels in pancreatic islet cells are tightly regulated. So the dysregulation can affect the synthesis, storage, and secretion of insulin, and therefore the glycemic control. The urinary zinc excretion was found to be higher in type 2 diabetes patients and may also play a role in regulation of amylin, where zinc deficiency can lead to clumping of the amylin and shutdown of the beta cell function. And this study was done mainly in rats, where the green line is depicted by the diabetic rats who were fed with dietary zinc supplementation. We can see that there is a decrease, and the blue represents the controls, and the red with the diabetic rats without dietary supplementation. We can see that there is a decrease in the mean blood glucose levels with dietary zinc supplementation. And also the histology shows that there is an increase in the islet beta cell regeneration with dietary zinc supplementation. And another meta-analysis and systemic review in diabetic patients has found that a moderately high dietary zinc intake can show about 30% reduce in the risk of type 2 diabetes mellitus, and this was also found to be up to 40% in patients who are from rural areas. And again, the guidelines ADA and ACE do not recommend regular supplementation of zinc, and the RDA is 8 milligrams in women per day, and men it's 11 milligrams per day. These are the foods which are high in zinc.
Aishwarya, another 2 to 3 minutes,
Yes.
so that we have time. Huh?
Yes,
It's an excellent presentation. Sorry for interrupting you. We just the time constraint.
I'll try to wrap it up soon. So the magnesium, another important cofactor of various enzymes in carbohydrate oxidation. Yes, again involved in insulin secretion, binding, and activity. Observational studies have found that hypomagnesemia was frequently found in type 2 diabetes, and benefits also have been found with magnesium supplementation. So magnesium deficiency can lead to decrease in tyrosine kinase activity, thereby leading to insulin resistance. And this study about meta-analysis of 22 prospective cohort studies found a significant inverse association between magnesium intake and the risk of type 2 diabetes mellitus, which was significant with a p-value of 0.004. Again, the guidelines do not recommend. The RDA is 310 milligrams for females and 420 milligrams for males. So these are the foods rich in magnesium. And chromium, although proper chromium nutrition improves blood lipid profile and insulin action, meta-analysis showed that dietary chromium has no effect on glucose or insulin concentration in subjects without diabetes, nor it was able to reduce these levels in subjects with diabetes. So the other nutrients such as omega-3 and omega-6 and dietary polyunsaturated fats have shown little or no effect in the prevention as well as in improving the glycemic status in patients with type 2 diabetes mellitus. Then the anti-diabetic effects of the herbs such as fenugreek has found some consistent and positive outcomes, and it's also found to improve the lipid profile in diabetic patients. So these are the other herbs which were sought and found to have a role in improving the glycemic status in diabetes. However, the American Diabetes Association clearly states that the evidence is little for the benefit from herbal or non-herbal supplements without their deficiencies. And also there is insufficient evidence to support routine use of cinnamon, curcumin, and aloe vera to improve glycemia. So I think we need to meet the RDAs of these micronutrients through diet. That would be sufficient, as the guidelines do not recommend the supplementations unless there are severe deficiencies. So, thank you.
Very nice presentation, Dr. Aishwarya. So elaborated about nutrients and their importance and the guidelines, what is the daily requirement and all. Our people revolving around, our people means our patients revolving around only few grains, few pulses, and few vegetables and fruits. So most of the time they are ending up with deficiencies. Excellently elucidated. Thank you so much for your presentation. I request my friend Dr. Dhanamithran to introduce the next speaker.
Thank you, Dr. Anbuselvan. Good morning, one and all. Thank you, Dr. GV sir, VK sir, the scientific committee and the organizing committee of the 3DCon, which has gone virtual this year due to the pandemic. And also the vitamins and the micronutrients have been more popular because of the pandemic, which has made us reset and readjust our lifestyle. I have now welcoming Dr. Nandita Arun, who is the director, consultant diabetologist, Dr. A. Ramachandran Diabetes Hospital, Chennai. He's also the founder director of India Diabetes Research Foundation, Chennai, Tamil Nadu. Dr. Nandita Arun is a director and consultant diabetologist of Dr. A. Ramachandran's Diabetes Hospital. She did her undergraduation in Sri Ramachandra Medical College, during which she had attained gold medal in preventive and social medicine, and post-graduation MD General Medicine at Sri Ramachandra Medical College, Chennai. She underwent training for research at the prestigious University of Cambridge, UK, training for diabetes at Christian Medical College, Vellore, and diploma on diabetes from Cardiff University, UK. She is also, to her credit, conferred fellowship by the Royal College of Physicians, Glasgow, and fellowship by International Medical Science Academy. She underwent training for healthcare management at Indian Institute of Management, Ahmedabad. Dr. Nandita Arun is a member of several diabetes and medical societies and has been an organizing member of many international conferences and has several international publications and presentations to her credit, and is a co-investigator in many drug trials. He is also on the advisory board of various committees. Dr. Nandita Arun received the Young Research Achiever Award from Dr. Cherian Verghese, WHO at JPEF 2019. Now welcome Dr. Nandita Arun, who is going to talk on the pharmaceutical preparations of vitamins and micronutrients.
Thank you, sir, for that, your kind words and your introduction. Before I start, of course, I cannot begin by without thanking GVK sir for this wonderful opportunity this Sunday morning to kickstart our day with our dose of vitamins. I'm happy to be part of this particular symposium because it's a unique topic. So thank you, sir. I'm just going to share my screen. Just take a second. I hope everybody is doing safe at this time of the year. Can you see my first slide now? Is my first slide visible?
Yes.
Thank you. So I bring greetings from ARH Chennai, and yes, so Dr. Aishwarya has actually set the stage now. She spoke about the various roles of micronutrients and vitamins and the natural sources of these vitamins and micronutrients in our diet. In the next couple of minutes, my topic and my role is to be talking about the pharmacological preparations and their relevance in our clinical practice. So with that, I would start off with this brief introduction that in the recent years, there definitely has been an upsurge. And this is not just in our part of the world, but in the global level of the use of nutritional supplements as well as nutraceuticals all over the world. So what is a micronutrient? A micronutrient is nothing but vitamins or minerals that are required for specific functions in our body as particular cofactors. For example, for any biochemical reaction, like even a basic glycolysis, we require certain micronutrients, which are either vitamins or minerals, as cofactors for the smooth functioning of these specific reactions. So overall, for a smooth functioning and biochemical functioning of the body, we need these particular vitamins and minerals, and they are termed as micronutrients. So as we heard from the previous talk, and as we all know, many of these vitamins and minerals as a whole, I've just listed them out over here. What we know, what we commonly use are chromium, magnesium, zinc, and I'm going to be elaborating on a couple of them in the next couple of slides. Due to lack of time, I'm not going to go into the details, but many of these vitamins have been implicated in improving glycemic control, improving insulin resistance, and overall reducing the risk of complications, even in the reduction in blood pressure and so on. But let's look a little further. How far is this true? So what are the clinical considerations when it comes to our daily practice and when it comes to actually prescribing a multivitamin or a vitamin supplement or whatever supplementation? These are the certain clinical considerations. First of all, measuring these levels in the blood, the measuring or the lab methods for measuring micronutrients is still unsatisfactory and not standardized, number one. Number two, micronutrient deficiency can also not be assessed clinically as easily as any other clinical condition. And last but not the least, research results with many of these micronutrients are varied and inconsistent and inconclusive simply because of various limitations. One, because dietary assessment is highly inaccurate and very, very difficult to standardize when it comes to research methodology. And also, as I mentioned, biochemical assays and are not standardized from lab to lab. So with that as a background, I'm now going to move on into select some of the micronutrients and discuss them very briefly. The first one that we have that is most commonly found in many of our combinations that we prescribe is chromium. The general function of chromium is, it is even been termed as the glucose tolerance factor. It is one of the main trace elements that is involved in carbohydrate and fat metabolism. In diabetes specifically, it has been shown to have some role to improve insulin resistance, especially in animal studies. So chromium has actually been widely studied. There are a lot of RCTs, a lot of human studies as well using this particular trace element. And overall, the results have actually shown that there is some improvement in HbA1c, especially in higher doses when it is given up to a dose of more than 200 microgram per day for a duration of 3 weeks, and some improvement in lipid function as well, especially triglycerides, and improvement in HDL. The dosage that is generally recommended is 150. This is the pharmacological recommendation, of course, 150 to 1000 microgram per day for about 3 to 24 weeks. Side effects are not much. There's not much of adverse events, but of course, the long-term safety is not known. Moving on to magnesium, this is another cofactor which is extremely important in many of our metabolic reactions, especially for calcium and potassium metabolism. And the proposed function in specifically to diabetes is that magnesium could be a cofactor mainly for glycolysis and actually have a major role with insulin resistance. Again, there is a lot of studies, a lot of data and with magnesium being used, but the dosing is not very clear because it has actually been used in various forms and various doses, but the average dose is around 300 to 400 milligrams per day. And the results are also varying, but in some studies, there has been shown that magnesium has significantly improved the fasting plasma glucose in patients with type 2 diabetes. And in some studies, some improvements in blood pressure as well. Side effects, again, there is not much evidence to show that there are adverse events, although there should be some caution when giving magnesium to patients with renal insufficiency. The next is vitamin E, which is a strong antioxidant, as we all know. And with regard to diabetes, because of its antioxidant properties, it is known to inhibit the formation of the AGEs and thus reduce the risk of complications. This is, of course, in animal studies, and also has some role to improve pancreatic beta cell function. There are a lot of studies again with vitamin E, a lot of RCTs. I'm not going to go into the details of each and every study, but a lot of meta-analysis. And as a whole, many of these results do not show a significant improvement in insulin resistance or HbA1c. Of course, the results are varied, but in general, this is the result. Although many of the studies, the authors do conclude that there is a non-significant improvement in insulin resistance with vitamin E in supplementation versus placebo. The side effects of vitamin E supplementation is uncertain. However, there are some studies which we even heard from the previous speaker that vitamin E supplementation may have some toxic effects in high dose supplementation. There is some evidence, even one of the Scandinavian studies, which has actually shown that high dose supplementation with vitamin E of more than 400 IU actually increased or all-cause mortality in the patients. So long-term high-dose vitamin E supplementation, we need to practice some caution, and the benefit is also questionable. Moving on to vitamin C, as we all know, the function is mainly for collagen and carnitine synthesis. And in diabetes, because of its role to reduce oxidative stress, it may optimize insulin secretion.
Nandita, I'm not able to hear. Is it the same with everybody?
Nandita, we lost you for a bit, Nandita.
Oh, I'm sorry. Can you hear me now?
Yeah. Maybe you can just start this slide again.
Where the vitamin C? Shall I start with vitamin?
Yeah.
Okay. So I was talking about vitamin C. Vitamin C is one of the vitamins which is extremely important for collagen synthesis. And with regard to diabetes function, because of its effect on reduction in oxidative stress, it has some role. There is a proposed role to reduce insulin resistance and improve insulin action. The dosage is usually 120 up to 500 milligrams per day for up to 4 to 16 weeks. The side effects, generally vitamin C is very well tolerated. In fact, high dose vitamin C is even prescribed by some in the field of dermatology to improve collagen synthesis and supposed to have anti-aging role. However, high doses are not recommended for those with compromised renal function and those with renal stones. Now moving on to the popular vitamin D. We heard a lot about this from the previous lecture as well. The function is mainly, of course, for bone health, and it also has been implicated in immune modulation and to improve immune function. With regard to diabetes, vitamin D has been in the spotlight for quite some time now, but although the actual mechanism is not understood, vitamin D receptors have been found in the pancreatic beta cells, in the liver, adipose tissue as well. And vitamin D status has actually been implicated to be important to reduce the risk of complications in diabetes, and may even have a role to reduce the progression from pre-diabetes to diabetes. There is also some data to show that vitamin D supplementation along with statins may have some role to reduce the effects of statin-induced myalgia. There is, of course, a lot of studies with vitamin D supplementation to look at whether they reduce the complications in diabetes, and the dosage is usually 1,000 to 2,000 IU per day, up to 60,000 or 50,000 units per week, and the duration is based upon your levels. The recommendation is to generally check levels after 3 months of supplementation, beyond which, if vitamin D status does not improve, then we should probably look for malabsorption or other causes. The side effects are toxicity is usually rare, but symptoms due to hypercalcemia like fatigue and tissue calcification are what are points of concern.
Nandita, reminder for another 3 minutes, if you don't mind.
Sure, sir. Just the last couple of minutes. So vitamin D, this is an RCT, in which with patients with diabetes and coronary artery disease, when given high doses of the recommended doses of vitamin C, they actually found that there was a significant improvement in HOMA-IR and fasting plasma glucose as well. Moving on to vitamin B12, of course, this is the most commonly prescribed vitamin in patients with diabetes. We know that metformin may reduce levels of vitamin B12. The dosage is usually oral or as an injectable parenteral for about 4 to 16 weeks. Adverse events are not really a point of concern. This is data to show a meta-analysis in which they actually shown that patients on metformin versus control, there is significant reduction in the B12 levels, and metformin may reduce the absorption of vitamin B12. And this is one of the studies in which they actually compared parenteral or IM vitamin B12 given twice a week versus nortriptyline, which is quite a powerful agent, for 3 months. And at the end of the study, they actually found that there was a significant reduction in pain, tingling, and paresthesia. So significant symptomatic improvement in patients with peripheral neuropathy or diabetic neuropathy, although there was no improvement in the fasting or the HbA1c level, blood glucose levels. But compared to nortriptyline, they actually found symptomatic improvement in diabetic neuropathy. Last but not the least, when it comes to a multivitamin formulation, there is supposed to be a role to improve glycemic status and reduce the risk of complications. There are some human studies that have also shown a reduction in HbA1c and lipid profile, and some role of multivitamins in reducing the incidence of infections in diabetes. And zinc, of course, again, last but not the least, there is evidence to show that there is increased zinc loss in urine in patients with uncontrolled diabetes, and zinc may play some role to reduce the risk of pneumonias and respiratory infections, which is why we have a lot of limelight on zinc now at this time of COVID, where it has been implicated that maybe zinc will reduce your risk of pneumonia when there is COVID infection. The only thing to be cautious with zinc is that long-term therapy may actually adversely affect lipid profiles. So now that we've had a snapshot of all the vitamins individually and the micronutrients, what do the guidelines actually recommend? Now, when it comes to the ADA, of course, Dr. Aishwarya already spoke about this. There is no clear evidence because none of these studies are concrete, and there is no actual clear-cut evidence that recommends, that actually endorses that we need to actually give supplements of vitamins or micronutrients. So the ADA actually recommends that dietary supplementation or dietary intake, or a whole diet that improves overall vitamins and micronutrients, is more important than supplementation in patients who are apparently healthy diabetic. So when do we consider supplementation? The ADA actually recommends supplementation only for those who are at increased risk of micronutrient deficiency. For example, those like the elderly, special populations, those with a very low calorie diet, or those who are on strict vegetarians or on a strict diet, or those who are on the so-called the fat diets, may require multivitamin supplementation. So in conclusion, there is not even enough evidence to actually suggest that multivitamin or individual supplementation may improve the status of our patients with diabetes. How the best recommendation would be to actually consume a diet that is balanced, that contains a sufficient quantity of your vitamins and minerals. And although supplementation may have some benefit and at the same time minimal risk of toxicity, these toxic effects or adverse effects are practically nil when it comes to having a wholesome diet. Thank you.
Thank you, Dr. Nandita, for an excellent presentation and a very precise explanations of all the vitamins and the micronutrients essential for diabetes. Now, due to paucity of time, now I invite Dr. Untitled to introduce the next speaker, Dr. Jayashree Gopal.
Thank you, Dr. Dhanmitran, sir. We heard two lectures, which one supported the natural and next one elaborated about pharmaceutical preparations. And is there anything in between to balance these three? I invite Dr. Jayashree Gopal, who is the director of Diapendo India, Chennai, Institute for Diabetes, Endocrine, Metabolic and Lifestyle, and Sitapati Clinic and Hospital. She's a senior consultant endocrinologist and diabetologist. She's a diplomat of American Board in Internal Medicine, Endocrinology and Diabetes. She's associate dean for teaching and research in MV Diabetic Research Center, Ayapuram, and recipient of Occasional Excellence Award from Rotary Club, and awarded the Sam G.P. Moses Oration Award in API Chennai chapter annual conferences. She's a very famous orator in medical thing. I invite Dr. Jayashree Gopal for giving a speech on balanced view. Thank you.
Thank you. Thank you. And while I'm trying to share my screen, thank Dr. Vijay Kumar for inviting me here and also giving an opportunity to meet up with my very good friends. So I'm hoping that what I share is not going to be repetition, and it isn't actually. So I was happy to see the previous two talks. Dr. Vijay Kumar said he wanted a balanced view. And I just wanted to share literally about 5 minutes of what I came up with when I did my reading again about this topic. Very briefly also, I just wanted to touch upon when we think about nutrients. Sorry, can you see my slides? I just missed that. Okay, fine. So there's been a lot of talk about the vitamins, which we are more familiar with, and some of these trace minerals. And of course, apart from these, there are other supplements like alpha lipoic acid, omega-3. And I think about a week ago, there was a study published saying omega-3 fatty acids do not reduce the risk of cardiovascular disease. And then there are studies which have looked at things like garlic and fenugreek and tulsi, so if you look at the literature, it's like filled with multiple, but we need to keep in mind that there is minerals and vitamins, and then there are supplements. So there is definitely more than meets the eye. And let me talk a little bit about these things. The relationship between the nutrient intake, the blood levels of those particular, whatever it is, the zinc or the copper or the chromium, and the risk of developing diabetes and its complications is very complex. And this is sort of a snapshot of, I think, the first lecture talking about various, apart from, I think chromium was mentioned, but also iodine, for example, iodine deficiency has been shown to alter blood sugar control. And high levels of iodine also have been shown to impair insulin secretion. Selenium treatment, for example, has been shown to reduce oxidative stress in people who are deficient. So it's sort of all over the place. I think the evidence is most clear probably for magnesium and for chromium. The others, I would say it is a little bit murky, and maybe for zinc. Blood levels may not reflect functional activity. Nandita alluded to this, particularly with respect to vitamin B12. And I think it's important that we keep it in mind that a lot of us are in the habit of measuring B12 levels. And sometimes even, in fact, this morning also I was talking with a physician who'd stopped her vitamin B12 because the levels were very high. But I was pointing out to her that vitamin B12 levels may also be high because of inflammation. Her CRP was very high. She is having some sort of a shoulder problem and pain. So vitamin B12 levels per se may not be an indication of vitamin B12 status in our body. If you want to actually diagnose vitamin B12 deficiency, we need to go back to our basics, methylmalonic acid or homocysteine. If these are elevated, it confirms functional B12 deficiency. So sometimes measurement of the actual vitamins or the minerals may not be indicative of the fact that they are functionally deficient or functionally even in excess in the body. Another very interesting aspect, and part of the reason why we see such varying reports and all the studies that have been done, is that our genotype may predicate that we require different intake. For example, an interesting study showed that a genetic variation in the magnesium-related ion channel may actually affect diabetes risk. And what this study showed was that if you had a particular variation of this magnesium ion channel, you needed to have more magnesium in your body. This is something that is evolving, similar to pharmacogenomics. This is sort of, the risk of maybe someday in the future, we'll have more of this precision personalized medicine, and we can say that this person has to take a lot of magnesium. But this is also something that comes into play. So if you do not have this particular variation of the magnesium channel, you're not going to suffer so much from magnesium deficiency. Whereas if you do have it, you might have to take higher doses to reduce your risk of developing diabetes. And finally, part of the reason why studies have not shown consistent benefits is that the preparations that they've used, again, Nandita mentioned this, the preparations that have been used vary widely. They either use, and anytime you take out a particular ingredient from a preparation, only pure vitamin B12 or pure, say, omega-3 fatty acid, instead of taking the parent compound of which it is a part, obviously you're going to lose some of the benefits. And not only that, not only are we using a more purified, a more sort of a chemical preparation, but different studies have used different preparations. So you can't really compare. For example, I came across this, there's a lot of studies looking at ginseng and its use in diabetes. And you can see that they've used it either as a tablet or as a ground root. They've used 3 grams or 6 grams or 9 grams capsules. So a lot of variation, and you can't really compare the various studies because absolutely no standardization. And once one relatively big study has been completed, no other study tries to replicate it or tries to do it again. A final word about elevated homocysteine and cardiovascular disease. This was in the news, I think, about 10, 15 years ago. Very clearly, studies show, and they still continue to show, that a person who has elevated homocysteine levels is at a higher risk of cardiovascular disease. This is similar to saying if you have a high CRP or a high LDL, you're at higher risk of cardiovascular disease. So the reverse was thought to be true, that if you reduced homocysteine levels by giving vitamin B12, you reduce the homocysteine levels, that you're going to reduce your risk of cardiovascular disease. The reason being that B12 is necessary for conversion of homocysteine to methionine. When you do not have vitamin B12, you're going to have elevated levels of homocysteine. So it was thought that if you gave vitamin B12, however, several studies and this meta-analysis showed very clearly that vitamin B12 supplementation does not reduce the risk of cardiovascular outcomes, whether in diabetes or outside, not helpful in primary or secondary prevention. And this interesting, when you sort of dig in a little bit deeper, you can see that some other things start coming up. For example, what was the baseline homocysteine level? If the homocysteine level was very less, actually B12 supplementation did not help at all. When the homocysteine level was high, it did not help. When it was very low meaning functional B12 deficiency, it did seem to help. Similarly, with the baseline folate level, when the baseline folate level was less, it seemed to have more of a benefit. Some other things, for example, if you looked at the benefit of the vitamin B12 in reducing the homocysteine levels, again, if there was a significant reduction in homocysteine, saying that definitely there was a B12 deficiency to begin with, there seemed to be more of a benefit in reducing the risk of cardiovascular disease. I just put up these 2 slides to show that definitely there is more than meets the eye when you look at all of these studies. We cannot blanket say either B12 is not good or B12 is not beneficial. I think there is more to it than that. Now, another interesting thing I was just thinking about, when do we suspect micronutrient deficiency? When we were medical students, we had this common thing of looking at the conjunctiva for people, and if it was pale, we said you were deficient. I think we still continue to do that. But a few things I wanted to point out. One is, for example, pale conjunctiva I mentioned. Niacin deficiency, hyperpigmentation. It's very common for particularly Indian women to develop this pigmentation in the face, neck, particularly in the perimenopausal time. We usually put it down to hormonal changes, maybe related to vitamin deficiency. Of course, we are all aware of angular stomatitis and cheilitis. Dysgeusia, altered sense of taste may be seen in zinc deficiency. Of course, we are all aware of the nail lines. Slow wound healing may be indicative of zinc and vitamin C deficiency. So the reason I put this up is, again, our clinical acumen comes into the fore. When we have a good physical examination of the patient and we pick up things that cannot be explained just by diabetes or its treatment, start thinking about micronutrient deficiency. None of the studies have shown that replacing isolated studies have shown that if you truly have a deficiency and you replace it, some markers of diabetes or insulin resistance and blood sugars improve, but supplementation studies have not uniformly shown any benefit. And ADA, as has been pointed out, do not recommend routine supplementation. What do I think? Definitely, I think most of us would agree that a well-balanced diet without any fats. For example, what do I mean by fat? A vegan diet. You're not having any milk. Where are you going to get your calcium from? So a well-balanced diet which has no fats should provide most nutrients. If, let's say, someone is lactose intolerant or whatever, and they are doing one of these like a diet where they're excluding one major food group, then consider replacing that particular nutrient that they may not be getting. There are currently no recommendations in checking micronutrient levels. You can consider checking up D and B12. If you're looking for B12 deficiency and you strongly suspect it, remember also to check methylmalonic acid and homocysteine levels. I personally think a general multivitamin supplement daily will not hurt, may help, provided we are avoiding mega doses of vitamin A, vitamin D, vitamin E, and zinc, because as was pointed out, these are the ones that tend to cause toxicity. So as long as we're not using high doses of these and using a general multivitamin supplement daily, I think our body will compensate for deficiencies and absorb as much as it needs. And this is my view. I think giving a general multivitamin tablet may not hurt and it may help. I think that is my last slide. I'll finish up so that we have some time for questions. And thanks again to Dr. Vijay Kumar. Thank you.
Thank you so much, Jayashree ma'am. Very excellently spoken about thing, and we have new insight about vitamin B12 level. And I'm handing over the mic to my mentor, Professor Venkatraman sir.
Thanks, Aishwarya, Nandita, and Jayashree. Beautiful, marvelous presentation, and Anbu and Dhanmitriyan for conducting the proceedings. Yes, I think I'll just sum up. Maybe have a couple of questions and comments. Vijay will just take about 5 minutes to finish this session because it's an important session. Actually, why we had this session is, number one, as has been the uniform opinion, whoever spoke about the micronutrients, there is a consensus that diabetics are deficient in micronutrients. The restriction of macronutrients makes the burden more. In other words, there is an inadvertent intervention with respect to micronutrient restriction. Number three, very, very important, which I thought I'll share with you before I have a comment from Vijay and others is, now you take apple or tomato, they have some thiamine or whatever minerals they have. Compared to what was happening in 1980, the nutritive output from these so-called these natural sources of vitamins and minerals have come down by 80%. It's only about 20 to 30%. That's because they've done a soil in India. It's a beautiful study. I wish we had shared the slide with you. It's a beautiful study. 1 lakh soils across the country have been studied. 1 lakh, mind you. And they found out that the fertility of the soil, for various reasons, I think Vijay gave some inputs because of his agricultural knowledge. He said probably non-rotation of the crops, and for the various reasons, monetary gains, when you have the same crop again and again, it usurps the nutritional content of the soil, so that ultimately you have this same tomato, you have the same apple, but the thiamine is only 20% or 30% or what used to be. In other words, the national recommendation is somebody is going to have about 4 to 5 cups of vegetables and fruits per day serving, and you'll be surprised to know that there was a study wherein in South India it was almost 4.5 cups of this intake. But in spite of that, I think it's very easy to anticipate what an amount of deficiency is there. So, number one, as Mohan also pointed out, it is not virtually possible to determine the micronutrition status in everybody. It is neither cost effective nor feasible nor warranted. So I think there is a evidence, even though the guidelines are not there, the guidelines insist on the natural way of availing these micronutrients and minerals, given whatever is happening in the agricultural front, and given a population like, for example, I am a vegetarian, not a vegan, but a vegetarian. But given a population like ours, wherein a good number of vegetarians, their access to the good amount of vitamins are not there, and there is a cost for a proprietary preparation or a pharmaceutical preparation. Of course, the caveat being, as Jayashree beautifully pointed out, when it comes to water-soluble vitamin, don't worry about it. There is no risk of accumulation. Fat-soluble vitamins, we always say ADEK, A-D-E-K. So all these things tend to accumulate. So these are my thoughts. Why we purposely wanted it to be included is, whenever we have a prescription and see a vitamin at the end of the prescription, some of us tend to think, is it a patronization of a pharma? Might have been, but probably we need to rethink ourselves and probably include a vitamin preparation, supplementing, understanding the fact that most of the diabetics are deficient. Now I think a comment from Vijay, and Sriram wanted to have a comment. Dr. Vijay Kumar, yes, please go ahead. And Madhu, and that we'll wind up.
Can I?
You're not audible.
Can I, Dr. Venkatraman?
Yes, sure, please go ahead.
Yeah, I'm very happy that Dr. Jayashree Gopal brought in the genetic variation because I am subject to correction. As far as I know, there is no population-based studies, for instance, for vitamin D in India. We always go by what the literature says. Less than 30, we say is deficient. And of course, vitamin D is now being recommended for everything. Type 1, type 2, prevention of complication, pregnancy-related hypoglycemia in pregnancy. For everything, they recommend vitamin D. Are we justified? And even about the dosage, there is a lot of controversies. Orthopedic surgeon says 60,000 twice a month, even weekly, whereas endocrinologists and diabetologists are strongly for lesser doses. And we never talk about the hypervitaminosis D and renal injury. I think this should be emphasized about vitamin D. And as you said, I understand that according to skin color, the human population is divided into 3 categories. The Caucasians who are white, we are browns, Orientals and the Asians, and the Africans they are called black. So it all depends on the skin pigmentation, about absorption, natural production of vitamin D from natural sources.
Sir, we are 15 minutes behind schedule.
Yeah.
So Dr. Shira Mahadevan, a short comment, and then Dr. Mohan, and then we'll close, sir, if you don't mind.
One small comment, maybe I think the discussion will go on and on. One point is, I was speaking to quite a few pharmacognosy specialists as well as Ayurvedic physicians. We sometimes, as allopathic doctors, do not give importance to, we are more worried about the active ingredient of a particular substance. Like, for example, even in this whole discussion, micronutrients are sometimes studied isolatedly. The same calcium, when given as natural source, is different from the same calcium taken as a tablet. Even though for study purposes, we do it as tablet, 400 milligram, 500 milligram absorption, etc. There are studies to show that if you take tablet calcium, with or without vitamin D, whatever, BMJ report is there 10 years back that coronary calcification is more. But if you take the same from natural sources, it is less. So sometimes we talk about precision medicine. There is one more aspect called functional medicine. The same thing given in a different form or along with something else will have a different meaning. These kind of things are unfortunately not in the curriculum of our typical MBBS or even postgraduate training. And I think a good collaboration in some of these kind of talks ideally may have an expert from the other view also, and maybe we should have some other session that day. I think I will stop here, but I was just I wanted to tell this, that these vitamins will behave, especially with respect to the metals, all the minerals, they will behave differently if given in a different form. It's very much accepted. And secondly, the nano nature of these agents, the absorption will be different. What we, as Jayashree madam already pointed out, the same B12, one more point is, most often it is given as an injection in India, so that's why the values may be very high. Secondly, antibodies to B12 will also interfere in the assay. We had a lot of problems recently with certain type 1s and others. Anti-vitamin, anti-intrinsic factor, anti-B12, that will also intervene as to give you a very high value. So there's so many issues in this. I'll stop here, but just to tell you that there is one more component to it. How you eat also matters, rather than what you eat. And what
we should have added for 1.5 hours. I think the time think you respected it. Thank you so much. Thank you all. Excellent discussion.
Thank you, everybody, for giving a wonderful discussion on the first session. We just delayed by 15 minutes already, but we should be able to cover it to great extent in this next session. It is on relevant issues. In the relevant issues, we have several things, and it's a short presentations by everybody, 15 minutes presentations. Bone health, periodontitis, hearing loss, loss of taste, and also about gastroparesis and sexual problems in diabetes. These are the few things we are going to discuss. And I think after 3 talks, I think we'll have one discussion and then go for the next discussion at 3 hours. And then try to finish on time so that we can cover at least 10-15 minutes. You need to do that. To take this meeting forward, we have Professor Madhavan, senior diabetologist from Chennai, who was former director of Institute of Diabetology.
I've already been introduced.
Rajiv Gandhi Medical College.
I've already been introduced yesterday. No problem.
Okay. Rajiv Gandhi Rajiv Gandhi Government General Hospital and Institute of Diabetology in Madras Medical College. And Dr. Mohan, a senior diabetologist in Chennai. He heads a hospital as well. And Dr. Sella Pandian also is a senior diabetologist. Both of them have been introduced yesterday. Please, chairpersons, please take over.
Thank you, Dr. Vijay Kumar. Good morning, everybody. We have a very interesting session next. Normally, we talk about micro and macrovascular complications. We rarely talk about certain topics like this. I congratulate Dr. Vijay Kumar for selecting such topics about one on bone health and diabetes and periodontitis. We rarely talk about it. We know Dr. Venkatraman will remember. We used to have a lot of research work in collaboration with Dental College when we were in MMC. And hearing loss and diabetes, and of course, the gastroparesis again is a subject well known but not discussed very often in many of the CMEs. And sex and diabetes again been some discussion, but I'm very happy that Dr. Vijay Kumar has given a very good collection of topics which are beyond micro and macrovascular complication directly. So we have very eminent speakers on these topics, and now I request my co-chairperson, Dr. Mohan, to take over. Before I hand over, I would like to apologize because I have a commitment. I have to leave at around 11:15, 11:20. I've already got permission from Dr. Vijay Kumar. Over to Dr. Mohan.
Thank you, sir. I have the pleasure of introducing Dr. Sriram Mahadevan, who's a HOD and professor in SRMC. And he's got more than 90 scientific articles in peer-reviewed Index Journal and a honorary national professor by IMA, College of General Practitioners in 2015. Currently the Vice President and previously the Finance Secretary of Endocrine Society of Tamil Nadu and Puducherry. He'd be delivering his talk on bone health and diabetes. Sir, over to you.
Thank you, sir. My profuse thanks to Dr. Vijay Kumar, sir, and everybody else in the organizing team, Dr. Mohan, Dr. Sella Pandian. So many of your colleagues are there. And without much ado, I'll go directly to the talk. And by the time I share, just prelude again, congratulating the whole team for including certain other aspects of diabetes, which are sometimes overlooked in a busy practice. And one such thing is bone health. And my job over the next 15 minutes is to give you an overview of an approach to bone health in diabetes patient, how each of them interact with each other. And a disclaimer that for this talk, there is no conflict of interest. So in general, in adult practice, whenever we discuss bone health, the immediate thing which comes to our mind is osteoporosis. And we will go through basics of this and giving you some introduction on how we approach the deterioration of bone density or the risk for fracture in diabetic patients, how is it different, etc. So definition, I will not spoil your Sunday morning by reading out this. There are two components. One is bone mass. The other one is microarchitectural deterioration, which is a very complex term. That's why the WHO and the NIH consensus came up with a reasonably simpler term called bone strength, which includes bone density and quality. For all practical purpose, I will clarify here itself that bone density, we have some ways of measuring it by radiological investigations, including X-ray, which is the last one, maybe an ultrasound, which is not used, and most importantly, and gold standard, is the DEXA scan. I'll come to it again. However, currently, we don't have any reliable bedside or any clinical method of assessing quality. Why this distinction is important is, as I go through in the next 2 minutes, you'll understand that a patient fractures even when the bone density is not very low. And one more physiological concept we should remember is the peak bone mass accrual in a normal person will peak somewhere around 30. And after that, it is slow reduction or decline in the bone density. And in females, there is a rapid decline after the sex hormones ceases to be secreted by the ovaries, what we call menopause. Their risk equals, after menopause, the risk is more. This we all know. But one concept we need to understand is, somebody whose peak bone mass itself is very low due to various reasons in the first 3 decades of life, they are bound to have osteoporosis more than others. This is easy. When you have more bank balance to start with, if they are steady decline, you will have more bank balance after 10 years. Imagine a typical normal young lady, diabetes or without diabetes, you can understand 2 to 3 children, at least 2 children in the early 20s or early 30s, her peak bone mass, lactation, pregnancy, etc. will be already low. This is one of the important reasons why, as Dr. Madhavan sir pointed out in the previous session also, vitamin D supplementation, which is repeatedly shown to be low in our setting, we are probably stressing more from the bone health point of view. Non-skeletal effects of vitamin D we are not discussing here. So type 1 diabetic, for example, if they have very low peak bone mass, they are bound to have very low bone mass at a later age, and their risk of osteoporosis is very high, and it has been well proven. So this concept needs to be remembered. An ultimate aim of bone health management, not only in diabetics, but also in every patient, is to reduce the risk of fracture. It is not just improving a radiological parameter like a DEXA scan based assessment of bone density. That's not the only aim. Ultimately, like in diabetes also, it is not just controlling sugar. We need to prevent heart attack. We need to prevent kidney complication. That's the ultimate aim. Same way, the hard outcome in bone health is reducing fracture. So in this context, we all know that DEXA scan is the gold standard. Arbitrarily based on certain parameters, we are following this rule of standard deviation, which itself is not a clinical parameter, but it is a statistically derived score from the DEXA scan based on Caucasians predominantly. There's too much of complexity here. For simplistic purpose, we all know that lower the bone density standard deviation, especially 2.5 in the negative side, more risk of fracture. This we have been following for more than 2.5 decades now. And there are a lot of issues with this, when especially in elderly and up to in diabetics with atherosclerosis, osteophytes, aortic calcification. All these can interfere with the spinal density especially. That's why we have to rely more on the hip, femoral neck rather than the spine. So I have already alluded to this point that though DEXA scan is unfortunately the easiest way to do, even though it is slightly costly, not easily available in every place, but that's the gold standard. But that alone is not enough. As shown by this data, long time back, this is often quoted in every talk on bone health. You see, most of the patients who fracture do not have DEXA definition of osteoporosis. They fracture in what we call in the osteopenic range, which means there are factors contributing to fracture beyond bone density. That is the quality of the bone. As you can see here, ultimately, we are not interested in density alone. The quality, which includes the bone geometry, bone size, and certain tissue properties, most of which cannot be measured in the clinical side. I am stressing all these just to give a prelude of why we are going for certain scoring in osteoporosis. In addition to all this, one needs to remember that a patient will fracture only if he or she falls. So fall prevention, for example, in a diabetic, addressing the neuropathy, addressing the radiculopathy, stroke, as well as cataract, retinopathy, etc., carries much more meaning in overall prevention of fracture in a diabetic patient than actually talking about all the complex bone density and other things. So fall prevention, improving the balance, improving muscle strength, etc., will also be the important points to be mentioned in whenever we discuss fracture prevention in a diabetic. And with all this in background, I'm sure the people who are listening to this talk will understand that we should not go only by the T-score which we derive from the DEXA scan. We should assess fracture beyond T-score. With this in background, Professor Canis and others from the Sheffield University proposed this beautiful scoring system, just like how we have, in CAD assessment, we have non-modifiable, modifiable risk factor, diabetes, hypertension, dyslipidemia. Same way, fracture risk can be assessed by these 7 or 8 important questions. The last one, you have to use your clinical judgment, which is secondary osteoporosis, multiple causes. So there is an Indian version also. This is freely available on the net. You put your patients into this Frax Sheffield, we go into it, you will go to the school calculation tool. There is Asia, there is India in that. Lot of data from different parts of India have been pulled in, though it's not a very robust thing, but still we have this, at least the audience should know that Indian score can be obtained through this. You fill these forms very easily done, all these parameters, age, sex, height, weight, smoking, glucocorticoids. For today's talk, there is one important caveat here. There is no diabetes here. I will come to in the next 2 minutes to explain how we can address it. So with this and without bone density or with bone density, you will get a score like this. What is the probability that this patient over the next 10 years will fracture either the hip or any other major osteoporotic fracture? Can be easily obtained within 2 minutes on your clinic. Today, app is also available on the mobile phone. So with this, if the 10-year probability of hip fracture is more than 3%, or the other major osteoporotic fracture risk is more than 20%, we are going for treatment. This is a background. We are introducing clinical risk scoring for fracture along with bone density rather than relying only on the bone density to treat. That will be the major message through this talk. So what have we done out of this? The previous concept was somebody who had a density less than minus 2.5, you treat. That means you will treat even a 50-year-old, you will treat also 80-year-old. That is absolutely wrong, no? 80-year-old will have more risk of fracture than a 50-year-old. So we have changed the approach now from a vertical to a horizontal line drawn here, where you'll see that if the frac score probability is more, then only you will treat a 50-year-old. Otherwise, everybody with low T-score will not be treated. And as clinicians, and that too as general physicians and diabetologists, we should know multiple other factors can play a role. I will not go through all this. Rheumatoid arthritis and other systemic inflammatory conditions are very, very important in this. It is not the steroids in the rheumatoid arthritis patient. It is the rheumatoid arthritis itself which worsens the bone density. So there is a big discussion going on in our bone health area. Should we include diabetes in this? And some interesting data are coming up with this. In addition to this, as you know, as endocrinologists and physicians, we all deal with thyroid patients and steroid patients. They are all standard risk factors, very high risk. Proton pump inhibitors, glitazones, even some of the SGLT2 inhibitors. All these have to be remembered when you are discussing bone health in a diabetic patient. And as has been already alluded, I have mentioned a couple of times, vitamin D deficiency is unfortunately, in spite of being in a tropical country, not uncommon. Even though the cutoffs and other things can be controversial, still we have to agree that calcium intake is also low and vitamin D is definitely on the lower side. So as was already discussed, supplementation will sometimes be helpful in our patient. So the clinical approach to osteoporosis, until now I have spoken for both diabetes and non-diabetes together, and just 2 minutes to take how we can fit in diabetes as an extra risk. So we need to have DEXA score if possible. Please use your clinical assessment of fracture risk by the Sheffield Frac scoring system. Check biochemical parameters, especially vitamin D. This is what we routinely do. And select your appropriate therapy based on the overall risk of fracturing of the patient, not based on a low T-score alone. Just coming for 2 minutes and fitting in diabetes here, you can understand that diabetes affects bone health more than what we expected. Interesting point is the bone density in a diabetic patient is more than what we see in the same age and sex matched patient. That means diabetes will be, the bone density will be fallacious by DEXA scan because of obesity or because of multiple other reasons. But internally, the architecture is affected. So, but the fracture risk is high in a diabetic patient. So bone density on one side is high. But
sir, 3 more minutes to go, sir.
1 minute more. That's so there are in type 1 diabetics, and hypoglycemia is a very major risk. I have already alluded to. So with respect to diabetes and fracture, type 1, no doubt, we have to control them. We have to address their bone health, especially as they get old. Type 2, please use FRAC score, but with some modifications. I'll skip these 2 slides to come to the last point to tell you that even drugs, different drugs used in diabetes, especially glutazones, please avoid in your postmenopausal ladies. SGLT2 inhibitors, please use with caution, even though the data is not confirming that they are causing, but we need to use our clinical judgment. So clinically, there is a new score introduced called the trabecular bone score, which is part of the Dexascone one more software, which gives us an idea of the microarchitecture. This may be used in addition to bone density, or one more interesting point I have to mention here is use, even though rheumatoid arthritis may not be there, diabetes may be an RA equivalent. Already we discussed diabetes as a cardiac coronary artery disease equivalent. Maybe we have to add RA or reduce the T-score. So these are all some propositions given. Even though fracture data is not there, 2 major points we need to understand in diabetics is they are fracturing at a higher BMD and their quality of bone is affected. So please have a lower threshold for addressing the bone density. So the last slide to give us these 3-4 important messages. Routine bone density test alone will not help in our diabetic patients. If available and affording, use trabecular bone score also, or use the FRAC score with rheumatoid arthritis as your extra risk. If that risk is more, please consider treatment or referring to appropriate specialists. And vitamin D calcium supplementation is definitely required to address the diabetic patients, and fall prevention, as I have already mentioned, also plays a very important role if we have to consider reduce the overall fracture risk in our diabetic patient. But as of today, from the anti-osteoporotic treatment point of view, diabetics and non-diabetics are treated in the same way. I stop here, and I'm sorry if I have exceeded the time. Thank you for the opportunity again.
Now we'll move on to the next topic. It is periodontitis and cause and effect. I think this I would have heard some 25 years back or something only. I heard something related to diabetes and dental health. But now I am very happy that GVK has selected this topic. And now I would like to call on the speaker, Dr. V. Ramkumar, one of my friend, and he's a consultant diabetologist in Guntur, past president of APDF, and Marjane Miles Scholar in 1998, and he's a district coordinator for IRSSDA, fellow diabetes in India, and certified trainer for diabetes educators, happiness and health coach, IATD, laughter yogi, and he is practicing for the last 25 years. Take on Dr. Ramkumar. Unmute. Ramkumar.
You have to unmute Ramkumar.
Unmute Ramkumar.
Yeah. Can I share my screen?
Yeah.
Can you allow me to share my screen, please?
Yes.
Okay. Okay, good morning, everyone. And I thank Dr. Vijay Kumar for giving me this opportunity. Am I audible? Okay, thank you. And it's very glad to be with my teachers, Dr. Madhavan and Dr. Venkatraman. And Chennai, I got trained in diabetology, I can't forget. And I thank Dr. Vijay Kumar for giving me this opportunity to be with you all. I miss Hotel Savera and all our friends. We used to have fun in the previous years. Today, I'm going to talk about periodontitis, cause and effect. If you see the various oral manifestations of diabetes, periodontitis has a major role. And if you want to see what are the other problems, oral candidiasis, tooth loss, oral mucosal ulcers, taste impairment, halitosis, xerostomia, salivary gland hypofunction, dental caries, burning mouth sensation, all these are also representative of oral manifestations of diabetes. But today we are going to discuss about periodontal diseases or periodontitis. Because what is periodontitis? Periodontitis is inflammation of the tissue around the teeth often causing the shrinkage of the gums and loosening of the teeth. It is permanent breakdown of supporting hard and soft tissues around the teeth. So you will be telling, patients will be telling, my tooth became loose or my teeth became loose because of the periodontitis. If you see this picture, if you compare between the normal and periodontitis, normal teeth will have healthy gums and they will be having healthy bone. In periodontitis, the gums will be receded and then the alveoli or where these teeth will be located will become loose. All these are caused by periodontitis. So what are the types of periodontal diseases? Are gingivitis and periodontitis, desquamative gingivitis, periodontal abscess, and finally all these things lead to tooth loss. We will be coming across diabetics who are very young, 40 years and without tooth. These people may be because of these periodontal diseases. See, if you see the gingivitis is a reversible infection of gingival tissues that surround the tooth. And gingivitis is a very common problem and many people don't bother about it unless there is some bleeding or some halitosis, other problems. Otherwise, they won't bother. The most neglected thing in diabetology is mouth, oral cavity. And the next one is desquamative gingivitis. Desquamative gingivitis is an erythematous and ulcerated appearance of the gums. It is a descriptive term and can be caused by several different disorders, including diabetes. So there will be the shedding of the gum tissue will be there in desquamative gingivitis. Periodontal abscess is, periodontal abscess or parietal abscess is a localized collection of pus. That is, a collection of pus is called as abscess within the tissues of the periodontium. It is a type of dental abscess. Finally, uncontrolled diabetes and untreated periodontitis lead to tooth loss. Periodontitis and poorly controlled diabetes negatively influence each other in a two-way causal relationship. So our aim is to control diabetes effectively and to prevent periodontitis and finally to prevent the loss of tooth. So what is the importance of periodontitis and diabetes? 20 years ago, periodontitis was suggested as the 6th complication of diabetes, and it is a non-specific infectious complication of poorly or uncontrolled diabetes. People with diabetes has lost more teeth than those without diabetes. I was fortunate to work with Professor Sundaram, and he used to tell, whenever you come across a patient with poorly controlled diabetes and without any obvious cause, ask him to open his mouth. So this is an important thing, and periodontitis plays an important role in controlling diabetes. So if you want to know what are the symptoms, there will be no symptoms in early and intermediate states, not until considerable breakdown of bone manifests itself as migration and mobility of tooth, means tooth will become loose. Until then, we won't be recognizing in some cases. Reddening and spontaneous bleeding of gingival tissue along with tooth mobility often recorded. So there will be bleeding and tooth mobility will be there. So let us see how diabetes affects periodontitis. So diabetes causes, as you know, hyperglycemia. Hyperglycemia will lead to so many factors like oxidative stress, advanced glycation end products, and receptor activator of nuclear factor kappa B, other things. And all these things lead to immune dysfunction, cellular stress, cytokine imbalance, and ecological shift in the subgingival biofilm. What is this subgingival biofilm is? Where these bacteria are there. Due to hyperglycemia, there will be change in bacterial growth, which cause harm. Harmful bacteria will be grown. That will also lead to immune dysfunction, other things, and periodontitis. So all these factors, adiposity and dyslipidemia, adipokines, all these things lead to enhanced tissue destruction. And as you know, there will be impaired repair of tissues in diabetes or uncontrolled diabetes. All these things are contributing to periodontitis. So this is the relationship between diabetes and periodontitis. The interesting thing is diabetes causes periodontitis, and periodontitis itself also causes hyperglycemia. So what is the effect of diabetes on periodontium? Then poor periodontal outcomes result from hyperglycemia in diabetes due to changes in microorganism. I already explained post-response, wound healing, and blood vessel, vascularity, other problems. All these things affect the periodontal tissue, and there will be periodontitis. And if you see the change in oral microorganisms, there will be reduction of saliva and high glucose concentration in saliva and development of periodontogenic flora. All these will cause, thus the susceptibility of diabetics to periodontal disease is increased. So these are the factors why diabetics or uncontrolled diabetics have more periodontitis. And let us see what is the effect of periodontitis on diabetes. So if periodontitis is a chronic inflammation, and diabetes itself is also a chronic inflammation. Some people say that diabetes is an inflammatory disease. So all these things lead to pro-inflammatory state, chronic overexpression of cytokines, and these can lead to pancreatic beta cell damage, leading to hyperglycemia and decreased diabetes control. And other factors, if you see, pro-inflammatory state affects interleukin 6, TNF-alpha. All these things lead to insulin resistance, and insulin resistance in turn lead to hyperglycemia and poor diabetes control. So these two things, periodontitis is caused by diabetes, and diabetes will be aggravated or will be out of control because of periodontitis. So we have to take care of both the things simultaneously. And another interesting thing is they found out that diabetes complications reported to be related to periodontal disease these are the complications are aggravated by periodontitis, like cardiovascular disease, coronary artery disease, ischemic heart disease, carotid intima media thickening, calcification of atherosclerotic peak, hypertension, cerebrovascular events, kidney disease, macroalbuminuria, proteinuria, end-stage renal disease, death due to cardiorenal disease, neuropathic foot ulcer, and retinopathy. So many things are there involved with periodontitis. Okay, let us see how periodontitis may influence diabetes. So as you know, any infection in the body will increase blood sugar. Acute bacterial and viral infections, they lead to chronic gram-negative periodontal infections, have significantly higher serum markers of inflammation like CRP, and than subjects with periodontitis. Periodontal treatment, and if you can treat the periodontal disease, may reduce the inflammation locally and also decrease the serum levels of inflammatory mediators that cause insulin resistance, thereby positively affecting glycemic control. So this is the reason behind controlling periodontitis and achieving better blood glucose control. So this is a consensus report. Overall, there is a consistent and robust evidence that severe periodontitis adversely affects blood glucose levels expressed as HbA1c in individuals with and without diabetes. Moderate to severe periodontitis is associated with increased risk for the development of diabetes. So periodontitis is a risk factor for developing diabetes, and evidence supports a dose-dependent role of periodontitis and diabetes complications. So periodontitis is causative for diabetes, and at the same time it will deteriorate the glycemic control.
3 more minutes, Ramkumar.
Yeah, finish. Treatment. What are the non-surgical treatment? What we will do is, if you get a patient with periodontitis, the aim of this is to remove microbial plaque that harbors. You heard of this term called scaling. So where they do the scaling, the pathogens of gingival inflammation, which is done by supragingival and subgingival scaling, and root planning. They plan the root, or they clean the root of the tooth, including tetracycline therapy. They use tetracycline. And periodontal treatment improves glycated hemoglobin level by about 0.4%, similar to adding second oral drug to metformin. So if you clean a oral cavity properly, it's equivalent to adding a second oral agent. This is how they do scaling and root planting. And surgical treatment, if it is beyond that non-surgical, they will go for gingivectomy, gingivoplasty, flap surgery, reconstructive periodontal surgery. And all the guidelines say that we should advise the patients to take proper oral care. So this is every year they should go to the dentist and they should take care of the oral cavity. It is much neglected. All the guidelines say that. And the best thing is to have a collaboration between a dentist and a diabetologist. Like I married a dentist. Then summary, periodontitis increases glycemic level and contributes to hyperglycemia, pre-diabetes, type 2 diabetes, diabetes complications, and possibly GDM. To manage diabetes, it would be beneficial to patients and to the society to collaborate between diabetologists and dentists. Oral health should be included in our routine diabetes care. So help diabetics to keep smiling and help your diabetics to keep smiling with good glycemic control. And 1 minute. We are laughing for oral care.
But Ram Kumar.
Yeah, finished.
Already married. Again, we can't marry a dentist.
Yes, sir. You can try always. So thank you. Keep smiling. Join Dr. Smiles Club Guntur. Thank you very much.
Thank you. Morgan.
I have the pleasure of introducing my close friend, Major Dr. Gauri Shankar. He'll be talking about hearing loss and diabetes. He is a physician in IIT Madras. He's an undergraduate from Stanley Medical College and postgraduate from MMC and served in the army. He's a member of various societies. He's very, very passionate about studying and speaking. Over to you, Dr.
Sir, thanks Mohan sir for the nice introduction. I would like to sincerely thank Vijay Kumar sir for giving me this opportunity to talk on a very important, often not spoken topic, hearing loss and diabetes. So Christopher Murray is one great person who always talks about the global burden of disease, which we don't often talk much. So what is global burden of diseases? Like to look into some of these minor ailments, which we may look minor, but it may be looking a big burden for the patient. Say, let us presume an example, an individual lives till the age of 70 years. And at the age of 60, he dies. The years that he lost because of this ailment is 10 years. When he gets an ailment at the age of 50 years and rest of 20 years, he lives with this disability. So 20 years he lives with this disability, but we don't quantify this morbidity with that mortality. So both the things looks distinct. So it doesn't correspond. So he tried to look both these parameters of morbidity and mortality into a single factor and derived this concept called as disability adjusted life in years. So if you see for hearing loss, the disability adjusted life in years for a person who has developed a mild hearing loss or a moderate hearing loss compared to a person with a severe hearing loss where the disability adjusted life in year is going to be minimal. Whereas if it is moderate, he loses about 2 years of his productive life. It is equivalent to his 2 years of productive life in with respect to the mortality. So there can be other illnesses in the form of his low back pain, or he may have a migraine, all these things. So we have to compound all these things. So one thing that we want to tell here is because of the hearing disability, the disability adjusted in life in years is equivalent to 1.5 to 2 years. Now, why do we want to talk about hearing loss in diabetes? So if you see international textbook of diabetes, there is not even a single word where we can find like hearing loss in diabetes is mentioned over there. This is the index which I have copied. So why do we want to talk about it? All came, there were some small studies which looked into hearing loss and diabetes, but this article which got published in Annals of Internal Medicine in the year 2019 in US, they looked into the population from Nantes group. So NANS are something like similar to our Framingham heart study, like almost similar to that, when Framingham heart study looked into various risk factors which are affecting the heart. This study group looked into the nutritional factors of individuals. So it's such a huge study, huge information we have developed. We can just go through and see what NANS has contributed towards the various risk factors and various nutritional supplements that we consume. Amazing amount of publication done by this group. So in those group, in the particular year 2004, they picked up about 10,000 individuals, and of them like 5,000 people, 5,200 and odd, they subjected to an audiogram. They just subjected to an audiogram and nothing more. So of these people, they are all non-institutionalized patients. Basically, it means they are non-military patients, because military patients, because of their work environment and industrial environment, may have some hearing loss. So they excluded all those people. And in these people, when the audiogram was done, then they looked into whether they are diabetic or not diabetes. So after doing the audiogram only, they did that, of which like 2,500 were diabetic, and surprisingly 2,500 were non-diabetic. We don't see that rationalization once the subject group is taken, but that is how the study happened. So, and at the end of the study, done for about 4 years, they surprisingly found that in diabetics, there was about, in general, like 10 decibel loss was seen compared to non-diabetic. So across the age group, whether it is 20s, 30s, 40s, 50s, 60s, there was about 10 decibel loss in the hearing loss, which was happening in people with diabetes compared to non-diabetic. So it became very clear, and after which there are many meta-analysis, type 1 subgroup analysis, type 1 meta-analysis, and there are small studies, various studies. I don't want to illustrate all those data. So NANS is one study which showed very clearly diabetics is associated with at least 10 decibels hearing loss across the age group. So, but why does this can cause hearing loss? Why should diabetes can cause a hearing loss? It could be because of diabetic angiopathy, which is a product of intimal glycoprotein with endothelial damage. Typically, we see in microvascular disease in the form of fundus, or objectively we can see in proteinuria, or when there is a neuropathy, or in the fundus. But numerous studies, especially almost all these studies are postmortem studies, have demonstrated diabetic changes to the stria vascularis, basilar membrane, and hair cells of the cochlea. So these are all postmortem studies. We are not able to demonstrate, because the stria vascularis is unique to the inner ear because of its rich microvascular, something similar to the fundus. In spite of that, which is we are not able to demonstrate these changes in stria vascularis, because the entire apparatus, stria vascularis with cochlea and organ of Cartier and hair cells, everything is being encapsulated by the bone. So for this simple reason, that we are not able to demonstrate like what microvascular changes are happening in the stria vascularis. So the editorial of Annals of Internal Medicine, which looked into, said like we don't have the cochlear equivalent of fundoscopic examination. So we have a very limited ability to confirm the enticing hypothesis of impaired microcirculation of the ear. So we are not able to demonstrate that it is because of the microangiopathy. Could it be because of mitochondrial damage? Because there are some defects which run in the family. So by increased mitochondria derived reactive oxygen species can it mediate it. So particularly maternal inherited diabetes of the deafness results from genetic substitution of mitochondrial tRNA, or Wolfram syndrome, where we all know it is characterized by the triad of diabetes, optic atrophy, and sensory neuronal hearing loss. So could it be something like mediated, something which happens in this disease to all these defects? But it is not so, because the prevalence of this disease is very low, something around 1 in 1 lakh, but the incidence that we see in clinical practice is much more higher than that. So that rules out like it cannot be due to mitochondrial damages. Could it be because of neuropathy? Then the third thing comes because of reductions in the dendritic branches, or the oxidative stress production from the because of the free radicals which are getting produced from the oxidative stress. Could it be because of all these factors? So these changes are associated with the degradation of the vasa vasorum of the blood vessels surrounding the vestibulocochlear nerve. So we have to study the vestibulocochlear nerve, which was much more easier, or objectively we can do in the form of auditory brainstem response. So what is auditory brainstem response? Is you are assessing the retrocochlear neural pathway, where you put two headsets over the patient and give an auditory impulse and see how much amount of responses it are evoked in the brain. This is typically done in pediatric age group. for the reason that we want to roll out in a congenital hearing loss in them to evoke the response. The patients are even done under, this test can be done under whole anesthesia also. So just to elicit the response of the electrophysiological signals which are generated in the brain secondary to the signals which are getting produced. So this also like produced this auditory brain response, this in this particularly this Portland Veterans Affairs Medical Center. I don't know, they studied people with the diabetics of about 15 years duration compared with a non-diabetic. So in this study, prospectively they studied for 4 years and they did this auditory brain response, and it showed in particular frequencies they were associated with latencies which are peculiar to neuropathy or absent. Every year it was progressively getting lost in diabetic than in non-diabetic. So which is amazing to show that it could be because of neuropathic changes. So how do we help our patients? Typically you ask for an audiogram. I'll just take 2 minutes to explain how to interpret an audiogram. So you ask for a pure tone audiometry where the decibels are getting matched against the frequencies. So what you see over the vertical axis is the decibels, the sound intensity at which it is lost, but that is not the alone important. We have to see match it against the frequency. So when we see the auditory hearing loss based on the decibels, like less than 25, it can be normal, 25 to 40, it can be mild, moderate, or severe. So this is the intensity of the sound that matters. But what is more important is not the intensity alone. What is important is for which frequency they are getting lost. Say it could be a elephant's trumpet, the low frequency sound. So if you see an elephant trumpet, like it is a very such high sound. If you see earthquake, it is such a high sound. Or if you see the dog barking or the lawn mowers or even the sound of the thunder, it is a high sound, but it is a low frequency sound. Typically vowels like A, E, I, O, U are all low frequency sound. The high frequency sounds like a bird's chirping or a child's sequel or a woman voice. Somebody may be selectively saying that he's not hearing to his ladies' voices. So it is not because of that. There is a loss of just a high frequency loss happening to them. So there can be a low frequency loss or a high frequency loss. So if you see in the audiogram in this chart, there is a loss of about 60 decibels, which corresponds to only 6,000 frequency. 6,000 frequency is the one which we see typically in noise-induced hearing loss because of exposure to various noises or using too much of headphones or working in a workplace where the sound is higher. This is the typical graph that we see in a noise-induced hearing loss. About 60 decibels is lost at about 6,000 frequency. So, but other frequencies are all same. So this is something which we need to understand. And also we should understand the loss that happens in diabetic is sensory neural hearing loss. So what is sensory neuronal hearing loss? Sensory neuronal hearing loss can be assessed by whether it is a bone conduction or an air conduction. So if the bone conduction is better than air conduction, what does it mean? That the sounds waves which are coming into the ear are not able to be transmitted inside the ear. So that is the reason there is a bone conduction which is happening better than the air conduction. So it means that there is a problem in the external ear where the air conduction is not felt. So you have to remove the cerumen or it could be due to the perforation which is happening in the eardrum, which can be causing. So bone conduction, if there is a gap between bone conduction and air conduction, always we should note that it could be because of some external ear functions, and these are something which we don't see frequently, but they can be surgically corrected, and they are correctable causes. There can be correctable causes of hearing loss. 95% of the defects we will be seeing only like this, where the progressively, as the frequency goes increasing around 2000 to 8000, we see a hearing loss over here. So quickly, 1 minute. A self-reported hearing loss or taking the history from the patient is not going to be specific. So this study very clearly showed that having a hearing loss, self-reporting hearing loss, is not going to be useful. So don't ask the patient or the attenders whether he has a hearing loss or not in your diabetic patient, because it is not going to help them. Rather, what is important is you can just do a whisper voice test, which is the most important test. If at all a carry home point can be taken from entire presentation, we have to know how to do a whisper voice test for our patients. Just stand behind the patients 2 feet away, 60 centimeter away, ask the patient to close one ear and whisper 3 syllables. It could include 2 alphabets and 1 number, or 2 numbers with 1 alphabet. It should be told in a very, very soft way, standing just behind the patient. And after exhalation, after you exhaling the air, it has to be told. If the patient is able to hear, then it means that it is very good. So this particular test, whisper voice test, has got almost about 90% sensitivity and 90% specificity, both for pediatrics as well as adults, both for sensory neuronal hearing loss as well as adult conductive hearing loss. So I just conclude the carry home points are disability adjusted life in years with respect to hearing loss is much severe than what we think. Diabetes and hearing loss, as we saw in the article which got published in Annals of Internal Medicine, it has got very, very specific correlation. The mechanism is probably neuropathic. We should understand how does our Puritan audiometry help, and simple whisper test is all that it is needed when we want to screen in our patients every day. With this, I conclude, and I thank the opportunity for
Now we'll have 5 minutes for the previous 3 topics. Any questions from previous 3 topics?
Can I start the discussion? To Dr. Sriram Mahadevan, sir, we don't talk about andropause and bone loss. We always talk about menopause and bone loss. Isn't it equally important, sir? Say you muted.
The andropause, the age is very varying, anywhere from 50, 55 years till 70, 75 years. And after the age of 75, the age-related bone loss, which we called the primary osteoporosis, superimposes on the andropause-related osteoporosis. That's why, and the longevity after that, and those adjustments also have to come. But menopause, as you know, happens anywhere between 45 to 55. The longevity, the age span, lifespan after menopause is almost 30, 40 years as of today. So that's why, and that's why it carries. This is simple answer. But your point is very well taken. Even though we don't use the word andropause, the secondary osteoporosis, any young male less than 60, 65 years, or probably even up to 70, I can include. That is why the US task force recommends that you don't do bone density routinely in men before the age of 70. But if you suspect hypogonadism for some reason in a male, please address bone health. One of the important reasons, as you know, many of the fertility patients, many of them come to us for treatment, like Klinefelter syndrome or hypogonadotropic hypogonadism or pituitary diseases. They all cause hypogonadism. If not appropriately replaced, the chances of osteoporosis is much higher. So we don't call it andropause in them. As a secondary osteoporosis is very important.
I have a question for Dr. Ramkumar. Sir, we talked about diabetes and the gingival health, but the inability to properly chew is going to make him select those dishes which are easy to swallow, you know, like ganji and things like that. That is going to also increase his diabetic, uncontrolled diabetes. So I think it is not only, you know, scientific in its nature, but also it's a practical problem that we are not talking about. So we need to start asking about it to everybody in reality.
Yeah, you're right, sir. Valid point.
Can I have a question?
Yes.
Dr. Gauri, excellent talk, and you saved us about 8-9 minutes also. It's a very brief but very effective talk. What I would like to ask a question to you is that you showed that the
Hearing loss is such a important aspect. Do you have any treatment options to improve that hearing or prevention of hearing loss?
So prevention of the hearing loss, we should, once the patients are diagnosed with a hearing loss, we should make sure that their diabetic control is good. They don't progress to neuropathy. There is some correlation with HDL, and they are not working in a noise exposure, and we don't give any ototoxic drugs. So these are the things that we can do as a diabetologist or a physician. But apart from that, like treatment, like obviously once we diagnose, if the patient has got a obvious mild to moderate hearing loss for that particular frequency, we have to refer to an ENT friend, and hearing aid can be offered where the specialist role comes into, sir. We can diagnose, but we have to involve our ENT friend.
Dr. Kannan asked a question for which
Dr. Sriram Mahadevan, somatic motor neuropathy and its impact on osteopenia. You've already answered, sir, but a lot of people may not be looking at this thing.
Neuropathy, in addition to fall risk, which is very easy to understand, neuropathy will maintain the position sense, joint position sense, there is a neural stimulus always to the bone also, and the biomechanical sensing, which happens when you walk, etc., or through these nerve, and that's how the osteocytes pick it up. So there is a neural control of bone health is well understood. And the extreme example of that is Charcot's disease, where the vascular component is normal, but the patient has severe neuropathy, which leads to totally distorted foot. You would have seen those patients. So I think from those things we gain knowledge that neuropathy, not just fall, but specifically bone health. I wanted to ask Gauri one small question here. He said that whisper test was very appealing in the clinic. What should be the ambient noise? It should be a very silent room, I suppose. In an audio-proof room, maybe that is possible, no? In a clinic, and that too in a typical GH kind of clinic and all, whisper test is not possible.
Sir, they say it can be done in any clinical clinics. Only thing, it should be silent enough. But
one simple clinical addition to that is you can keep a normal person and talk, and if he hears and if this fellow doesn't hear, maybe that can be a comparison. Maybe that's a simple thing we do, no?
But the whisper test is not meant for that, sir. Even when we went for army, that is how they assessed. So army, they are very particular about you should not have any hearing loss. So even in such a big organization, they didn't ask for audiometry on evaluation. They did just a whisper test. So
one more suggestion. I mean, sorry, I'm taking one of the. The stethoscope can be put to the patient's ears, and you tap it slightly. You can have some way of objectively tapping it, and that could be also considered. These are all screening tests for our clinic purpose. That's why.
Sir. We can ask the patient to close his own tragus and keep doing a round over there, sir. That is how it is just done. Actually, we should ask him to close the other ear, and he should close his tragus, and he should be doing a round sort of thing like this over there in the opposite ear. That is how he gets distracted from the one ear and the other ear. So the other ear has to be put
I
open.
understand.
If you use a stethoscope, both the ears will get occluded. No, sir.
I remember in MBBS, they used to tell this clicking of these nails.
Sir.
That is heard, then that is a good test.
But that that would be a high frequency sound, sir.
This clicking of nails.
True, sir.
Thank you.
Yeah, for want of time, let's go to the thing. Again, we'll continue the discussion at the end. Over to the next speaker.
Yeah. Just once.
Dr. Pandit.
Yes, sir.
Just one question to Ram Kumar, before going into the next session, I have a question for you. See, we generally
ask the patients to do fasting BP, HbA1c every 3 months, and we do a plethora of tests every year as a screening for ECG, creatinine, all those things we do, lipid profile, everything. But we tend to not look into the oral hygiene as a theme. So do you suggest that we need to do the oral hygiene test also every year along with other tests, or you want to do more frequently?
Sir, I advise my patients to go and see Dr. Kamala, who is upstairs, but many people don't bother unless they have a problem. but we insist to take a proper care. And many guidelines are saying that they should go for a oral health examination every year. Even if we do freely, they don't go. They don't bother unless there is a problem. So, but this is much neglected issue, as told by you. We should more stress on it and to prevent complications and better control. Thank you.
To close the discussion on a lively note, possibly India is the diabetic capital of the world. So possibly that's why they don't, they all have hearing loss. They don't listen to the social distancing, masking and all. Maybe that's the reason.
Move on to the next topic. The next topic is loss of taste and smell in diabetes. We all have heard about loss of taste and smell in COVID. And now Dr. Rajesh is going to talk on loss and smell in diabetes. And Dr. Rajesh, one of my friends, is a consultant diabetologist at Adhavan Diabetes Care and HOD Department of Diabetology in Mehta Multi-Speciality Hospital, visiting consultant in the Ministry of Defense, Havdi, and frequently involved as a faculty speaker, as a part of organizing committee of various national and regional conferences in diabetes, involved as faculty in various certificate courses, diabetes for medical practitioners and diabetes educators, involved as an advisor and principal investigator in multi-center clinical trials in diabetes, and formed the Chennai Diabetes Forum, CDF, through which CMEs have been conducted in diabetes every month since for the past 8 years. Now, Rajesh, take on, Rajesh.
Am I audible, sir?
Yes, Rajesh.
Can you see my screen, sir? Can you see my screen,
yes,
sir?
Yes, yes, yes,
yes,
yeah.
yes.
Yeah. Make it full screen.
I have made it, sir. Just
yeah. Yes, right.
So, yes, sir. Thank you, sir, for the very kind introduction. Respected chairpersons, senior clinicians, and my dear friends, wish you all a very good morning. And before I could start, I want to profusely thank Dr. GVK sir for giving this wonderful opportunity. As rightly said by the chairperson, the moment we hear about the terms loss of smell and loss of taste, what immediately strikes our mind is a COVID-19 infection. Because these two symptoms are very common in COVID-19 infections. But what we need to understand is that loss of smell and loss of taste is equally common in patients with diabetes also. So before going into the topic, just a brief note on the physiology. We know that olfaction forms one component of multisensory event. For example, when a patient is eating, when a person is eating or drinking, what happens? There will be interaction of at least 3 sensory pathways: the gustatory, the trigeminal, and the olfactory systems. And the gustatory system will actually pick up all the components of the taste, and certain sensations like a pungency of a mustard and sparkling of a carbonated drinks, all these will be transmitted by the trigeminal nerve. And we have the olfactory system, which picks up thousands of different odors from the environment via the nostrils anteriorly. But when the food or drink is being consumed, what happens? The smell will reach the olfactory mucosa by way of the throat posteriorly. And what happens? When nasal airflow of utterance happens, then that will reach the olfactory neuroepithelium, and there they will bind and activate the olfactory receptor proteins. And this olfactory receptor proteins have numerous olfactory receptor neurons. There are about up to 30 million olfactory receptor neurons. One special characteristic of these olfactory receptor neurons is that they continuously renew themselves from the basal cells. But this regeneration capacity actually diminishes with increasing age. So that is the reason why in advancing, as the age advances, usually the olfactory function actually declines. But on the other hand, if you look into the sensation of taste, it is actually conveyed through only 5 taste receptors, that is the sweet, the salt, bitter, sour, and umami, which is expressed in the tongue as well as the palate gustatory buds. So when somebody is having an olfactory dysfunction, we usually refer that they have a reduced or distorted ability to smell or during sniffing or during eating, that is the retronasal olfaction. And when we refer that somebody is having a hypergeusia, we usually mean that they have a decreased sensitivity to taste. So if you look into the manifestations of the olfactory dysfunction, that can include presbyosmia, which means an impaired sensation of smell, and phantosmia, that is in the absence of an external stimuli, they will be still able to identify smell, and parosmia, there will be completely altered smell. So external stimuli will be something different, what they identify will be something completely different. And hyposmia, which is a diminished ability to detect and identify smell, and anosmia, that is the ability to detect or identify smells. So inability to detect or identify smells. So how far these conditions are prevalent in the general population? First of all, we need to understand that sensation of olfaction itself is being underreported or underestimated or often overlooked when compared with other sensations like vision or hearing. And if you look into the research work on olfaction itself, that is all 40 years behind the research works that has been done in the field of ophthalmology or in hearing. So here there is a survey in European data which reveals that 1 out of 5 individuals have hyposmia, and at least for 300 people, at least one person has anosmia. So taken together, these two conditions, at least 20% of the European general population have some form of altered olfaction, impairment in their olfaction. And regarding there is another US data which shows that 13.5% have smell impairment and 17.3% have taste impairment, and 2.2% have both taste and smell impairment. And again, in the general population, anosmia is prevalent at least in 5% of the general population. And with advancing age, I told you there is a decline in the olfactory function. So above 50 years of age, at least to 25% of the patients will have some sort of impairment in their cell, in their smell. And what happens is that when there is an olfactory dysfunction, that will actually significantly impact the quality of life. And that also, there is also evidence to show that there is these people will have signs of depression, and it doesn't stop there at all. There are also evidences to show that there is increased mortality in patients who have defective smell. So if you look into the factors which are associated with the loss of smell or taste, so sex and age, I told you advancing age is a risk factor. And again, in sex, men are more likely to experience the smell loss because of the occupational and environmental hazardous exposure, and again, environmental airborne pollution and toxic odors, trauma, especially to the frontal head injury, and certain diseases like chronic rhinitis and allergies, infections of the middle ear. All these things can even loss of sensation of taste, and there are certain drugs, cancer treatments. All these things can lead to loss of smell. But one important thing is that Alzheimer's disease and Parkinson's disease, their smell loss can be there, and this could be an early indicator of an degenerative neurological disease the patient is going to experience later. So this thing we have to keep in mind, and there are also other reasons for taste loss. I'm not going into those details. Now let us look into the loss of smell, especially in people with diabetes. How far it is prevalent? There are so many studies. I'm going to project you a few studies here. Here, this study has been done between 2013 and 14. So here, the sample size was 3,151. And there they looked into the self-reported olfactory dysfunction. Just 3 questions was asked to these patients. Have you had a problem with smell in the past 12 months? Have you had a change in the ability to smell since age 25? And do you have phantom smells? And they were also subjected to other tests like an 8-item pocket smell test. If they had less than 5 correct answers, then they have advanced disease. So what they found was that in the US population, 21.5% have a self-reported olfactory dysfunction, and 13.3% had a measured olfactory dysfunction. And especially people with diabetes, they had a higher prevalence of phantom disorder, of phantom odors, and they also had a higher prevalence of hyposmia and anosmia. And again, here there is a systematic review and a meta-analysis. 11 articles were taken. You can see a good number of people were involved there, and at least 4 studies were taken for meta-analysis, and they looked into all the components of olfactory function. And they also did, in most of these studies, they did a complete ENT examination to rule out other reasons for the olfactory impairment. What they found in all these studies was that there was a strong association between diabetes and olfactory impairment. And in the meta-analysis of that 4 studies, what they found was that the odds of having an olfactory impairment in people with diabetes was actually 1.5 times more than people who do not have diabetes, that is the control people, and this was statistically significant. Why do these people with diabetes have loss of smell? What is the mechanism? First of all, the main culprit is hyperglycemia itself. See, hyperglycemia will actually result in increased cortical thinning of the orbitofrontal cortex, which is responsible for olfaction. And type 2 diabetes patients have significant atrophy in the cortical and subcortical regions of the brain. And chronic hyperglycemia and microvascular disease have been, which are frequently encountered in type 1 and type 2 diabetic subjects. They have been associated with mental and motor slowing. And diabetes is actually characterized by a neuronal slowing and increased cortical atrophy and microstructural abnormalities in the white matter tracts. With respect to this phantosmia, which was higher in diabetic subjects, this was related to a reduced gray matter volume, especially in the orbitofrontal cortex region. And evidence shows that diabetes people have reduced cortical gray matter thickness in these particular regions, especially the orbitofrontal cortex. And again, people, when they have macrovascular disease, that also will explain the increased prevalence of severe olfactory dysfunction. This has been evident that when you control cardiovascular risk factors, as well as when you control hypertension, there was attenuation in the effect of diabetes on the phantosmia. And third and most important thing is that insulin resistance, which is there in type 2 diabetic subjects, is responsible for this olfactory dysfunction. That is, insulin resistance in the olfactory bulb and orbitofrontal cortex potentially could play a role in the olfactory dysfunction. And there is also a lot of evidence in this regard that insulin regulates the olfactory mucosa physiology, and intranasal insulin may actually improve the olfactory sensitivity and discrimination. So, with respect to the loss of taste in diabetes, again, we know the basic tastes, which are sweet, umami, sour, salt, and bitter. What happens is that when there is an impairment in taste perception, this will possibly shift the patient towards an unhealthy eating behavior. And that could result in extensive health consequences, and there will be increased risk of metabolic diseases like diabetes, obesity, and metabolic syndrome. And people with diabetes, a lot of evidences have shown that they have impaired the taste sensation to all the taste, which is most prominent for the sweet taste perception compared to the other taste modalities. And here there is a study which was done among patients who had good glycemic control, 32 diabetic subjects who had good glycemic control compared with 32 healthy volunteers. What they found in this study was that taste scores were lower in subjects with type 2 diabetes. Particularly, the sweet taste was actually grossly reduced in diabetic subjects, even when they had a good glycemic control. And what they hypothesized was that this alteration of taste function will actually result in search for foods which are richer in sugars. Thus, it will result in a vicious cycle of search for foods richer in sugar, and thereby eventually leading to hyperglycemia. And again, here there's another trial where they compared controlled diabetic subjects with uncontrolled diabetic subjects. 40 controlled diabetic subjects, they have taken another 40 uncontrolled diabetic subjects and another 40 healthy matched controls. What they found was that both in the controlled as well as the uncontrolled diabetic subjects, there was a gross impairment in the taste, which was statistically significant. And this was highly significant, especially for the sweet taste, which is followed by sour taste. And even for the salt taste also, the reduction in the taste and perception was actually significant in patients who have diabetes. So, hypoglycemia was actually reported among 62.5% of the diabetic patients, whereas it was noted only in 12.5% of the control subjects. What happened to the uncontrolled diabetic subjects? If you take them, 6 patients who had uncontrolled diabetes had actually ageusia, that is complete loss of taste to sweet. So this was actually statistically significant. So it concluded that people with diabetes had a blunted taste response, which was most prominent, most marked for sweet, which was followed by sour as well as salt taste. And again, what about type 1 diabetic subjects? Do they also behave in the same way? Here there is a comparison. They did electrocaustometry method as well as chemical caustometry method, and what they found was that in type 2 diabetic subjects, they also had a grossly taste impairment when compared with the healthy subjects, and hypoglycemia.
1 minute
Sir,
more.
sir, 12 minutes only, sir. Okay, sir, I'll finish off. So hypoglycemia was actually found among 73% of the diabetic subjects, whereas only 16% of the control subjects had hypoglycemia. So, and what they found, there was a significant association with the peripheral neuropathy. That's what they found in this test. And what about newly detected diabetes patients? Here they have taken 20 newly detected diabetes patients, and what they found was that when you reduce the HbA1c in those patients, when you bring down the HbA1c from 12.6 to 8.8, what they found was that when they were not under control, they had a severe taste impairment. But when they bring it under control, it was partially reversed. The taste sensation actually, reduction in the taste was actually partially reversed on correction of hyperglycemia. And again, what is the mechanism here? Again, here hyperglycemia itself is a culprit here. Hyperglycemia will induce a concentration-dependent impairment of a sweet taste perception in diabetic patients as a result of an adaptation of the sensory cell to an elevated circulating concentration of glucose. And in case if a patient is having a neuropathy complication, then there will be neuropathy involving the taste nerve tracts and microangiopathy involving the taste buds that is responsible. If the patient is not having any complication like a newly detected diabetes, what happens? Defects in the taste receptor will also be responsible. And to conclude, what we have seen is that there is a high prevalence of loss of taste and smell in diabetes, and type 2 diabetes has a strong association with cognitive impairment and dementia, and olfactory dysfunction will be an early marker of development of cognitive impairment. So if a type 2 diabetic subject is having an olfactory dysfunction, then that denotes that these patients will be developing some kind of neurodegenerative disease later on in their life. And now, olfaction is not routinely assessed in clinical setting, but with the availability of low-cost validated tools like you have a sniff and sticks or a University of Pennsylvania smell identification test, this is actually possible. And evidence also is there to support an association between olfactory impairment and diabetes with potential link to microvascular complications, especially peripheral neuropathy with regards to taste. If there is a general reduction, the type 2 diabetics, diabetic subjects, generally they have a decreased sensation for taste, especially for foods, for sugar foods. And what will happen is that there will be search for foods richer in sugars. So there will be a vicious cycle, thus decreasing the likelihood of remission in diabetes mellitus. So with this, I end my talk. Thank you. Over to the chairpersons.
Yeah, move on for the next topic.
I take great pleasure in inviting Dr. Ram Lakhani to give us talk on Om Lakhani to give us talk on sex and diabetes, erectile dysfunction. Can I have a introductory slide, please? He's a consultant endocrinologist, Department of Endocrinology, Zydus Hospital, Ahmedabad. He's completed his MD and DNB in endocrinology. His honors and achievements: a winner of the President Gold Medal in Endocrinology, national winner of ESI TYSA in 2016, second runner in AV Gandhi Award 2017, winner of 2 gold medals in MD, 5 gold medal in MBBS, winner of API Vittal Rao Nadgoda for best thesis in MD medicine. So over to you, sir.
Thank you so much for the kind introduction. I'll start sharing my screen. Technical team, can I be allowed to share my screen, please? Yeah. Okay, is my screen clearly visible?
Yes, sir.
Okay. First of all, thank you so much for giving me an opportunity to give a talk on a topic which is very close to me. This is an area of active research again for me, and this is something which is very, very important for your patients, and for not only their overall well-being but also their quality of life. And if you can master the art of managing sexual dysfunction in diabetes, I promise you, your patient number will increase dramatically. It's something which is really helping your practice in a great way. So I'm going to talk about sexual dysfunction in diabetes, but instead of giving you a theoretical background, I'm going to talk about practical tips which can help to improve your practice and which can help you in managing your patients in a better way. Now, I'll start with, those who are fan of web series online. There's a very nice web series called Mirzapur, which is available on Amazon Prime. Why I'm alluding to this thing is because, erectile dysfunction actually plays a very important role, not to give away the plot, but erectile dysfunction plays a very important role as a plot point in this entire story. And, just to brief you, the main protagonist or main antagonist rather, the guy called Kaleen Bhaiya, who is basically a big don in Uttar Pradesh, he suffers from erectile dysfunction, and the consequences of this are actually pretty much devastating for not only him, but for the entire series as well. So, there is a funny scene where he, tries to meet a sexologist, and the conversation, he's a big shot don, and he's really embarrassed to talk about his sexual problem, which you can imagine every male who comes to your clinic, I think, faces the same problem. In his mind, he may not be a don of Mirzapur, but he would certainly be the don of his house. That's what he feels. And often, the conversation is very difficult. So the first question I'd really like to ask and answer is, who starts the conversation? Do you start the conversation on this topic, or do you allow the patient to do that? That is a very important point. Now, the answer to this is very simple, and this has been actually proven in clinical studies as well. The answer is you need to start the conversation and not the patient, right? You provide a good environment for the patient to discuss this. We all know that, discussions, consultations in a clinic are family consultations, okay? So you don't have one patient who walks in, you have the patient, you have the wife, you have the children, you often have the mother-in-law, the father-in-law also joining the consultation. I think, for you to initiate a discussion on the sexual dysfunction, the first thing is you need to clear the room. Okay, allow the patient to be alone with you, and then start the conversation. Ask him these questions. You can just ask the relatives to step out for a moment, and then perhaps in the privacy of that room, you can perhaps the conversation is better. But the point here is that you should always start the conversations from your end. This has been again given in the American Family Physician Guidelines for erectile dysfunction, that the conversation starts by the doctor, by the clinician, and not by the patient, right? So you have to ask these questions. Now, there's a typical model which is given way back in 1987 for discussion of the sexual dysfunction. It is known as a PLISSIT model. It stands for permission. You give the patient permission and a good environment for them to discuss the problem, limited informations, specific suggestions which can help the patient, and an intensive therapy. If, of course, you are not trained for the same, you may refer the patient to a specific doctor who can help in this process. Again, a lot of people are, and again, from taking a cue from the Mirzapur series, in this conversation, like the Uttar Pradesh Don, he's not comfortable talking about his problem. He brings his right-hand man to sit down, and he says that this guy talks in third person, and some people, you'll be surprised, tend to be more comfortable talking in third person, right? So you can raise the topic, he'll say, my friend suffers from erectile dysfunction, and sometimes very comfortable for patient as well as for the doctor to talk about an imaginary third person or about an X person. I think, and that puts the patients to ease. This, you'll be surprised, again, is a part of the American Family Physicians Guidelines for erectile dysfunction. You often raise the topic, and if the patient is not comfortable talking about it, a third person can be said. You can ask them, do you have a friend who suffers from erectile dysfunction? You want to talk about that? Yeah, the patient will often, volunteer more information in that sense. What is in it is, doctors will ask me that the discussion on erectile dysfunction is another 5-10 minutes of your consultation time. What is it in it for me? If the patient is not going to volunteer the information, why should I, raise this issue and waste my time? I think it's a very fair question. But as a clinician, it is going to benefit you. I'll just give you some reasons why it would, right? And then you can judge for yourself. First of all, we'll discuss this point in a few minutes again. There is a very strong relation between cardiovascular disease and erectile dysfunction. In fact, as I discuss further, and I'll raise this point once again, that erectile function is the window to the robustness of your endothelium. So if you want to, a quick clinical test for diagnosis of endothelial dysfunction, the answer is erectile dysfunction. You can prescribe the right medications so as not to make the problem worse. We'll also discuss this point. And it is one single quick question. We have been discussing about diabetes complications in this, series of lectures since the morning. But one quick question that can assess both the neuropathy as well as the vasculopathy can be erectile dysfunction. So if the patient has erectile dysfunction, it says that the patient has he has diabetic vasculopathy as well as diabetic neuropathy to some extent. Obviously, most important for you, most important for the patient, most important for the business of medicine is that it improves the quality of life of the patient, improves compliance of the patient, and allows your patient to come back to you again and again. I think that is a very, very important aspect of your practice. The second important pearl is, what key information do you ask in the history and what should you look for in the examination, right? So here are some clinical pearls which can help you in that. A very important aspect you should always ask is importance of loss of libido, right? Some of these patients will complain loss of libido. And, if the patient says that he has loss of libido, it makes sense to test for the testosterone level, right? One of the early signs of hypogonadism is loss of libido. In fact, I'll tell you, we have diagnosed a lot of patients with prolactinomas, with other pituitary dysfunction, even hypopituitarism, when they come with when they come with just the history of low libido. And I think low libido is a very important clinical history. You should ask the patient. What you have to be careful, however, is that this is a double-edged sword. Sometimes it could be a trap. It's a trap because patients with a long-standing erectile dysfunction have a secondary loss of libido. And this is something you should keep in mind, that long-standing ED would also lead to loss of libido. So loss of libido, though not very sensitive for hypogonadism, is a very important, still a very important question you should ask. And any patient who complains of loss of libido, a morning 8 a.m. testosterone level should be done in these patients to evaluate anything further. Of course, clinical examination should include other features of hypogonadism that should be looked for or asked for. You should have an orchidometer available with you. Orchidometer is a very simple tool. There are strings of beads. The beads, each bead is approximately the volume of a testis. And typically adult males have, just for the information, 20 ml testicular volume bilaterally, and you should measure, and lower testicular volume would suggest possibility of hypogonadism. Again, ask the patient about the frequency of shaving, the facial hair growth, and again, the patient would often tell you this information. The penile length, a shorter penile length would suggest a long-standing hypogonadism, often a hypogonadism that initiated before puberty or peripubertal onset. And of course, gynecomastia is a very important clinical examination and a history point that should be taken into account. Another very important, very common problem, again, all of you who have practiced for a long time would know this, that premature ejaculation is a big problem in our Indian patients. This is something which patients are not very comfortable discussing again. And a lot of the patients suffer from isolated premature ejaculation. But what is important is that you tend to have both the ED and PE exist in the same patient. I think this is a very important problem, and you should ask your patient about premature ejaculation, right? Now, unfortunately, because of the advent of a lot of pornography, easy access to the same, patients tend to have a lot of preconceived and a lot of wrong notions about premature ejaculation. But, first of all, reassure your patient. On an average, a lot of studies have been done, and the average sexual intercourse time is about 5 minutes. Some studies have even shown 2 minutes, right? So you are able to, perform for 2 to 5 minutes. That is actually considered to be normal, right? Unfortunately, like we said, a lot of these people get there. Unfortunately, we do not have very good sexual education in children and younger adults. And, most of the information these people get is from pornography, which, the actor performs for hours together, which is absolutely not possible physically in day-to-day life. So what is important here is that people should be aware about the expectations. However, if they are if the partner or the patient himself is not able to achieve orgasm, I think that again is an important area which should be looked at. So premature ejaculation is another important aspect that should be looked at in your patient. It is very important to take the history of medications and drugs. Some of these drugs I will contest myself. This is a list taken from this reference, but very importantly, beta blockers, right? Be very careful of beta blockers. Beta blockers lead to erectile dysfunction in a lot of your patients. Again, they talked about cimetidine, but I think domperidone, right? We all prescribe domperidone to a patient. Pan-D, Nexpro RD, and just, pardon me for the brand names, but we all prescribe domperidone. A lot of our patients have GI issues and diabetic gastroparesis, and you prescribe this, but often can lead to erectile dysfunction secondarily. So be careful of this history. As far as the cardiovascular drugs are concerned, again, three things: beta blockers, diuretics, and digitalis can often lead to erectile dysfunction. Alpha blockers actually help, right? We'll discuss this point in a few minutes. ACE inhibitors also help. Calcium channel blockers help to an extent. ARBs help to an extent. And statins is actually contested. Some studies show that it worsens, some studies show it actually improves the erectile function. Like I said, beta blocker, though not very common, beta blockers, irrespective of the beta blocker which the patient is taking, can lead to sexual dysfunction, erectile dysfunction. So if the patient has history of ED, don't give beta blocker, or unless the advantage is by far too much. But at the same time, this is something you should be looking for. As far as statins are concerned, there is a bidirectional link. Some studies have shown statins are associated with ED, but on a longer run, and please bear this in mind, it actually improves the endothelial function, leading to better erectile function. So when statins are given for a long time, for a shorter time, it may lead to erectile dysfunction or maybe neutral to it, but when given for a long time, it leads to improvement in the control. As far as antihypertensive is concerned, this is a tip, you should keep this in mind: doxazocine. Doxazocine is also used in benign BPH as well. Doses are 1, 2, and 4 mg, which are available. Starting dose is 1 milligram. It's a very effective antihypertensive drug, as well as a very effective drug for erectile dysfunction. And losartan or any other ARB are also very effective for patients with ED. Some practical aspects of starting a PDE5 inhibitor: check the patient's preferences. If the patient wants a natural and on-demand erection, right, where the patient does not want his partner to know that he or she is taking a pill, they should consider using tadalafil. Even a tadalafil daily administration is very, very effective. A lot of these patients have very good quality of life. You can give a lower dose of tadalafil, which is 2.55 milligram, instead of on-demand dosing. However, some patients who have intercourse very intermittently, they can be considered giving a short-acting agent, and vardenafil is it's available in India. It's an on-demand, short-acting, low onset of action, very effective drug for treatment of patients with erectile dysfunction. Only thing is, vardenafil is extremely potent PDE5 inhibitor, and sometimes you can have a first dose effect, meaning the patient can develop sometimes orthostatic hypotension after taking it. What you have to understand is timing of the medication. Though there is no clear study for that, it is advised to be given 1 hour after a heavy, especially a fatty meal, right? So if the patient has a very heavy fatty meal, I think this time you have to make sure that it's being taken at the same time. If the patient has premature ejaculation, don't give depoxetin alone. Depoxetin given alone can worsen the ED. So it is always better to give ED plus PE treatment together. That is a fixed drug combination of tadalafil with depoxetin, which is available in India. I think it's very effective. A lot of these patients, like I said, would have PE, and premature ejaculation must be asked for. And if they have it, it would be a good idea to combine tadalafil with depoxetin. In some studies, if the patient especially has low testosterone levels, right, or low normal testosterone level, it would be a good idea to consider adding testosterone. We typically use a testosterone gel, which is given daily.
2 more minutes.
Sure. Though slightly more expensive, it is very, very effective in a lot of these patients. Again, a lot of patients say, I'm taking sildenafil, but it doesn't work. It can lead to, how do you deal with PDE5 failure? Few questions you have to ask. Is it a genuine product? A lot of the time, PDE5 inhibitors are fake products available in the market. A lot of these patients don't get it through a proper pharmacy. This is an important tip. Please beware, check the product which the patient is taking. The timing of the medication, like I said, 1 hour after a fatty meal. And, sometimes the dose is not adequate. So giving a higher dose is very effective. Daily, if the patient is not responding to intermittent dosing, a daily tadalafil of 2.5 to 5 mg or even 10 mg can be beneficial to your patients. Other drugs like epomorphine, cabergoline, and doxazosine, we already discussed this. These are all available in India and can be administered. Just a few slides here. Remember, erectile dysfunction is the window to your endothelium. Please mark these words. Presence of ED increases the patient's risk of having a cardiovascular disease. There is something known as the arterial size hypothesis. We'll not go into too much detail, but you can look at this reference over here for more details. And ED as a risk of myocardial infarction, it has 50% sensitivity for predicting the first episode of an acute MI. Again, ED may be linked with smoking and dyslipidemia, which are other risk factors for cardiovascular disease as well. So I'll just summarize with some important take-home messages. First of all, you need to initiate the conversation from your side. Check the patient's preferences before prescribing the PDE5 inhibitor. If the patient needs an on-demand system, give vardenafil. If the patient wants, to have a natural erection, you can give a daily tadalafil, which is very effective. You can consider escalating the dose of PDE5 inhibitor if required. A lot of these doctors don't do this. They start with one dose and stick to that dose, and it may not be enough. Check the timing of medication. Preferably give it 1 hour after a fatty meal. And ED, remember, is a window to your endothelial function, and presence of ED suggests a poor endothelial function and perhaps increased risk of diabetic macrovascular complications also. So I thank you again, and I hope you stay safe. And these are my details. You can visit me and you can follow me on Twitter, and we can discuss this if any questions are there. Thank you.
Thank you, Lakani. Now we are coming to the end of the relevant issues by the last topic, a brief overview of gastroparesis by Dr. Purvi Chawla. I think she's come, yeah. And she's the Director, Clinical Research, Lina Diabetes Care Center in Mumbai, and co-investigator, National and Global Clinical Trials, BSES Municipal General Hospital, industry consultant in clinical development programs, patient education programs, and diabetes educator and training programs, leader in diabetes and metabolic disorders, Pyramid Enterprises Limited, and expertise in clinical and regulatory affairs for global early phase trials. Please, you can take on, Chawla.
Thank you so much, first of all, Dr. GVK, for this kind invitation to share screen with such an elite panel. And thank you, Chairperson, for the kind introduction. Without much ado, let me dive into a brief overview of diabetic gastroparesis. Just give me a second. To describe it, it's a chronic disorder characterized by impaired gastric emptying and altered motility of the upper GI tract, often symptomatic even in the absence of any mechanical obstruction. Even though it was first described in 1925 by Boas, a formal gastroparesis diabeticorum, a term was given by Cassander and all in as late as 1958 to describe this asymptomatic gastric retention in diabetes patients. There may be many other causes of gastroparesis as well, which we will go into a little later. But largely, it's been a complication that has been under explored or under talked about just because our understanding of it was very limited and we did not have many therapeutic options for the same except symptomatic relief. So magnitude of the problem, most of the patients with gastroparesis, if you look into their history, they do have either type 1 or type 2 diabetes. And yes, there is a heterogeneous group with no known factors for the same. In fact, a large study from the US reported almost 30% of the gastroparetic patients as having diabetes, 13% developing these symptoms after gastric surgery, while almost 30-35% were idiopathic in origin. Long-standing diabetes and hyperglycemia with autonomic neuropathy predict the development of this. It has a female preponderance, and the average age of onset is about 34 years, which is quite young. Overall, the US alone reports 5 million patients suffering from diabetic gastroparesis, which is a huge problem. So overall, it is associated with higher morbidity, including increased rate of hospitalization visits to the emergency rooms, and there was a 138% increase in gastroparetic admissions to the hospitals in a span of 10 years noted few years ago. So what happens clinically is the patient complains of early satiation, nausea, vomiting, that indigestion feeling, postprandial fullness, abdominal pain, heartburn, anorexia, and then systemic effects like weight loss and nutritional deficiencies. It may be associated with other symptoms of autonomic neuropathy as well, from long-standing poorly controlled type 1 or type 2 diabetes. In fact, overall, it results in poor nutritional status, dehydration, and even poor glycemic control in patients of diabetes, resulting into frequent hospitalizations, other complications, often refractory to therapy, and then overall poor quality of life and even economic burden. So to understand what really happens, just a quick reminder on the structure of the stomach. There's the esophagus leading into the main stomach. Uh, uh, on the anterior portion, we have the fundus, and then the cardia, and then the main J-shaped body or curvature of the J-shaped curved stomach. And then the pylorus consisting of the broader pyloric antrum leading to a narrower pyloric canal guarded by this pyloric sphincter going into the duodenum. Various muscular layers are also described here. And let me walk you through the pathophysiology. So even though there is heterogeneity in the different patients of gastroparesis, we do understand partly why this happens. But to understand that, let me just tell you what happens in the normal stomach. So the food reaching the gastric cavity is liquefied, fragmented, and then turned into a homogeneous mixture of smaller particles which transit into the duodenum. But before the transit into the duodenum, they are stored in the fundus by gastric accommodation, which is modulated by the vagus nerve. Gastric antral contractions are modulated by the vagal fibers as well as the intrinsic cholinergic neurons, whereas the nitrogic neurons modulate the relaxation of the pyloric sphincter and the peristaltic activity. The pacemaker stimulation and inhibition is mediated by interstitial cells of Kajal located in the smooth muscle cells and other fibroblast-like cells called telocytes. And then this entire coordination results in the food moving from the proximal portion of the stomach in towards the pylorus and then transiting into the duodenum. So what happens in diabetic gastroparesis is there is intrinsic neuropathy with reduced nitrogic inhibitory neurons and interstitial cells of Kajal as compared to the normal stomach. And there is an accompanying component of inflammation which initially protects and then adds to the problem. So these abnormalities collectively cause impairment in the gastric emptying and decreased coordination of the entire peristaltic activity, leading to pyloric dysfunction and further leading to gastroparesis. Other causes of delayed gastric emptying include abnormal small bowel motility, acute hyperglycemia or opioid use, viral infections, systemic problems like scleroderma or degenerative diseases, amyloidosis, and other visceral myopathies also. In fact, studies have shown that there may not be change in gastric emptying in patients with diabetes, but delayed emptying definitely is improved when glycemic control is improved. This is again a diagram just to show that there is a gastroglycemic vicious cycle, whether it's acute or chronic hyperglycemia, they both lead to delayed gastric emptying through various mechanisms that I just described. And this further leads to altered nutrient absorption and insulin secretion, leading to further glycemic variability and further causing hyper and hypoglycemia. So this whole cycle just continues. There are various mechanisms, but most prominent are, besides this component of autonomic neuropathy, there are other hormonal defects as well. And this is mediated by cholecystokinin from the proximal small bowel, peptide YY, GLP-1, etc., and amylin from the pancreas. There's also other inflammatory mechanisms involved in diabetic gastroparesis. And this is again a cartoon just to show you that there are several, because of this difference between a healthy and a gastroparetic stomach, there are several other upper gastrointestinal symptoms reported by the patients. So clinical history obviously includes a thorough symptomatic evaluation, and then we should also suspect it when endoscopic procedures are done and you find undigested food in the stomach. We should suspect paresis as well, or at least delayed gastric emptying, even if we don't call it paresis. We need to rule out other organic diseases like diabetes, connective tissue diseases, myopathies, and even surgical history of major abdominal and thoracic surgeries causing damage to the vagus nerve. Procedures like cardiac ablation, mesenteric revascularization, and celiac plexus blockage need to be carefully considered as well. Presence of constipation and defecation disorders and autonomic and other symptoms leading us to think that the patient has autonomic neuropathy are also very important to take note of. And there may be systemic symptoms like loss in body weight, vitamin deficiencies, and just psychological disturbances as well. Conditions that can provoke gastroparesis include diabetes as the top condition. Many procedures, post-surgical procedures like vagotomies or gastrectomy or even Roux-en-Y gastric bypass, connective tissue disorders, hypothyroidism, end-stage renal disease, so on and so forth. Drugs that can cause gastric delaying again are an important class, and if you notice, some of these are actually medications we use to give symptomatic relief to the patients, like proton pump inhibitors, sucralfate, tricyclic antidepressants, and so on. Opioid-induced gastroparesis is special because it is typical when patients use these agonists like oxycodone and tapentadol, and they interfere with gastric and intestinal motility. They slow the gastric transit and may induce vomiting even through the central mechanism. So this is slightly different and needs to be understood better. As far as symptomatic evaluation is concerned, mild, moderate, and severe were described by a group led by Wasim and all, and severe being gastroparesis with not responding to medical treatment, and in addition to the symptoms reported by the patient, there may be presence of malnutrition, weight loss, and requirement of more frequent medical attention to these patients. Again, there is a gastroparesis cardinal symptom index or GCSI, which is an easy tool to assess symptom severity based on several grouping of common symptoms like nausea, vomiting, postprandial fullness.
Dr. Purvi, 2 more minutes are there.
Okay. So which leads us to the understanding of the therapeutic management. Symptom control is absolutely necessary with correction of nutritional deficiencies and maintenance of optimal weight. We must identify the causes of delayed gastric emptying when possible. Acceleration or normalization of gastric emptying may not improve the symptoms, even though delayed gastric emptying is a hallmark of gastroparesis. And dietary modification is very important. Pharmacological management with prokinetic, antiemetic, and psychotropic agents, endoscopy, electrical stimulation, and surgery are other options as well. Glycemic control is of paramount importance, but the use of oral agents may be limited. Of course, GLP-1 analogs are completely contraindicated in this case, or not. They may exacerbate the symptoms and should not be used. DPP-4 inhibitors may be used with limited use. Even metformin may not be used. Insulin is probably the answer in patients with severe gastroparesis. And again, small frequent meals are very, very important. So with that, mild, moderate, and severe gastroparesis comes with a good guidance on how to treat. Diet and nutritional support is required in each and every step. Prokinetic agents may be used for more moderate and severe cases, antiemetics and symptom modulators also, and the surgical options or endoscopic techniques are reserved for the more severe variety of gastroparesis. Nutritional important, I just want to highlight that small multiple meals through the day with limited fat and fiber intake is extremely important in these patients, with adequate supplementation of vitamins and other nutrients. Alcohol and smoking should be avoided. Amongst the pharmacological options I mentioned earlier, metoclopramide used to be the only approved agent for the treatment of gastroparesis since 1979, but its use was limited with the development of tardive dyskinesia as an important adverse effect. And hence, domperidone, again, a dopamine receptor agonist, is a very good option to treat gastroparesis in our patients. Again, motilin agonists like erythromycin, azithromycin can also be used. There are several other agents which I'm not going into the details of. But I just want to just highlight two surgical or endoscopic procedures which are used commonly. One is the botulinum toxin injections. These are used for patients.
Doctor, we're already out of time.
I'm just getting done. So this toxin injection in the Botox injection in the pylorus may relieve the spasm and give symptomatic relief. Transpyloric stenting, balloon dilatation of the pylorus. But the most important is the gastric per oral endoscopic myotomy or GPOM procedure, which is very popular for severe gastroparesis. And it's a modified procedure based on the earlier success of the procedure in esophageal achalasia. And here we've got promising results, and even refractory cases have responded to this therapy. So that's important. So with that, thank you very much for a kind and patient hearing, and I'll be happy to participate in the discussion. Thank you so much once again.
Thank you all the speakers, but unfortunately for void of time, I think we may not be able to take questions for this session. We are really sorry.
Yeah, we'll go to the next session. We'll go to the next. We will go to the next session.
Hello. Yeah. We will go to the next very important session. We have 3 plenary lectures by eminent speakers of the country. To chair the session, we have Dr. Sanjay Reddy, a senior diabetologist from Bangalore, and he's got a lot of experience in research and as well as teaching. He's also a great organizer. You can see that most of the programs that are done in Bangalore and other places, he's a great organizer, I would say that. Dr. Sanjay is a good friend of mine as well. And I have one more friend of mine, Dr. A. Natarajan. He's a senior diabetologist and family physician from Chennai in a place called Annanagar. He is a very good speaker and very knowledgeable person. He's part and parcel of all our endeavors in imparting education from our side. He's an important member of our organizing committee. Please, sir, take over.
Okay. Good afternoon, Dr. Vijay Kumar. Thank you very much for those kind words. It's always a pleasure spending time with you. And at the outset, I thank 3DCon organizers for giving me an opportunity, and my co-chair, Dr. Natarajan, to be chairing this session. For the first talk today, we have, do pathophysiological therapy really affect the natural history of diabetes? To speak on the topic, we have none other than Dr. Sabu. Dr. Bansi Sabu is a good friend, president of the RSSTI, the most dynamic till date I have seen so far. He's chief diabetologist and chairman of Diabetes Care and Hormone Ahmedabad. He's been board of many organizations. He's also an advisory board member at JAPI. He has more than 47 publications to his credit. Over to Dr. Bansi for the talk. Over to you, sir.
First of all, thanks, Dr. Sanjay, for very kind introduction. Thank you, Dr. G. Vijay Kumar. I'm sorry, actually, I can start my video, but I don't know it is showing that my internet is unstable. So in between, I may stop my video, but my audio will be continued. Thanks, Dr. Kandula Sai and Dr. Natarajan. And once again, thanks, Dr. G. Vijay Kumar, for giving me this opportunity. I'm just sharing my screen and then I'm starting. This topic given to me was very, very interesting. When I was thinking what I should talk on it, and then when I was seeing the literature, then I thought a full day conference can be done on this topic. So once again, thanks and congratulations, Dr. G. Vijay Kumar, for a fantastic topic which you had given to me when I was preparing for it. And I think I will not able to complete the things because I had written agenda in a very big way, but then I thought that in 20 minutes I may not able to complete, but still I would like to talk few things. So I have taken my maximum slides on this particular topic by one of the paper, which is by Dr. John Buse and his team, Dr. Lawrence, Robert, and Stephen Khan, that we can change the natural history of type 2 diabetes. And the topic given to me that do pathophysiological therapy really affect the natural history of diabetes? So we all know about that diabetes, a global emergency. This is IDF 2019 IDF Atlas, and we all know that how diabetes is increasing all over the world. But this very important paper of UK PDS had shown that it is over a period of time, whatever best we do, the beta cell get declined, beta cell function get declined as type 2 diabetes get progress. Even at the time of diagnosis itself, beta cell function is already reduced by 50%, and it continues to decline regardless of therapy. Even severe beta cell failure may require insulin for treating type 2 diabetic patient also. So this is what the natural history of diabetes, and this happens, and this has been long been in 1998 in UK PDS paper, this was described. But the natural history of diabetes, can it be changed? And we can change it from pre-diabetes to diabetes to the complication. This is the normal history. But if we start picking the patients at the level of pre-diabetes, that is what in this paper of we can change the natural history of type 2 diabetes in a diabetes care in 2014, we talk about that if we start treating the patients early and aggressive management itself can change the history of diabetes, and this natural history reflect the underlying loss of beta cell function. Then I will be talking whether we are treating by pathophysiological mechanism, will it change the history of that or not. The early diagnosis is the very, very important. The foremost aspect of diabetes care is timely diagnosis and early treatment. But most of the patients who are diagnosed little later, maybe 3 years, 5 years, they have already complication. So that when we want to change the natural history, the early detection and early treatment is very, very important part of it. So early detection of diabetes, not only diabetes, even pre-diabetes. It provides an adequate treatment to reduce the burden of diabetes and its complication. Failure to achieve an A1C of less than 6.5 within first year after diabetes diagnosis itself is sufficient to establish an irremediable long-term future risk of macrovascular complication and mortality. So you can understand how important it is that we have to achieve a early and aggressive tight control. If we are not able to do that in even 1 year, there is a data, those patients who could achieve early and aggressive control in first year and those who could not achieve in that first year, there is a significant difference between the complication rate, morbidity and mortality in both the groups. Patient with long-standing diabetes, they develop complication despite excellent control. Later in the course of their disease, probably they are late diagnosed, or maybe in early course of the diagnosis of diabetes, their disease was not diagnosed also. So this early intensive therapy generates legacy effect. And this legacy effect, again from the UK PDS paper in Lancet 1998, which had shown those patients who have early and aggressive control, they have lifelong, they had enjoyed this legacy effect to have less and less complication as far as macrovascular complication. Even there was a 13% risk reduction of all-cause mortality also. But at the same time, not intensifying early may also generate a bad glycemic legacy. So one side, we are talking of a legacy effect of a early and aggressive control, but at the same time, in this VADT paper, they had talked about all those patients who were not having good control in last 10 to 15 years, had a bad glycemic legacy. And this legacy will also continue, and it drives risk of complication throughout the lifetime also. And rather, it takes long time to undo a bad legacy. So somebody who was having uncontrolled diabetes in his first 10 years, and now if you are seeing that patient, even you do best of best, whatever best we do for that patient is still to undo that bad legacy, it is very, very difficult. In VADT, the benefit of intensification was visible at later year, after 10 years of follow-up, but not at the earlier stage. So, I mean, if you see the same patients in the first 2 years, even with the intensive control, there was no benefit, and the benefit was seen after even 5 years or 10 years of follow-up, not at the earlier stage. And that is what undo a bad legacy is also very, very difficult. This may be because of intensification was not done early. Intensive treatment might have taken time to undo the bad legacy part of it. The pathogenesis of type 2 diabetes and its implication for therapy. Effective treatment of type 2 diabetes requires multiple drugs. I mean, it is as per pathophysiological defect. All those trials which I had shown is a early and aggressive control by whatever method they have done. They had shown some benefit in UKPDS. There was a legacy effect. There was a bad legacy was also there, those patients who could not get a good control. But these multiple drugs used in combination to correct multiple pathophysiological defects will able to get a tighter glycemic control. Treatment should be based on known pathogenic mechanism, not simply on reduction of A1C. We should not just wait for A1C to get reduced. Our primary aim should be to take care of multiple pathogenic abnormalities. Therapies must be started early in the natural history of type 2 diabetes to prevent progressive beta cell failure. So therapy must be started as early as possible, even somebody even at the stage of pre-diabetes, to prevent the progressive beta cell failure. And that is what the natural history of type 2 diabetes can be changed. So this is what the Omnius octet. I am sure all of you must have seen this slide 1,000 times since 2009 when DiFronzo had published this slide in diabetes. And a hyperglycemia is just not because of simple defect like a beta cell failure or insulin resistance. There are multiple pathophysiological defects which are responsible for a type 2 diabetes. And over a period of time, in last decade, now we have multiple medications which are available to us, and we can take care of these multiple pathophysiological defects. So if we treat the diabetic patients by treating different pathophysiological defects in combination from earlier stage of the diabetes, can we change the natural history of type 2 diabetes? That's the question. So no single anti-diabetic agent can correct all pathophysiological disturbance which are present in type 2 diabetes. And that's the reason we need multiple agents which you are to be used in combination, and they will be required for optimal glycemic control. Newly diagnosed type 2 diabetic patients who have more than 8 HbA1c, already a single agent is unlikely to achieve A1C goal of less than 6.5 or 7. That is already known. And now many of the guidelines is already talking those patients who have A1C of more than 8.5, you start with the combination. But then we have a verified trial which had talked about even at the time of diagnosis, the A1C was not more than 7.5. These patients also started with a combination therapy also. So by one drug, virtually no patient will able to get a control of A1C less than 6 if you are diagnosing the patient with A1C of more than 7.5 or even 8. So most patients with A1C of around 8 or 8.5, they will require a combination to reach a target of less than 6.5. And as per DiFronzo, we should try to achieve a A1C as normal as possible. That is the only way by which we can really change the natural course of type 2 diabetes. With maximal dose of any drug, whether you talk of DPP-4, SGLT2, glitazone, metformin, they can be used as a monotherapy. Still, you will not able to achieve a target A1C of less than 6.5, or only 1/3 of the patient will able to achieve that. We tend to advise combination therapy when A1C level are typically high, and this is really very difficult. This is because of either clinical inertia or whatever which we are learning over the period of time. What we understood, when patient is having A1C more, I mean, then we follow the patient and we try to use the combination of the drug, and most of the time these patients remain around 7.5 or 8. We are not able to achieve a tighter glycemic control. And even this is the one of the paper where it had shown that in India the average A1C when further escalation of therapy is done is around A1C of 8.6. So this stepwise strategy which we use to achieve a target is actually we are moving around 8 A1C. We are not moving around 7 A1C. And that is also one of the important reasons, not only for this bad glycemic legacy which we have, but a lot of micro and macrovascular complication. And then we can't just change the natural history, because all these diabetic patients develop the complication over a period of time. In reality, actually in a traditional management design, at the time of diagnosis itself, we have 50% of patients already have complication. 50% of beta cell function is already been lost. So it means at the time of diagnosis itself, we are very, very late. We are just not, its diagnosis is just done. It is already late. 2/3 of patients do not achieve target A1C, even whatever the current management which we are giving to them. Majority of them require multiple medication to achieve glycemic goal if we want to have. We all know that risk of complication increases with A1C high. Individuals with high baseline value require particularly urgent and intensive treatment, and monotherapy is insufficient in these individuals. And a combination therapy, which is a pathophysiological approach, as per the pathophysiological different defects, we should initiate this therapy as early as possible. This is one of the interesting trial which has been again published in the same paper. Actually, they were talking about the prevention trial. The patients who were in the DREAM study, they had shown that cumulative diabetes incidence in the DREAM study where subjects with pre-diabetes were given rosiglitazone or placebo. So those patients who were given the glitazone for prevention of diabetes, you can see even after once they have developed the diabetes, still that benefit remained with them in compared to the patients who were not given the therapy and they were on they developed the diabetes. So, I mean, the patients who were started with a dietary modification along with a pharmacotherapy for a prevention of diabetes, and same thing was there in one more study of docking study which had shown subjects with pre-diabetes who were randomized to receive instruction for diet and exercise as a control subject, and they were getting benefit throughout the lifetime. Even for next 20 years, the benefit was sustained in compared to the patients who developed the diabetes and they were as a control subject, they were not on a diet or exercise modification. So the point is, even not before the diagnosis of diabetes, even at the stage of pre-diabetes, the benefit was sustained over a period of time, those patients who were in the intervention arm. So the potential advantage of combination therapy, a early achievement of therapeutic goal, potential reduction of risk of side effects if you combine drug at lower doses versus up titration of single dose, opportunity to combine oral anti-diabetic agent with complement modes of action, and potential to delay disease progression also. So the modern approach should be a very early and aggressive management if we want to really change the future of diabetes, if we want to change how the diabetic patients will have less and less complication. And the modern approach can be that then aggressive diet and exercise control, and this benefit should remain lifelong. It's not like that we should enjoy the only legacy effect. This should become flat only. They should not develop complication, and that is what the natural history of type 2 diabetes can be changed as far as the complications are concerned. As we know that a type 2 diabetic patients have a two major problem. One is, the first is a insulin resistance, followed by a first phase of insulin secretion which goes away. So a defective insulin secretion is responsible, and what we had seen in a reversal of diabetes. So that is what the natural history can be completely changed. Even the patients with a duration of diabetes of less than 5 years and who are comparatively overweight and obese person, so that means they have higher insulin resistance. If we just correct their positive calorie balance, even type 2 diabetes can take U-turn. It can be reversed also. So the complete natural history of type 2 diabetes can be reversed, or it can be changed if we understand the primary pathophysiological defect in diabetes. And in obese diabetic patients, what the primary defect is, it is the positive calorie balance which is responsible for them to become diabetes. And if we just take care of that part, problem can be reversed also. That is what. And the same way, that one of the novel subgroup of adult onset diabetes, now type 2 diabetes, is not just a single disease. It's actually a cluster of 4 different type of disease. There is a moderately become diabetic patients who are in their age of more than 60, or there are patients because of obesity they develop diabetes. So I think the therapy for these patients, the person with these 22%, if primary problem for them to develop diabetes is obesity, if we take this cluster and we treat the obesity primarily or giving them a low calorie diet, I think the natural history of type 2 diabetes for these patients will be completely changed. Similarly, the patient who are SID, the therapy for these patients will be insulin therapy. The patients who are in this 20% who have severe insulin resistance, if we treat them, their insulin resistance by good amount of exercise, by giving them a metformin or the glitazone, probably their natural course of type 2 diabetes will be also changed. The similar cluster was also done by V. Mohan and group, and they found almost same, except there is a one new unique cluster which was found more in India, which was combined insulin resistance along with deficient diabetes, and these are the patients should be treated as per what type of cluster they have. So this is the primary pathophysiological defect in these patients, and if you treat these patients by giving proper therapy, like patient with insulin deficient, it is insulin. The patients who need sulfonylurea, when patient with highly insulin resistant, is insulin sensitizer, or the patient who are with MARD or SIRD, use of these medicines are also very useful in many of these patients. But one thing which was again different after Steno-2 trial. Steno-2 trial had shown it is the aggressive control. By whatever way which you do, still it reduces the complication. So the natural history, we don't know about that Steno-2 trial, but it had shown that if you treat these patients, it is the complication rate in type 2 diabetic patient can be significantly reduced. And in that particular case, also they talked more again cholesterol rather than A1C. It's not only the A1C which is responsible, it is the multifactorial management of type 2 diabetes which is more important as far as complications are concerned. But the natural history of type 2 diabetes, whether it will change or not, we don't know with the different glucose lowering agent, but definitely by intensive glucose control, we can reduce the complication rate if we can achieve the target A1C as early as possible, and without getting hypoglycemia, the patients will have less and less complication. So the appropriate glycemic control must be set for the individual patient, and only then one can decide up to path to follow. This is very interesting. Somebody asked that, would you tell me please which way I ought to go from here? That depends a good deal on where you want to get to, said the kid. I don't much care where do I. So then it does not matter which way you go. So if your patient or if your clinician does not know that where we have to go, then it will not make any difference what you are giving them. But if you know that where the target is, what exactly we want to achieve in our patient, then probably it will make difference by giving them a proper medication which is as per their pathophysiological defects, and to achieve a target glycemic control, then we can reduce a lot of complication in our type 2 diabetic patients, and their future of diabetes or life for diabetes will be completely changed. Effective treatment of type 2 diabetes require multiple drugs used in combination to correct multiple pathophysiological defects. Early initiation of combination therapy has been proposed as an approach to delay the deterioration of glycemic control with possible better preservation of beta cell function early on the disease. So this is very important, and this will probably preserve the beta cell for a longer period of time. It will change the future of diabetic patients. Current guidelines also do recommend start early combination as early as possible. The combination therapy approach offers optimal glycemic control with least incidence of hypoglycemia and with weight loss. Conclusion, we believe that we are at time that we can change the natural history of type 2 diabetes. This is important, that at this point of time, probably we can change the natural history, but after 10 years, probably, or 15 years, we will able to see a lot of data that could we change the natural history of type 2 diabetes or not. Doing so should benefit the health of millions of patients and might also benefit healthcare system by reducing the resource use as well as cost. With this, I thank once again, thanks Dr. G. Vijay Kumar for giving me an opportunity, and thank you everyone. Thank you.
Thank you, Dr. Bans. That was lovely enumerated on the importance of early diagnosis, aggressive treatment, addressing multiple drugs, addressing aggressively. Now I open the question forum for any questions, 1 or 2 questions before we move on to the next topic. I don't see any questions coming in, but I understand you and me share the same logic in trying to be aggressive, and we've discussed this in the past. But how far we are from getting to this?
Yes. Thank you, Sanjay.
Thank you. May we
Thank
move
you.
on to the next talk, please?
Thank you. Thanks for, thank you, Dr. Sabu, for doing the topic extremely well, that too in time. Thank you so much. We'll move on to the next topic without wasting much time. The topic is the carb confusion. Are Indian diets really bad? To talk about that, we have none other than Dr. V. Mohan, who is the chairperson in Dr. Mohan's Diabetic Specialty Center and President Madras Diabetic Research. And he is, we all know that he's a senior diabetologist and the leader and he's confirmed FRCP London, and he received over 180 awards, and also he has received Dr. B.C. Roy National Award and Dr. Ambedkar Centenary Award, and recently he has been received the National Award of Padma Shri as well. Now, without wasting much time, we'll move on to Dr. V. Mohan. Over to Dr. Mohan.
Sir, unmute, sir. Please unmute. Sir, please unmute, sir. Ah, yeah.
Okay, they had muted me. That's why. Okay, let me try to share my screen. Can you see it now?
Yes, sir.
Okay. So I'd like to thank Dr. Vijay Kumar for organizing yet another wonderful conference. We know that year on year, he does these really marvelous conferences, which are not only clinically based, give a lot of clinical wisdom, but also bring in a lot of science. He always manages to keep to time and also to select some of the best speakers in the country and abroad. So congratulations, Vijay Kumar. I'm always proud to see the great work that you do. Thank you also to Dr. Natarajan for the kind words of introduction. I'm going to talk to you on the subject of are carbohydrates linked to type 2 diabetes epidemic in India. Although it was said about Indian diets, I'm not just making this a diet talk, but I'm trying to answer the question whether carbohydrates are one of the reasons for the diabetes epidemic in India. To formally thank Dr. Vijay Kumar and the scientific committee program, all the names listed here. So this is the structure of my talk. I'll talk about the increasing prevalence of diabetes. And Chennai and Delhi are two cities in India where we have almost every 5 to 10 years some prevalence study or the other going on. And we believe that at least in southern India, it is rice, and in northern India, it may be wheat, and therefore carbohydrate playing a role. And so the next topic is carbs in relation to this increasing prevalence of diabetes. We now have new data on incidence of diabetes. Prevalence is always good, but there are a lot of confounders when you do a prevalence study. If you do a cross-section study now, you will pick up all those who are alive. What about those who died? You don't pick them up. Whereas when you do a prospective study, you get those who were living, those who died, you get their information, you get everything. And therefore, in terms of the hierarchy of science, the incidence study will come right on top as far as the epidemiological studies is concerned. I'll also try to tell you that not all carbs are bad. So there are good carbs and bad carbs. It's not that carbohydrate is a big villain. We need carbohydrate in our diet. And then talk a little bit about brown rice because we're talking about rice. So what about brown rice? Now, first, let's talk about the prevalence of diabetes. Now, these are studies done in different parts of the country, and you can see from over a period of time, the prevalence of diabetes from the time I started with my father in 1972, when Professor Ahuja published the ICMR study and showed that in cities of India, the prevalence of diabetes is 2%, and in rural areas around 1.5%. A lot has changed. So the diabetes prevalence has kept increasing, initially in single digits and then into double digits. And now we are entering to figures more than 20%. In fact, just I think tomorrow, I think our latest paper will be published in Diabetologia, where we are doing mathematical modeling to see what will be the rate of diabetes in urban metropolitan India using lifetime statistics, looking at how obesity rates will change and how the population will change and so on. And it's very frightening. I'm not showing you the data now. I think tomorrow it will be published in Diabetologia. The press release has already gone from Diabetologia. But the figures are very, very frightening. So even if you take these figures, the latest ones published from the CARS study. Now, CARS is a epidemiological study. It's not a house-to-house. It's not a hospital-based study. And there in Chennai, the prevalence is 23%. In Delhi, it was even higher, 25%. So almost a 10-fold, 11-fold, 12-fold increase in prevalence of diabetes over 40, 50-year period is very, very worrying. Now, these, of course, translate into huge numbers of people with diabetes, almost 73 million in 2017. Now we're close to 80 million, and this is set to increase to more than 100 million in the years to come. Question is, what has diet to do with all this? And is this at least partly driven by diet? Diabetes, just now, Dr. Banshi Sabu showed you 8 defects in diabetes. Obviously, 8 defects are not going to come due to one diet factor. Anything in diabetes, if you say it's due to one thing, you'll be wrong. Chances are that you'll be wrong because diabetes is a multifactorial thing. So in relation to that, what is the carbohydrate intake and its relevance to diabetes? And I must admit, because it is absolutely true that it was my guru, Satya Sai Baba, who told me about this. In an interview, he asked me, until then I had not done any work on carbohydrate, I had not done any work on diet. I had taken collected all the data, but my focus is on genes and something else and physical activity. I had not really looked into diet. So in one of the interviews, he asked me, doctor, why is diabetes increasing in South India? He asked me. So I thought it's genes, and I said something, and he said, no, it is rice. It is excess rice which is translating, and he gave the full mechanism. In fact, he said when you take more rice, what happens is that your the glucose levels go up. With that, you're putting more demand on the beta cells. Then the insulin is getting pulled out, and eventually the insulin levels go down, and then you develop diabetes. A very simple mechanism. You've got the data, Dr. Mohan. Why you're not looking into it? He asked me. Then only I thought, gosh, I haven't even looked at this. Then only we started studying, and this whole thing that we have done, the next 10 to 15 years of work came from that 2-minute discussion that Baba gave about 15 years ago. And that was what started us to take the study. So as you can see, I'm just showing you one more slide, showing that the prevalence of diabetes in Chennai, Delhi, how it went from 2% to 22%. Now, this is a study, since we had the data, that the data which you just showed in the earlier slide includes the CURE study, where the prevalence of diabetes increased. We also had detailed diet history regarding, so this is around the time he asked me. I think 2007 was when he asked me. Then we started our work in 2008. We got all the data and sent in 2009. It was published in British Journal of Nutrition. So I used to joke and say that the idea itself was only Baba, so he should be an author on this paper, and I wish I had the honor to have published a paper with him. So anyway, so this is the the study which we did, just looking at, suppose people in Chennai, and Chennai we had the best longitudinal as well as cross-sectional data. So we took Chennai as an example, and we said, suppose we divide Chennai into 4 quartiles. People who took the least carbohydrate, next. Will the diabetes prevalence go up? That was the question that we asked. And will there be any data that if you take more fiber and so on, the opposite will happen? So that is what we saw, and this is a very important paper published in British Journal of Nutrition. And as you can see, as you can see, if you look at the total carbohydrate, now we have divided the Chennai population into 4 quartiles: first quartile, second, third, and fourth. And if you look at the carbohydrate in relation to the diabetes prevalence, as the carbohydrate goes up, in the first quartile, we had people who take about 190, 200 grams of carbohydrate. In the maximum, the fourth quartile, we had people who are taking 400, 500 grams of carbohydrate. The diabetes prevalence went up 4.5-fold, which means what is 4.5-fold? Suppose the prevalence in this was 6%, it will become 25% in the same population when you take more rice. You may say it may not be rice, it may be obesity which is producing it. No, it is not, because we have adjusted for age, gender, BMI, family history of diabetes, cigarette smoking, alcohol, and all the other factors that we could possibly adjust for, we have adjusted, and still the carbohydrate intake is showing a steep rise in the prevalence of diabetes if you try to link the two. Now, if you look at glycemic index, glycemic load, all of them have the same. So it's not just the carbohydrate. We're able to show it's due to the glycemic load, which is there. And we've done detailed nutritional studies on this. Now, what about dietary fiber? If this is true, then if you take more fiber, you should see the opposite. And that's exactly what we found. Red is the fiber. Now, as you take more and more fiber, the prevalence of diabetes comes down to 0.31 is the odds ratio, which means there's a 69% reduction in the fourth quartile where people take the maximum dietary fiber. The diabetes prevalence goes down by 69%. So this is kind of a hypothesis generating thing. It still doesn't prove it because, as I said, cross-sectional studies have their limitation. There could be some other confounder which we are not looking for. From that time, of course, here we concluded that in urban South Indian total dietary carbohydrate and glycemic load are associated with increase in dietary fiber, decreased type 2 diabetes. Of course, we had many other studies coming from China, from Japan, all showing the same thing. Then started the proper epidemiological studies, following up the population for 5, 10, 15, 20 years. It's very difficult. You have to follow the same people in a population again and again for many, many years. And that is when we can calculate what's called as the incidence of diabetes. Now, in our incidence studies in cures also, we showed the same thing, that when you follow people for 10, 15 years in the cure study, they also develop incident diabetes. But the problem with studies like cures had 26,000 population, and we followed up about 2,000, 3,000 people for 10, 15 years. That's not enough. It's not powered enough. So then you need a much larger study. Luckily for us, from the beginning, I was involved in the prospective urban rural epidemiological study, or PURE, which is the largest epidemiological study ever done in the world, period. Not just for diabetes, but in the world. There's no study bigger than PURE because currently it has 250,000 people, 25 countries, followed for more than 15 to 20 years. And I'm part and parcel of the PURE study from the beginning. And this is, of course, the mastermind of Salim Yusuf. So I told Salim, you know what, I want to look at the rice and diabetes. In the whole PURE study, I'm the only diabetes investigator. So I said, I'll take this part. And Bavadarni Balaji, who was my PhD student, who later spent 2 years with Salim Yusuf, she was the first author. We were joint first authors, actually. Both of us joint first authors. So we looked at the rice intake and incident diabetes. And this is, remember, it's published in September 1st, 2020. By that time, Baba, unfortunately, was not there. But then his words saying that this is the cause rang true in my mind. So when we did this, we had 132,000 people followed up for about 10 to 15 years, 21 countries, and you can see the number of collaborators across the world. What did we find? Now, this is the rice intake in different parts of the world. If you look at South Asia, this is cooked rice, not uncooked rice. So cooked rice, if you see throughout the day, in South Asia, the mean intake, and South Asia included Pakistan, India, and Bangladesh, we had 630 grams per day is the amount of rice that we eat. Whereas in Southeast Asia, it is much less, 239 grams. In China, you can see that they've stopped eating rice. So a lot of Chinese have now changed to noodles. They've changed to other things. They're eating a lot of vegetables, a lot of protein. The Chinese are eating very healthy food now compared to South Asians. And then, of course, in other parts of the world, hardly any rice being taken. So we wanted to know whether this translates into new onset diabetes. Now, what do you mean by that? When we started the study, we had the entire dietary history of these people, and we took people who did not have diabetes in, say, 2000, and then followed them up to 2020 and saw who developed diabetes, and then went back to their original diet and saw where they're taking rice and did that contribute. And of course, every possible confounding factor has been corrected for. And you can see that in South Asia, where the maximum rice is taken, the hazards ratio is 1.61. What does it mean? There's a 61% increase in new onset type 2 diabetes in South Asia. And this parallels the increased rice intake that South Asia you have. Whereas in China, it was very modest, only 4% increase, because they're eating 1/3 of the amount of rice that South Asia is eating. And the rest of the world, if you put all together, Southeast Asia and all put together, there's still a 41% increase. And if you take the whole cohort together, put China and everyone together in the whole world, there's still a 20% increase. And that's what all were statistically significant. So we are able to prove through this that rice not only is associated with the prevalent type 2 diabetes, but also with new onset, new cases coming. That means you're getting new cases coming, especially in South India. This is largely related to the rice that we take. And this has been adjusted for every confounder, about 20 confounders we have adjusted for. Now, you may ask, what if you do exercise? Can you reduce that risk? In the same population, we looked at those who are physically inactive, and there the hazards ratio was 50, 1.5, which means 50% increased risk. Whereas if you're physically active, that risk came down to 1.16. That means there was a 34% reduction if you ate the same rice, but you were doing physical activity. You can see the statistical significance is gone. There is no unity here. It's going on both sides of the unity. And therefore, the message is that even if you eat rice, if you exercise vigorously, then you can still prevent diabetes. And this explains why the prevalence of diabetes was 2% in 1970s, when so much of physical activity was being done, manual labor was being done. Most people did not have cars. They traveled by foot or by bus. Today, when you have all these comfort and physical activity has gone down, this excess rice that you're taking is shown. So we concluded that higher consumption of white rice associated with an increased risk of type 2 diabetes, the strongest association being observed in South Asia, while in other regions it was modest. Now, what about places in India where rice is not taken? You may say, you're talking about rice. We don't even eat rice. You know, in Mumbai, Dr. Shashank will immediately say, we don't even eat rice here. You know, in Delhi, you know, Dr. Nikhil Tan will say, we don't even eat rice. So are you saying all our diabetes is due to the rice we take? That's where Shashank's paper comes in. And he showed in the START study that it doesn't matter where you are in India. You are eating carbohydrate in every place. For example, in the north, south, east, west, central, wherever he studied in India, the total carbohydrate was virtually the same. If anything, in south, it is little less, 64%. Central was 67%, west 61, north 63, and east 65. It's all in 60s. It's all between 61 to 65%. No difference. According to me, no difference in the carbohydrate intake. And carbohydrate in the north also, the wheat that you take is refined wheat. It is not the whole wheat grain that you used to use many years ago. So the same problem that we have with rice here, we are having with wheat. In fact, we have a paper, I think just published in the BMJ last week. Yes, it is published, where we looked at the refined grain versus non-refined grain. Sumati Swaminathan from, that's also from Pure. Sumati Swaminathan from St. John's was the first author. I'm also an author in that. And the main BMJ was published about 6-7 days ago, where we are showing that even in the places where rice is not consumed, the same thing happens. Whereas if you eat the coarse cereals, the diabetes prevalence is not at all high. So it depends on the type of carbohydrate that you take. And that brings me to the bad carbs versus the good carbs. So far, we talk about the quantity of carbohydrate. The quality is also important, and there are good carbs and bad carbs. The bad carbs are the highly polished white rice or the highly polished wheat or sweetened drinks, fruit juice, white bread, cookies, ice cream, candy, French fries, chocolate. All these are bad carbs. They contain a lot of calories. Whereas there are also good carbs. Remember, vegetables also contain some carbs. Whole fruits also contain carbohydrate. Don't take it as a juice. Legumes like kidney beans, peas, lentils, and all that, they are very, very good. Nuts, walnuts, almonds, hazelnuts, seeds, sunflower seeds, chia seeds, pumpkin seeds, and whole grain such as the brown rice or steel-cut oats, quinoa, all these, the unrefined wheat, all these are millets, unrefined millets, all these are good carbs. So carbs are not bad. The last is about brown rice. Do you have any evidence that actually if you change to brown rice or healthier variety of carbs, it is useful? I have at least 6 or 7 papers on that. I'm just showing you one of them, I think, where if you look at the glycemic responses of brown rice, white rice, and brown rice with legumes, we did continuous glucose monitoring, put people on this and looked at CGM. You can see the red is the white rice. You can see how much the postprandial the surges occur, whereas blue is brown rice, and the black is the brown rice plus legumes. If you add that also, the fiber also, you can see how much in the same day you can see the glucose levels going down. This is in non-diabetic people, and the insulin levels are also reduced, and the area under the curve is reduced. So a simple switch to a healthier type of carbs makes a huge difference. We now have population-based studies on this, where we looked at if you do a randomized control trial, this was done with the Harvard University, where we substituted brown rice with white rice and followed people up for 6 months over a feeding trial to see what happens. And what you can see that at least if you have metabolic risk factors, if you have metabolic syndrome, then there was a marked reduction in the HbA1c isocaloric. If you give them the same amount of white rice and brown rice, you can see that with the brown rice, there is a marked reduction in the A1C levels. So substituting brown rice, white rice showed potential benefit on A1C level. So I'm going to stop here, ladies and gentlemen, by saying that excess refined carbohydrates, white rice, we have now proven to be associated with increasing prevalence and incidence of type 2 diabetes. I think after the PURE study, nobody will even question what my guru taught me 15 years ago, that rice is one of the causes. I never doubted it in the beginning, but now increasingly this is getting confirmed by studies across both, and even in US there are studies showing that rice is associated, excess rice associated with diabetes. Changing from polished white rice to brown rice has beneficial effects, or my formula would be take about 40-50% carbohydrate, take 20% protein, and take good fats, 30 to 40%, along with plenty of green leafy vegetables and some fruit, and add physical activity. I showed you even in our rice paper that adding physical activity can reduce the risk of diabetes. So it can help to not only prevent type 2 diabetes, but can also help to reverse it and to keep the diabetes under control. So you don't have to go to keto diet. You don't have to go to zero carbohydrate diet. Carbohydrate is not a villain. It's only the amount which is important. It is not a poison that if you take, you will die and so on. But if you control it well, eat the right type of carbs, then you have a very healthy diet. So Indian diets, so the question given to me, are Indian diets healthy? Well, it's up to you. You can make it healthy or you can make it very unhealthy. It all depends on you. So you cannot blanket say all Indian diets are bad, all Indian diets are good. You have to choose, and that is our duty as diabetologists to teach our patients. So I will stop here. And if there are any, I'll be happy to take.
Thank you, Dr. Mohan, for your, as usual, excellent talk, thought-provoking. You discussed about the prevalence of diabetes, carb involving in prevalence of diabetes, and the glycemic index, glycemic load, and the fiber in that, and talked about good carbs, bad carbs, association of white rice, and association of refined wheat in the and how to change to a healthier diet. Thank you so much. It's open for question.
So one question, sir.
Yeah, go ahead.
Mohan sir, is now the glycemic index of millet is, when compared to rice, is less. And what about when compared to brown rice? Any studies has been done, sir?
Yes.
Because nowadays people are more, especially diabetics, are more fond of millets, especially the foxtail millet.
Yeah.
So any idea about your suggestion, sir?
Yeah, we have several publications on them. If you see our papers in British Journal of Nutrition and Asia Pacific Journal of Nutrition, we have a series of publications the last 2 years on millets. Unfortunately, what you said just now, that the glycemic index is lower, is not correct, because the millets are also polished. That's the whole problem. See, everybody goes by the thing. That way, if you see rice 40 years ago was very healthy. There's nothing wrong in it. Wheat was very healthy. All these very healthy. Millets are very healthy. Not today's millets. Today's millets are polished. I'll tell you why it is done. The reason why they keep on polishing this is, number one, to make it more attractive. When you see it, it looks very good. A white rice definitely looks better than a brown rice. Okay. Second is shelf life. It's a trader's trick that if you keep white rice, you can keep it for 1 year, 2 years. Brown rice stays only for 3 months. If they don't sell it, the whole stock is gone. So nobody wants to keep a product which is there only for 3 months. So therefore, you polish it, and keep. The problem is you're removing the phytonutrients, you're removing the B complex, you're removing the protein, you're removing the fiber, you're removing the entire part of it just to make it look nice. And for you to make more money, you are actually endangering the population. So if you want to take millets, you must go back to the original millets as they were prepared. Find it for me in the shops. It is not there, okay? Get me the brown rice. We introduced brown rice in Chennai. There was no brown rice. We went to Kanchipuram farmers, told them, don't mill the rice, give it to us. We will make it, and we kind of manufactured it and produced. It's not my job, but because it's not there in the market, we had to do it. So I think if we go back to the original millets, I have no doubt that it's very good. Having said that, the glycemic index of the millets today is maybe equal to white rice, but it's still nutritionally superior. Nutritionally, it has some other properties which it's almost equal to brown rice, I would say. So nutritionally, millets are still very good. And we are writing a big review article. I think it's a 50-page article on millets with some of the world experts in millets is under review now. We are writing it. So I'm very much deeply involved in millets research. And every aspect of nutrition, we are very deeply involved in it. But a lot needs to be done. It is not that, oh, just go millets, buy something from the market and take it. They are very high in glycemic load. Yes, Dr. Mohan.
I heard in a talk that if you take whatever vegetables you have on the plate, if you take it 15 minutes before your rice eating, it will decrease the amount of excursion. Will that help?
Naturally, not only vegetables, legumes. I showed you the CGM with the legumes. No, even more than the vegetables, the legumes. The legumes contain a lot of fiber, and it also contains protein. So if you add protein to the carb meal, you are bringing it down somewhat. So that you mentioned the plate concept. So the concept, what we have to teach our patients is very simple. When you take a plate, don't put your rice on it first time, say rice and sambar, rice and rasam, rice and curd, rice and thing, goes on like that. First, look for your vegetables. First half is vegetable. Then look for the protein. If you're a non-vegetarian, it's easy. You have fish, chicken, white of the egg. You've got so many choices. If you're a vegetarian, you have to really look, where is my protein? You will get it from lentils, beans, paneer. There are so many things, milk. There are so many things which will give you protein. See that you put protein on your plate, morning, afternoon, night. Now you come to the carbs. So by the time you have eaten this, you have very little rice, that even then it will be good and it will satiate you much better. So that principle, if you follow, the same white rice you're eating now also, you can take, nothing will happen. It is only when you want to eat more that you have to look for healthier varieties of rice. I would say instead of going and manufacturing all kinds of healthy, actually we have just signed an MOU with the Tamil Nadu Agricultural University where we're going to go do more work on millets and other, they've got about 2,000 varieties of rice. So we are going to again get into that and try to find whether there is that some, magic rice there, which is sitting there in the library, which may not even be grown, which we'll now start, as with an MOU with them, we are starting that. So we are constantly looking for new things but you don't have to wait for that. With what you have, you will eat healthy. Put more vegetables on your plate, put more protein on your plate, take a little bit of carbohydrate as you need. Don't cut that carbohydrate out. If you cut that carbohydrate out, you're losing a very important nutrient. There are a lot of amino acids, a lot of things in carbohydrate which are very important. So don't get rid of that. They're needed for your energy also. That is where I don't agree with the keto diet people and paleo diet people and all who say, that's a shortcut. You just cut that, you lose weight. That's very obvious. You cut off all the main thing that you eat, you are going to lose weight. How long? After 3 months, what are you going to do? Don't plan anything unless next 15 years you want to do it. Don't plan anything for 15 days or 15 months. Plan it for 15 years. If you can do that, then you do that. Ram Kumar?
Sir, good afternoon, sir. Nice lecture, sir. Sir, you might have heard about Roy Taylor's diabetes remission.
Yeah.
Why it is not popular in India and why didn't take it up much?
I don't think it's popular anywhere in the world, Ram Kumar. 800 calorie diet, if you put, that's a starvation diet. That's not only Roy Taylor who did it. If you go to Alan 100 years ago, 200 years ago, Jocelyn, they used to make people starve because there's no medicines for diabetes. Even insulin was not there. If you don't starve them, they'll die. So first thing they said, don't stop eating. Eat some little bit, 10% of what you eat, 20% of what you eat. So 800 calorie diet, if you are put on 800 calorie diet, how long you will take it, Ram Kumar? Forget about your patient and forget about everything. You are now put on an 800 calorie diet, okay? And now for the next 25 years, you take 800 calorie diet. Is it possible? So experimentally, you can do anything. You can put 800 calorie, you can make it even 200 calorie diet if you want. You can even starve. Gandhi even starved for 21 days. You can do all that. How long? What next?
But I think after getting remission, they switched over to normal diet. I think
then you will gain it back because it's not magic that once you do it, you've reversed it. You're not done pancreas transplant or islet cell transplant where, completely the rest of your life, even bariatric surgery comes back where they lose 35 kilos, 50 kilos, they lose. And then after 2 years, again, the diabetes is coming back. Because nature finds its way to come back. So these are not permanent solutions. If you're doing it for a purpose, you have to, I always say the joke, and I can see Shashank smiling. You are getting married and you've got 3 months time. You want to impress your wife or impress your husband and you want to lose some weight. You've got a motivation to do it. Go on not only 800 calories, 600, but then keep some for the honeymoon, keep some energy also. But then if you cut down the diet drastically like that, then you will lose weight and you can present yourself when you stand in the wedding reception, you can look very good. But I'll assure you that after the first pregnancy, that lady will again put on 10, 15 kilos after that, That time 800 calorie will work, you tell me.
Thank you.
Does diabetes go away? GDM will give 800 calories. I mean, it's good. At least there is proof
Yes,
that
sir.
it
Proof
is
that.
reversible. That way, the science part, I have no problem at all. It's very good. It's shown that reversal is possible. This whole idea about reversal of every Tom, Dick, and Harry, except the diabetologists, now can treat diabetes. Every quack in town now has a reversal diet, and so all that is great. We are the biggest fools in the world. We give insulin, they give tablet, alphenyl urea, killer drugs they are giving, SGLT2, killer drugs. All these diabetologists give. We give reversal. We are the big guys. And who is he? He's an engineer. He's some stupid guy who's got something and he's got some formula and he gives it and thing. Now, 1,000 people, 10,000 people he'll make, and he'll make 50 crores out of it, and then he'll form some other reverse cancer he'll start now after that, But we are stuck in the game. We can't be playing such games, and we are stuck in it and say the truth, So if it didn't work in China, I'll have to say it didn't work in China. I can't make it up and say in China also rice was associated. It's not. In China, it was not. They're eating only 200 grams. It is not. We are science people. So we can only talk science.
Thank you, sir.
Thank you,
Thank you, sir.
Dr.
Thank you.
Thank you, Dr. Mohan, for your excellent talk, thought-provoking. And I think we will move on to the next topic for want of time. The next topic is the current pandemic, COVID-19 and diabetes, before, during, and after. To talk about that, we have none other than one of the important warrior for the COVID-19, Dr. Shashank Joshi from Mumbai. He's the chairperson in the IDF Southeast Asia, president of Indian Academy of Diabetes, former president of Association of Physicians of India, involved in the activities of American Association of Clinical Endocrinology, and over to Dr. Shashank Joshi. He's been awarded with Dr. Padma Shri, one of the prestigious Indian award as well. Over to Dr. Shashank Joshi.
So, let me see now how to do this, because I am not very good at. Is my screen visible?
No, sir.
Yes, your screen is not yet.
Can you see my screen?
No, sir.
Not yet, sir. We can
So
see it.
to see this, and now I have to first unlock. One, two, three. Can you see my screen?
Yes.
Now, yes, sir. Now, yes. Now,
Yes.
See my screen now?
Yeah,
Yes,
now
yes.
you're able.
I don't know how
Good
to.
afternoon, Dr. Shashank.
Yeah, good afternoon. How are you? So
Fine.
at the outset, I must thank and congratulate Dr. G. Vijay Kumar for having COVID on board. I thought in COVID times we will be a de-COVID conference, but I think COVID is everywhere. And after this very nice talk by Dr. Professor Mohan, I think we are moving gears to COVID and diabetes, because if there is the single most important comorbidity of COVID, probably diabetes is going right up the pecking order. People thought initially it was hypertension. Obesity is a close competitor to diabetes. So I think that's where it stands. So I'm going to probably, I don't know how much time I have. Maybe I have 20-25 minutes, Dr. G. Vijay Kumar. I might exceed my time maybe by 5 or 7 minutes. And COVID changes every day. So some of the things which I say today may not hold appropriate later. And I'm just trying to negotiate my slides, and I'm not able to do that. So anyway, so what I speak today on COVID-19 and diabetes is on 22nd November 2020. And that's something which we all know we need to speak on, and we need to be there. And let's look at, we know that number 1 and number 2 for morbidity and mortality of COVID is clearly diabetes and obesity. And diabetes and COVID has a link. We know that there is very good epidemiological evidence to suggest that there is an association of diabetes with other infectious diseases. So we know that from that data. We know the rule of 10, that 10% of diabetics get tuberculosis, 10% of tuberculosis patients will have IgT or diabetes. So we have very good data, whether it's fungal infections, urinary tract infections, respiratory infections. Diabetics are more vulnerable to get infections in general because of a lower immune system. We also know, that is the second point, that in the bacteremic form of pneumonia, it's an independent risk factor for LRTI. And we also know that when it comes to serious infections in hospital setups, which is something which we all recognize better and we know better, clearly we know that 6% of infections related to hospitals and 12% of infections related to hospitals are linked to type 1 and type 2 diabetes. So that's something which we know very clearly. And then we got this large Chinese database to show very clearly that, hypertension was number 1, diabetes was number 2, and obesity was number 3. And that is what they showed: obesity, hypertension, and diabetes as a deadly trio. And this so-called trio clearly had data to show that diabetes and COVID was strongly linked. So what do we know today? What we know today about COVID and diabetes is people with diabetes have increased risk of infection because of innate immune defects, which is linked to elevated glucose. Both acute hyperglycemia and chronic hyperglycemia leads to blunting of innate immune system. The second fact which we know about diabetes is that when you have a diabetes state, it's a pro-inflammatory cytokine state, which means a normal diabetic also has exaggerated IL-1, IL-6, and TNF-alpha. The third point we know about diabetes physiologically is there is increased expression of H2 in diabetes. And the fourth thing which we know about diabetics is diabetics in general are more pro-coagulable, or they have increased coagulation activity and hypercoagulable. So obviously they have stickier blood, they have more coagulopathy, they have a lot of H2 expression, they have a lot of pro-inflammatory cytokines, and obviously they have a blunted innate immunity. That's what we know as of today. Clearly we know that the H2 has been linked as the docking receptor for COVID. COVID docks in our human body through the H2 pathway. Clearly that's now very well recognized. And when it docks on the H2 receptor, it triggers a serine protease called TMP-RSS2, okay, which is a transmembrane serine protease. And that will trigger the entry of the viral particle through furin inside every cell of our body. First being the lungs, second being the cardiac tissue, third being the renal tissue, fourth being the enterocytes, and fifth being pancreas. And there's very good data now, including human data, to show that lung is top on the pecking order, followed by probably the gut. Heart and kidney and pancreas are right up on the pecking order. So obviously H2 has a role. Clearly we now know that when we explore through various analysis, including a Mendelian random analysis, there is a direct expression of on a GWAS in type 2 diabetes on ACE expression. So we now know that when you look at a putative receptor of SARS-CoV-2, which is ACE2, clearly there is an increased expression in type 2 diabetics. So obviously, when you look at susceptibility to COVID and the predilection of COVID to develop severe complications, including a cytokine storm, including myocarditis, sudden death, ARDS, clearly it is all linked to various factors. Whether the SARS-CoV-2 will have an impaired neutrophilic response, which is seen in diabetics, whether it is linked to impaired interferons made by the natural killer cells, whether it is the improper antigen presentation by the dendritic cells or the CD4 cells, whether it is the impaired macrophage function, or whether it is the increased ACE2 expression. All these features which are listed on the slide are seen in diabetics. And therefore, diabetic presents a perfect culture medium for not only COVID infection, but more important than that is it prevents a perfect milieu for a COVID storm. And that's what COVID does. So obviously, COVID fundamentally has this big challenge. We also know that a lot of these conditions can destroy islets, because we know islets of Langerhans, as we celebrate a century of insulin discovery, have H2 receptor. And obviously, there is a ketosis prone flat blush diabetes described in COVID. So we also have an entity, distinct entity. You may not be diabetic, you may not have a predisposition to get diabetes, you may never had family history of diabetes, yet you will see a patient standing up in the hospital with frank COVID, moderate to severe, and you will get flat blush decay, frank decay. I've had an elderly patient right in the beginning of the pandemic, somewhere in the month of 4th of April, I got a senior citizen, 89 years old, glucose 555, never was a diabetic in his lifetime, never. And had mild TSH elevation for which I had not treated him. Had no family history of diabetes at 89 and was in frank diabetic ketoacidosis, not even a hyperosmolar state. Had a flat blush or a flash diabetes. This was a ketosis-prone diabetes and probably had a COVID pancreatopathy. So obviously there is data to show that, and that could lead to death. And that's why we know diabetics are up on the pecking order, and glucose predicts mortality. This is Bruce Board's study, which very clearly showed in the US hospitals, 88 US hospitals they analyzed, that people who had no diabetes, no hyperglycemia, mortality was 6.2%. Minute they had diabetes or high glucose, mortality was 28.8%. So clear data to show that glucose matters and it increases mortality by 4-fold. There's a direct endocrine link, as I told you. The link pathway is the MAS receptor pathway. And Stefan Borenstein showed this so nicely that the MAS receptor pathway is mainly linked to the angiotensin 1-7. This will lead to an anti-inflammatory, anti-fibrotic response, which allows recovery. And what happens? What happens is that in severe COVID and diabetes, there is the activation of these pathways, increase activation from 81 receptor to 82 receptor. And that switch which occurs actually is a very negative switch. And that negative endocrine switch actually makes things worse. Also, there's very good data which Bruce Board published this year to show that acute hyperglycemia is linked to COVID mortality. And just simple hyperglycemia can kill. So obviously diabetes has evidence to show that it will have more severe COVID, and that's something which we know. And let's summarize that high glucose predisposes to enhanced release of cytokines. There's greatly elevated levels of inflammatory cytokines leading to multi-organ failure. There's a metabolic inflammation. There's a compromised immune system which leads to impaired healing. And clearly we know there's dysglycemia and immune dysfunction. So diabetes, clearly IDF also stated this, that is a functional immunocompromised state, and it promotes, high glucose promotes viral replication. So obviously diabetes is a high risk for COVID-19 infection, and we all know this. We had developed an Indian COVID score. Any person above 55, male, gender, hypertension, diabetes, obesity, chronic heart disease, COPD, chronic kidney disease, any congenital or acquired immunodeficient state, any human being using steroid, immunosuppressant or transplant recipients are vulnerable for COVID in India. The 65 cut point may not be applicable. Our cut point is a little earlier. Male, gender, hypertension, diabetes is so vulnerable. So let us look at management priorities of COVID with diabetes. Well, obviously, we need to see the collateral damage. What happens with the change of care. And we know that staying healthy and controlling diabetes during pandemic has been a big challenge for all of us as physicians at large. And we know that various authorities said that we need to get better care for diabetes. We need to tell people with diabetes that they need to maintain a healthy diet, monitor their glucose, ensure that they keep connected with doctors, take their injections and tablets on time, do their distancing right, and ensure that they are a vulnerable group. So the outpatient care needs to be digitally connected. We need to sensitize diabetic patients, reach out to them, and we should ensure that they don't discontinue their therapy and do telehealth and telemedicine, and try to keep normoglycemia, A1C to target, and sometimes even use a CGM-like mechanisms. Because any minor fluctuation in high blood glucose level will make them relapse, vulnerable to infection, not just COVID, but even non-COVID infections. And therefore, it's important that they seek help and treat and care and be very, very aggressive about it. So obviously, diabetic patients with COVID, we need to have a step-by-step approach. We need to get aggressive. We need to ensure that they are volume depleted. We need to ensure that they are appropriately isolated and they take the right amount of oral anti-diabetic drugs. If they get COVID with diabetes, we need to do and tell them simple sick day rules. We need to educate them in advance that if they get sick, get their glucose on target, take their medications on time, upgrade it. If they get thirst or dry mouth, if they have a lot of polyuria, if they feel tired or weight loss, they need to report to the doctor or get into hospital. That's what we need to do. So obviously glycemic management of COVID affected with diabetes, we need to know are crucial for a tight glycemic control, and that's a standard of care. So obviously, what are the treatment pathways? Because are there treatments of diabetes which could be anti-COVID? Are there treatments of COVID which might aid and help COVID? Or could they be deleterious in COVID? Let us look at that. Well, clearly we know all diabetics will see fluctuations or worsening of glycemia. All diabetics will need sick day rule management. and we recommend close monitoring of blood glucose. So that's something which is a given. So if you see, we also need all this with common cold and flu, sore throat, UTI, bronchitis, skin infections. COVID is no difference because we have excess cortisol. And therefore, we ensure that insulin should never be stopped, drink appropriate fluids, and monitor everything appropriately, follow SEB rules. This COVID diabetes front door guidance in United Kingdom, which was come out by the British Association of Clinical Diabetologists, was very useful. That treat diabetes in an emergency response state, particularly for hyperglycemia and diabetic ketoacidosis. So there are two pathways we have. Either give them oral medications. If you can manage them at home, or if there's mild COVID, or if you have home isolated, we can manage most of our diabetics at home very well. But if they get into hospital, we prefer that the OHs be continued if they are eating orally. But if they are moving into an ICU or a critical state with moderate to severe state which needs oxygenation, probably insulin is in the order. So obviously a patient-centered approach is appropriate based on the age, severity of COVID, cardiovascular comorbidities and hypoglycemia risk. And we need to treat them with a euglycemic individualized goal approach. So obviously we need to avoid anti-hypoglycemic agents in hospitals which will cause volume depletion and hypoglycemia. We may need to downgrade the doses of anti-diabetic drugs. We sometimes may need to stop metformin if needed, and that's something which we need in order. So that's why different authorities came with different guidelines. Like there is a strict no-no in hospitals for SGLT2 and metformin. For sulfonylureas and insulin, lot of caution has to be exercised and monitoring for hypoglycemia has to be exercised. And obviously in ordinary cases, subcutaneous insulins are recommended. In severe cases, IV insulin is recommended. Good glycemic control is on order. During the illnesses, glucose will rise. Try to keep it between 110 and 180 and test at least twice a day. So if you test twice a day, what are the red signals in a diabetic? If the glucose goes above 180, increase the dose. If it crosses 250 or 270, which is the ketosis threshold, get them in hospital. If in hospital, get aggressive. Insulin probably has data in animal studies that it reduces the renal ADAM17 expression in diabetic mice, which reduces the urinary ACE2 shedding, increasing the intrarenal ACE2 expression. So obviously in human data, there are no such concerns. Metformin could be anti-COVID. Sulfonylureas are neutral. And you know, pioglitazone can actually down-regulate ADAM17. So there could be an upregulation of ACE2 in insulin-sensitive rats. So all this animal data cannot be applied in day-to-day medicine. Liraglutide has a similar risk. SGLT2 inhibitors actually promote renal ACE2 activity. And gliptins are probably the only agents. You know that DPP4 was the receptor for MERS-CoV-2. DPP4 do not alter the ACE2 activity in diabetic mice. And DPP4 inhibitors might have an anti-COVID role, just like metformin may have. So in early COVID, in early admission, we advise them to manage glucose, take ketones, stop SGLT2 inhibitors, give some fluids, hydrate them. In severe cases, start IV insulin drips. That is the standard of care. And therefore, they have this ABCDE approach in which we look for shortness of breath due to metabolic acidosis, start them on insulin and upgrade immediately. Watch for hypoglycemia and up titrate appropriately. All these guidance is available on the websites, and monitor for ketones and ensure that the inpatient care, stop oral agents, give insulin and monitor them well, manage other comorbidities appropriately. ACE2 agents can be continued and ensure that there is no challenge with them at all. But is there a role for gliptin? Because DPP4 looks like an appropriate treatment approach, because we know DPP has the entry receptors to ACE2 receptors, is a key receptor during the MERS pandemic, is a serine protease enzyme itself. It is similar to the viral protease, so it's very mimicking the viral protease. And if we give DPP4 inhibitors, it could be anti-inflammatory and immunomodulatory properties. And in DPP4 in elderly, diabetics, obesity are increased. So there's a lot of retrospective and observational data to suggest that people who have used DPP4 inhibitors and looking at outcomes of COVID-19, and we are also compiling our own data, show some potential benefits. So clearly there is some data showed there is no benefit, no harm. Retrospective data showed decreased mortality. And we have these elegant studies which have been published from various centers, including the multi-center study, which was published in Diabetes Care, which showed that with sitagliptin, actually, there was reduced mortality with type 2 diabetes in a multi-center case control study. We also showed from Italy that gliptins work. And very clearly, we show this from this data in Diabetes Care, that if you give DPP4 inhibition in COVID-19, like sitagliptin, it might impact mortality also. And the hazard ratio is 0.13 and 0.44. So they could have some life-saving potential. So probably, is there a mechanism to show that the COVID-19 mortality with sitagliptin treatment might have some high science on it? Yes, it's possible, it is probable, and it's a research area. In India, we have come out with our own Association of Physicians and ICP recommendations for diabetes and obesity. We feel they are risk factors, they are associated with severe disease, they have immune defects, they can cause pancreatic damage as well as stress hypoglycemia. And if you get diabetes, male gender, elderly, hypertension, chronic renal disease, they need strict supervision. Early diabetes specific nutrition is order of the day. Monitor glucose and anti-diabetic agents appropriately, and also take care of cardiovascular health. Don't ignore cardiovascular health. And then the last point is, are we looking for one more wave? Because we are now looking at another wave coming up. And due to this disaster of COVID, we are going to see that you will need communication and consultation. So as physicians, it's our job to consult remotely and communicate with our patients for insulin titration, hypoglycemia and hyperglycemia. We need virtual consultations, and we need to ensure that we need to protect our patients to preserve ourselves. That's the new normal. We need to do mass testing for diabetic patients. We need to do telemedicine. We need to encourage telemedicine more and more appropriately. We need to use apps. We need to ensure that we follow our highest ethics, which is very, very important, so that we maintain confidentiality, privacy, data integrity, informed consent, autonomy. And we need to ensure that we need to have a right setup for appropriate teleconsult. That's so important. We don't need to forget nutrition. Drink adequate amount of water, eat enough amount of vegetables, eat right, eat slowly, eat on time, sleep well. And it's important that nutrition will have more focus. Mental health and stress will have more focus. And don't forget vaccinations in our diabetics, because it's important that they need to be protected. They need to get their flu shot. They need to get their pneumococcal vaccine shot. And therefore, it's very important that you don't forget your flu vaccine, pneumococcal vaccine, and various other vaccines for diabetics. And these all recommendations are available in public domain. So I'm very grateful to Dr. G. Vijay Kumar that he allowed me to present COVID in COVID times. Diabetes is clearly a risk factor. And we know that when you get diabetes, you will get severe COVID and you're likely to die. Glucose control is important in COVID times. We need to empower doctors, physicians, healthcare workers to manage diabetes. We need to reach out to our diabetic patients. We need to make an effort. We need to use telemedicine appropriately. We need to protect our diabetics from hospitalizations and COVID. And we need a holistic diabetic care for our diabetic patients. We are all here with a common goal for diabetes care. And I'm happy that COVID care has put diabetes more on spotlight. I only wish and pray that diabetes across the world, including India, will take care of themselves better in COVID, because in COVID, we are all sitting at home, so we have become sedentary. We have been eating inappropriate foods, and we are stuck on to screen time. So my only take-home message is for all diabetics is eat less, walk more, sleep well, and do a 2 hours of digital detox every day. I'm really grateful for Dr. Natarajan and Dr. Vijay Kumar for allowing me to speak in this meeting. And I'm thankful that you have allowed me to speak here for what I like to speak on. Thank you so much.
Thank you, Dr. Shashank. Thank you for your extensive talk, and which you have completed in 20 minutes on dot. Thank you so much for that. You extensively dealt the correlation of COVID and diabetes, starting from pathophysiology and moving on to the relationship with the AC inhibitors, the receptor, and the hyperglycemia and the mortality in COVID, and the management step by step, and the treatment pathway and patient-centric approach, and the usage of DPP4 and telemedicine, and adjusting to the new normal what we are experiencing. Thank you so much, Dr. Shashank. Open for question.
Dr. Shashank, I have a question.
So you are the task force for Maharashtra
COVID-19. So you are also mentioning about the second wave of virus. Do you think that there is a reduction in infections nowadays to get a second wave, or you think that it has come down and are going to be a second wave? I feel it is still continuing. That's what I felt. But you're the right person.
Let us look at India is a mini continent, and in India, you are right that in say Mumbai, Maharashtra, or say in Tamil Nadu, we are still getting out of the first wave. So we have had the first peak in Mumbai, for example, in between mid-May to early July. We had the second peak after Ganesha festival between 15th to 30th of September, and we might get post Diwali a small peak. And our second peak, if it occurs, will occur end December to end January, if it occurs. Remember, India is a tropical country. In a tropical country, usually the peak is during monsoon times. Now remember that south of India gets second monsoon, which second peak can come with the second monsoon. The point is that in north of India, due to pollution, due to unlocking, due to festivities, and due to low temperatures going below 10 degrees, Delhi had temperature 2 days back at 7 degrees, there has been a peak, which is a second wave. Delhi had 3 waves. So if you look at the geography of Delhi, Haryana, Rajasthan, parts of Uttar Pradesh, Madhya Pradesh, probably they are in the second wave. Let us look back at history. 100 years back, the so-called flu pandemic which came in, which was probably the Spanish flu, though it didn't occur in Spain, but Spain reported it the most. It started from Kansas City and went across the world. India had 15 to 20 million deaths. And that amounts to 1.5 to 2 crores, when Indian population was 22 crores. The second wave was more sinister, more deadly. So what is Delhi seeing? Delhi is seeing a more detrimental pandemic now. They are seeing in their so-called second wave, people without comorbidities between 30 and 60 affected with a little higher mortality. So that is the worry. Now we have to be careful and cautious. We need not be careless and reckless. So I think we have to tread a very careful path in COVID. You are absolutely right that as of now, Tamil Nadu or Maharashtra are reasonably swimming in reasonable waters. But as the temperature will drop down, in those geographies where temperature will come down below 10 degrees, in those geographies where air quality index will go up, we'll have challenges. We are not the world number 1. Worst country on air quality is Kabul. Delhi is world number 3. Mumbai is world number 8. Calcutta is world number 15. Unfortunately, fortunately, no South Indian city comes up on the pecking order for pollution or air quality index. So in terms of air quality in Mumbai, we clearly have a challenge. We don't have stubble burning like it is there in Haryana or Punjab, but we do have 2 places where pollution comes from our areas. Number 1 is vehicular pollution or traffic pollution. And the second area where pollution comes in is from the waste disposal. So we need to have a clean India. That's something which is very important. So that's my take on the second wave. I think.
I have a question.
Yeah, Mohan.
Sir, I heard in a talk that you cannot get immunity by suddenly changing your lifestyle. Or walking or exercise may decrease the amount of diabetes, but will it help in building immunity in such a status?
So immunity, which is acquired and innate, cannot be got overnight. You are absolutely right. But if you sleep on time at 10 o'clock, between 10 to 11, you will make some interleukin 10 and interleukin 8, which is protective. So if you sleep for a good 8 hours, your likelihood of getting viral infections is lesser. If you sleep later, you will not make that IL-8. So if you take some simple cues from biology and stay a little healthy, eat a little appropriately, eat a little sensibly, I think we can walk the path. If you are reckless in terms of your lifestyle, if you are digitally intoxicated, you're all the time on a screen, then you are going to actually cause challenges. So it's important that we ingrain some appropriate behavior to build a better immunity. Our immunity we have acquired over years. We have had poorer hygiene, which is why we have better immunity, which is we have a better recovery now. We are BCG vaccinated. Look at Portugal and Spain paradox. Portugal, full country BCG vaccinated. It didn't get the number of cases like the way Spain exploded. So we have some conferment of immunity for sure as Indians. But if we persist with better behavior, we'll have better confidence. You are muted, Dr. Vijay Kumar. I can't hear you.
Thank you, Dr. Sachin Joki. Is there any further questions?
Yeah, Dr. Kannan had a question, I think.
So the role of micronutrients, especially the vitamin D, zinc, and the supplementation by exogenous, it is helpful for enhance our innate immunity, sir, as per told, sir.
So these are all adjuvants. Vitamin D levels have been shown that low vitamin D levels in COVID can cause a worse disease. Having an appropriate vitamin D level may help. There have been some studies which have also been done in that direction. Keeping a vitamin D level above 30 or 40 doesn't hurt, but I can't say that it's an anti-COVID therapy. So at best, it's an adjuvant. Vitamin zinc definitely has some antiviral effects, but again, it's an adjuvant. So vitamin C, the data on COVID is poor. So it's not, but in regular cold and flu is better. So in terms of that, I would say all micronutrients should be there in the appropriate doses, but they are not standard of care. Vitamin D and zinc have some data to support it, but not totally in COVID space. Most of the data is retrospective or as old data from respiratory viral infections. And we are trying to correlate it with COVID. Now some COVID data is emerged. So I think give it, but it is just a supportive care. It is not classically a standard of care. Vitamin D probably has some now data in COVID space. So I would still keep it on the pecking order. And we can give a match dose. So somebody gets COVID, giving 60K 3 doses every day for 3 days doesn't hurt. It's cheaper than doing a vitamin D level. Rajesh had a question.
What is the role of fomites, sir, in transmission? Is it proved or?
So increasingly, the data is emerging that the role of fomites is getting lower and lower.
Okay, sir.
Okay, but it's still there. I don't think you can dismiss it.
Asymptomatic carriers, sir.
Asymptomatic carriers transmission rate has dropped down to 40%. So every asymptomatic carrier may not transmit. So that's only 40%. Also remember our RT-PCR threshold has been, ICMR has put it at 40. We know that infectivity of the particle is only when the viral load drops below the cycle threshold of 24. So any cycle threshold value below 25, the likelihood of infectivity starts dropping down. So that is why if an antigen test is positive, that viral load is higher and the transmissibility is more. If the viral load is lower, the transmissibility is less, but it doesn't mean it's absent. Okay, predominant route of transmission is airborne droplet, not airborne droplet. Crowded spaces, poorly ventilated environments are the key.
Thank you, sir.
Vaccination.
Are you able to hear me, Dr. Shah? Are you able to hear me?
Yes.
Okay.
Vaccination, Dr. Dharma. Vaccine. We have 5 candidate vaccines likely to come to India. Next month, the first vaccine which will come out will be the Oxford vaccine if the safety is proven. It's the Oxford Serum Institute vaccine which will come out. In 2 to 3 months, we will have Bharat Biotech and Zydus vaccine. The Bharat Biotech vaccine is undergoing phase 3 clinical trials. It's basically a vector-borne vaccine, while Zydus vaccine is the DNA vaccine. The 4th vaccine which will come out is Dr. Reddy's and Sputnik vaccine undergoing phase 3 trials. And the 5th vaccine is a Johnson & Johnson biological events vaccine. Pfizer and Moderna, which are mRNA, which need very high cold storages, are unlikely to come. Right now, the data in public domain is only for efficacy, that too not published. Safety data for even Moderna and Pfizer is not yet out. So we need to see the publication before we speak. Okay, so vaccine will be there, but I think for India to be realistic, it will come in anywhere between March to June of 2021, but full India will only get vaccinated by 2022.
If the chair permits, I'll ask one question. Last question.
Yes, last question.
Dr. Shank, anyway, we are blessed in Chennai. We have only 3 seasons, hot, hotter, and hottest seasons. So we don't have any cold season. That is one thing. So second thing is that, how about your take on that reinfection? A lot of people are worried and scared. What is it you suggest the delegates?
Reinfection is exceptionally rare, but its prevalence in healthcare workers in COVID care is higher. So as doctors and nurses and our healthcare workers, we need to be cautious. So in that space, we have seen it, but it's extraordinarily rare or exceptional. So at Nair Hospital, at Hinduja Hospital, at a couple of other hospitals in Mumbai, including the hospital where I work, we have noted and reported cases of reinfection. But we can count them. I can count the numbers actually, and I can count the names. Also remember that reinfection will occur, but it is exceptionally rare. And it is most vulnerable. We are the vulnerable group because we are constantly exposed to a COVID environment working in COVID care or the non-COVID environment, but in COVID care. So therefore, I think if you can handle a virtual consult, continue to handling the virtual consult. The more exposure you are and the longer is going to be the duration of your consultation time, the higher is the risk of exposure. And that is why I think even the CDC recommends that if you want to do a consultation, optimal time is 5 minutes and try not to exceed 15 minutes. Because we are not consulting with full PPE kits. And also remember, PPE kits are reasonably hostile on personal health. So it's important to recognize that feature, and we need to be very careful and mindful. As much as possible, do virtual consults. If there is a diabetic foot wound, if there is a acute emergency which needs care, let that person go to a proper medical care unit, and you can still connect them with them digitally. But try to see whether you can appropriate it. I think Dr. Vijay Kumar, you said hotter, hottest is Chennai, but still COVID came there.
I know.
COVID stayed there. COVID had a peak in Chennai. COVID had a challenge in Chennai. So I think this temperature myth needs to be busted. Lower or higher temperatures, I think COVID has only one thing which is common. And that is the last word I will say. It is predictably unpredictable.
Thank you, sir. Thank you very much for this wonderful deliberation and all the take-home messages, and also clearing a lot of doubt with everybody here. Really enjoyed listening to you. So thank you very much, and have the remaining day, whatever is left, for yourself. Thank you very much. And
Thank you.
Dr. Vijay Kumar, Dr. Kannan for co-chairing this, Vijay Kumar for the opportunity, and Dr. Kannan for co-chairing the session. Over to the organizers for the next talk.
We have next session that is in a case discussion from a journey from diagnosis to complications, and we have two eminent speakers to take care of this. And to take it forward, we have none other than Dr. S. Venkataraman as a chairperson, and he will lead the. Dr. S. Venkataraman, all of you know that is senior most and has been introduced yesterday. Senior most diabetologist, and is also guru for all of us. You know, he is a most knowledgeable person, and we are blessed to be with him. Sir, Professor Venkataraman.
So good afternoon. So we are in for a very interesting session. A small preamble as usual from my side. I wouldn't take much of my time, and between Sanjay and Suresh to deliberate in the next 30 to 40 minutes. Now, if you look at the pattern of treatment in diabetes mellitus, there has been a paradigm shift in the last 3 to 4 decades. I'm sure many seniors are there will agree with me. From a concept of treating some degree of hyperglycemia to some degree wherein patient relief from symptoms and prevention of acute complications was the only aim, we were into a target-driven approach. This target-driven approach has been supported by a lot of data, and we urged the clinicians, and we practiced the diabetes practice in such a way that we were able to achieve the target in a very safe manner. Along with that, we felt the compelling need to address the comorbid conditions. And we have a basket of molecules in the last 2 to 3 decades. Some of them have proved to have compelling evidence in the prevention of cardiovascular disease and in the progression of renal disease. Amalgamating everything together, it was tempting to speculate whether at the start of the treatment of a diabetic patient and down the line when there are subclinical manifestations of the complications and maybe even towards the later stages of the complications, a combination of molecules which have made their say both with respect to the glycemic efficacy and achieving it in a safe manner, and the durability has been achieved. And more importantly, at least one of the components of the molecules has had a telling effect on the macrovascular disease in a highly vulnerable population and in the progression of the disease. And molecules of this class, the SGLT2 inhibitors, to be very precise, along with the DP4 inhibitors, especially the SGLT2 inhibitors, as a class effect, they have been found to have an effect on cardiac failure as well as in the prevention and in the amelioration or progression of kidney disease. So it is in this scenario, we thought whether a journey from diagnosis to complications could be achieved, that is, initiate with a class of molecules with a concept of the glycemic targets as well as beyond glycemia, address the comorbids as well as position them in the later part of the disease. So if this is the perception or the expectation of the clinicians, what are the evidences? To do it in the first phase, a case of early type 2 DM rational null combinations, we have none other than Dr. Sanjay Kalra from Karnal. He is the President Endocrine Society of India and Vice President South Asian Federation of Endocrine Societies. You can see his profile, brief profile here in the screen, but much more importantly, one of the most respected and eminent endocrinologists of the country, who is known for his enormous work and the immaculate way he is able to convey things, whether it is a commentary, whether it is a editorial or an article written or an oration given by him. I think all of us learn a lot whenever Sanjay is there on board. Now it is to you, Sanjay, for the next 15-20 minutes to talk about an early, a case of early type 2 DM, rationale behind novel combinations. Sanjay Kalra.
Thank you, Dr. Venkatraman, sir. And thank you for your kind words. It's a pleasure to be part of this 3D gathering, the August gathering, and also speaking under your tutelage, your chairpersonship, that has taught me a lot of things. Like you very eloquently put it, our approach to diabetes care has changed. Earlier, all we could offer our patients, all that our patients expected from us was symptomatic relief. Then about 30-40 years ago, we began offering glucometabolic relief. The definition of glucometabolic relief also changed. Earlier, it was only fasting and postprandial. Now it is HbA1c, time in range, CGM, so many new things have come. But from glucometabolic relief, we have also moved on to vasculometabolic and then viscerometabolic relief. And now the data that is coming, the studies that are coming, they talk not only about macro and microvascular disease, they also talk about fatty liver, polycystic ovary syndrome, heart failure, the improvement in all these aspects of metabolic health. Just like our approach has changed, our management has also changed. When Dr. Venkatraman sir was a student, when I was a student, the first line management for type 2 diabetes was only lifestyle modification. It is after I completed my MD and my fellowship, I don't remember the exact year, maybe 15 years ago, that metformin entered as first line. And then the guidelines began saying, first line therapy for type 2 DM is lifestyle plus metformin. We had just begun to understand this and practice this when again newer guidelines came, and they said that HbA1c is not only a target, HbA1c is also a tool to help you in risk stratification. HbA1c is also a tool to help you in decision making. So if your A1c is more than 7.5 or 8, you begin with 3 things: lifestyle modification and 2 drugs. If the A1c is more than 9, you can actually begin with lifestyle modification and metformin and 2 more drugs. So they call it triple therapy. Actually, it is quadruple because the lifestyle modification is also there. We began practicing this, and then suddenly last year there were guidelines which began talking about SGLT2 inhibitors and putting SGLT2 inhibitors or GLP-1RA as first line therapy, not opposed to metformin, but along with metformin. So all these changes have occurred in the past 10 to 15 years. And when there are so many choices, certainly we will get confused. At the same time, diabetes is not a homogeneous condition. You can have a slide deck saying, how will I approach a person with newly diagnosed diabetes? But if there was only one approach for that, then there would be no need for talks. There would be no need to discuss. The expertise that, for example, Dr. Venkatraman or Dr. Suresh Damodaran will speak after me, the expertise that is there in the OPD that comes from seeing patients, from talking to them, from listening to them. And you have to treat every patient individually. We are not the first people to face this challenge. Our philosophy also tells us the same. The truth is one, but interpretations are many. So it is up to us as responsible physicians to make a responsible or rational interpretation of whatever we are reading, whatever we are learning. How have I evolved in the past? Now, Dr. Venkatraman sir, I have completed 21 years now of endocrinology this year. So it has been a very pleasant journey, a journey full of learning, full of knowledge. Initially, we coined the word glucophenotype. Phenotype, we know what it means. It means the sum of all external attributes. We changed it to glucophenotype, which would include fasting glucose, postprandial glucose, HbA1c, the occurrence of hypoglycemia, nocturnal hypoglycemia, glycemic variability. But this is a biochemical concept. And our patient is much more than biochemistry. The patient who is coming to us, the lady, the gentleman, the boy or girl, is a human being. That human being has a personality. So then we began talking about glycemic personality. And we coined, or we began using, what we call the SURE model. This is something that I still use in my practice. I will continue with how I have evolved. But this is a simple model for all of us to learn. When your newly diagnosed patient comes to you, look at the severity and style of hyperglycemia. What is the HbA1c? Does the patient have predominant fasting or postprandial glucose levels? Look at the urgency and utility of treatment. If the patient has a pyelonephritis, cholecystitis, diabetic foot, the urgency is high, the utility is also high. But suppose patient has CA pancreas with metastasis. The urgency may be high, but the utility is not going to be there because the lifespan as it is not too much. So urgency and utility are two different things. R is for risk of hypoglycemia. If your patient has renal, hepatic, or gastrointestinal impairment, chances of hypo will be more. If the patient has hypopituitary, hypoadrenal, or hypothyroid, chances of hypo will be more. So this R tells us to be cautious. S and U are the action-oriented angles. R is caution-oriented. E is reality-oriented. Depends upon the patient's economy, patient's expectations and enthusiasm. Accordingly, you will treat. This is simple, but we like complicating things. And like I said, one truth, but multiple interpretations. So another interpretation of the SURE model. Not only do you look at what we have mentioned just now, but you also look at superadded comorbidity. A patient with diabetic foot with tuberculosis will certainly get different treatment. Without, I may go slower. U also stands for understanding of pathology, insulin resistance versus insulin deficiency. We have to treat differently. And in R, we also look at the renal complications. We already mentioned that. We also look at the related complications, acute and chronic. For example, somebody with proliferative retinopathy, that is not the right time to be very aggressive in treatment. You should try and control glucose, but don't go overboard in trying to do that. Now, coming to what I do at work. So I've told you how I have evolved in practice, but where I work, Dr. Venkatraman sir, it is a relatively small town. We do not have many stable patients coming to us. When you read the American and the European guidelines, it is assumed that the patient comes in as a newly diagnosed diabetic. The patient is very well behaved. The patient will stick with you as a doctor, or at least will stick in the same healthcare system, the same insurance system, the same NHS of UK. Our patients are very democratic. They are very freedom loving. They will come to the hospital only if they have S for severe hyperglycemia. They have symptoms, or they are sick with an acute or chronic disease. They will come in special situations such as maybe pregnancy, lactation, renal impairment. And sorry for the typo, they will come for surgery. Patient will come and say, I've had sugar for 10 years, but I was okay, so I didn't come to you. Now I have got cataract. So please help me control my glucose because the eye surgeon is not operating on me. So severe symptomatic sick patients coming in special situations or for surgery. And to add to these 5 S's is our sweets and starch. The rice, the wheat, the sweet meats, all this is what we have to tackle in the diabetes clinic. Therefore, our choice of drugs may be different as compared to what is suggested elsewhere. But when a patient comes to me, the first thing I do is to assess the patient and assess the previous prescription. I want to talk about the difference between interchange and intensification. My topic for today is initiation. How do I initiate therapy in a newly diagnosed diabetic? But why I want to talk about these is, if you have a patient with lack of efficacy, patient is on single drug or 2 drugs or 3 drugs, that is immaterial, but the glucose level is not coming down, then you have to intensify. You have to add another drug. So lack of efficacy means you have to add. Do not interchange, because otherwise A1C is going to remain the same. Supposing I stop DPP4 and I start SGLT2, there is not going to be 2% change in A1C after that. But when will I interchange? I will interchange if there is lack of tolerability or lack of safety. So if there is lack of safety, either I can reduce the dose of sulfonylurea, for example, or I can just change the drug to DPP4 inhibitor. Same for lack of tolerability. Suppose my patient has got genital infection with SGLT2 inhibitor, then I will change the offending drug. So that is why interchange and intensification, the difference we should understand. Coming to initiation now, when we initiate, we will initiate based upon the baseline A1C. There are a million combinations that you can have. But to make it sensible, this is a simple taxonomy that we created. You can divide all glucose lowering drugs apart from insulin into secretagogues, sensitizers, and nutrient load reducers. Try to choose one from each bucket. So one sensitizer, one secretagogue, and one nutrient load reducer if required. The incretin-based pathway, these drugs, they are indirectly acting secretagogues, though they also do help sensitize the insulin receptors. With this background, what is my choice now? In a standard patient who is coming to me, because my standard patient has one of those 5 S's, like I mentioned, I will usually begin dual or triple therapy. It is very rare in my OPD to start metformin monotherapy. The reason is that nobody is coming at an HbA1c of 7.5 or 8. But if I had better behaved patients, if my community was more diabetes literate, certainly I would stick to monotherapy. When I begin dual therapy, I usually start metformin unless my patient is malnourished. Now, we must understand protein energy malnutrition and micronutrient malnutrition are very common. Even in a state like Haryana, which is quite rich, we will still see adult malnutrition. Sometimes it is because of pancreatic diabetes, sometimes because of very poorly controlled or wrongly diagnosed LADA, type 1 diabetes, type 1.5, but sometimes it is just type 2 diabetes with malnutrition. Metformin is a calorie restriction mimetic. If already my patient's calories are restricted, patient is not eating calories, patient is not absorbing calories, then it doesn't make sense to give high doses of metformin. Also, if patient has GI symptoms, they can be because of diabetic gastroparesis, they can be because of lactose intolerance, or because of wheat intolerance, celiac disease. They can be because of associated giardiasis. This is something that I face very commonly in my patients. I have to fix the GI symptoms first. Only then can I start high dose of metformin. But still, around 90% of the patients will get metformin, and I will start sulfonylurea unless there is high risk of hypo. If there is a high risk of hypo and my patient is at low risk of CVD, I prefer a gliptin. This is along with metformin, remember. And also, if the patient has high CV risk or the patient is overweight, I will start an SGLT2 inhibitor along with metformin. This would be maybe half of my patients in the clinic where I'm initiating oral drugs. The other half, I will start triple therapy because they are more symptomatic or more severely hyperglycemic. If I'm starting triple therapy, at least in my practice, metformin and SU will be there. I will use a modern SU like glimepiride or glyclazide SR. Along with this, depending upon the CV risk, if it is low risk, I'll choose a gliptin. High risk, I'll choose SGLT2 inhibitor. I continue to use pioglitazone. If there is cerebrovascular risk, which is high, consider pio. If patient has acute weight loss, consider pio. And also if there is hyperglycemia in the postprandial phase, consider voglibose or acarbose. So this is my standard patient where I've started either dual or triple. How do I decide dual versus triple? That is decided by the baseline HbA1c or even glucose levels. So far was biomedical, but like I said, we talk of glycemic personality, not only glucophenotype, because my patient is a person. So every person is different. If my person is coming from a very far off place, maybe up country, she is not going to come back to me for 3 months. I will educate my patient. I will tell the patient, whenever you anticipate or suspect or experience symptoms suggestive of hypoglycemia. Anticipate means tomorrow I'm going to keep a Tuesday fast. Suspect means I had ghabrahat or uneasiness. I don't know what it was. And experience means you actually have a documented low glucose. Then I will educate my patient. I will give a squad tablet of metformin plus glyclazide. I'll say you can always break it in half if you anticipate, suspect, or experience hypo until you come back to me. Encourage your patient to take half the tablet if there is hypo. This is for patients who are coming from far off place. But if I cannot educate my patient about this, I feel patient is not numerate enough. Patient is not going to interact with me frequently. Then metformin gliptin is the safest choice. Also, if CV disease risk is low, then gliptin metformin is the safest choice. SGLT2 inhibitors we write, but we do take time out to explain to them about genital hygiene and also the red flags. That means if you have uneasiness or dyspnea or genital infection, please come back to us. For pio, whenever I write, my joke is that we are writing pio. If your weight remains the same, continue with this medication. But if your weight increases and you feel that you have to go to the tailor or you feel that you have to buy a new belt or a new pair of trousers, please do not go there. Come back to us. And how we tell them, this is good news. You have to come back. We will reduce your dosage. So this is what we tell the patient. Come back to us if there is weight gain. And alpha glucosidase inhibitors, I do write in my OPD, but not very frequently. But if the patient does not accept dietary advice, continues to take high carb meals, and PP glucose is not coming down, then AGI is what I add. In the past few years, I have begun speaking more about diabetes remission. Here also, I am very sure Dr. Venkatraman sir will agree with me. There is one group of healthcare professionals who says that you can give remission to everybody with diabetes. They are wrong. There is another group of healthcare professionals who says nobody with diabetes can go into remission. That is also wrong. So remember the philosophy, interpretations are many. Remission is possible in type 2 diabetes if we give the correct medical nutrition therapy, provide good diabetes coaching, and use the right drugs. We are all aware of these drugs. But when do I speak about remission to my patients? This formula is from Lee et al. 2013. If the age of the patient is less, remember it is type 2 diabetes, not type 1 or pancreatic or MODY. If the age is less, the body mass index is more, the C-peptide is more, and the duration of diabetes is less. Chances of remission are there. If your patient asks you about remission, you say yes. There is a chance, provided that we follow the ABCDE formula. And this E formula, the patient has to be enthusiastic. We are offering good expertise. We are going to use metformin or GLP-1RA or SGLT2 inhibitor. We can also use gliptin. We have to use a lot of medical nutrition therapy. But alone my patient's enthusiasm and my expertise is not going to work unless we engage with each other. And it is good to have a coach for such patients. Your diabetes educator can take on the role of a coach, or there are online programs available now. There are many good companies in India which are offering such coaching. We can use theirs. And all of this will be possible only if the entire team is euthymic or remains happy. So we have to have a very happy discussion with these people who hope for remission. My last slides now. I have spoken about the evolution of diabetes care. Dr. Venkatraman sir began by talking about how we are able to offer better care now to our patients. We continued that journey. We talked about different models that I have used. This is what I use now in my clinic. Assure. Remember, when you are assessing your patient, what drugs to use, look for associated complications, keep social realities in mind, and then SUR is from the original SURE, severity and style, utility and urgency, and relative risk of hypo. And E is for expected efficacy. Be aware of the efficacy of the drugs that you're using when you prescribe them, so that our patients can enjoy their journey of diabetes with us, and we all can live happily ever after. Thank you, sir.
Thank you, Sanjay. As usual, it was a very, very clear-cut exposition of, as you rightly said, your perception as well as interpretation of the truth. So we know the molecules, we know the concept, we know the target, and all these are signs. At the back of your mind is your patient, his phenotype, his affordability, his compliance, all these factors. How do you gel together? I think nobody could have explained it better. So you have a various possible combinations in this scenario. I think the combinations that you have that the clinician can choose. You have not given a single choice. It is up to the clinician. You amalgamate, you integrate all these reasonable inputs with respect to the patient and the science, and then present it to the patient. It was excellent the way you put it. I always enjoy your presentation, and so was today's. So we'll have some questions and comments at the end of the session. And now I'm going to invite Dr. Suresh Damodaran for the subclinical cardio-renal metabolic conundrum. As I told you, we were shifting from a glucose-centric approach towards glucose plus other risk factors. And pleasantly, we realized that beyond controlling the risk factors, one can probably have a beneficial effect with respect to the renal and the cardiovascular endpoints. I think in this scenario, it is tempting to speculate. If you position such a molecule or a combination of such molecules early in the course of the disease, wherein you talk about a subclinical disease being in operation, then your endeavor is possibly with all soft data or interpretation of some of the huge data, then you might end up in a situation wherein you're in a position to prevent future events. So with this, let me invite my good friend Suresh, an enthusiastic young endocrinologist from Coimbatore. He recently concluded one of the best meetings, and it is nice to gel with him always. You see his credentials. He has done his postgraduate super specialty training in England and special entries in all aspects of endocrine medicine. He was awarded the Donald Eitzwiller International Scholar Award. Everything you see for yourself. The way I introduce Suresh is a great friend, absolute enthusiast, enormous knowledge, and always having an urge to crave for more knowledge and more accolades. And he thoroughly deserves whatever he has achieved so far, and my blessings to him for the future ones. Suresh.
Thank you very much. It is like getting a pad off from Guru. I always respect Dr. Venkatraman sir and GVK and Anand Moses and Shantaram, and as a group of people who guided me when I entered this country about 9 years ago. Thanks very much for the wonderful opportunity, Dr. GVK. So each and every big conference, we want to learn something new. I think we coming after a very practical, good lecture from Dr. Kalra. We are moving towards a science that has been evolving, or how to approach people with the subclinical cardio-renal metabolic, because the evidence are coming thick and fast. So we need to catch up in one of the meetings in India. South India is a big place. So wherever we get an opportunity, we just need to drive home the message. And if I can drive in next 13 minutes or so, I've done justice for the talk. I receive a honorarium for this talk. So practically, if you look at it, the case what we got today is a guy how to minimize this? Okay, a 52-year-old, type 2, 3 years, and weight of 80 kilos, and the BMI of 27. We got the metformin and also hypertensive drugs. A1C is 7.8, and we got diabetic dyslipidemia, and the TMT is positive. So we got somebody who's like a sitting duck for a cardiac disease. And what we do, so the cardiac and renal, there is a chain of things like atherosclerosis leading to CAD, MI, and then LV modding, and then heart failure that comes to the kidney. So we got a continuum, and where do we approach? And if you look at it, what we've done in the past with the UKPDS, ACCORD, or ADVANCE, or VADT trial, all the trials have showed you intensify, you being a glucose-centric, you approach with a glucose-centric approach. UKPDS is the one thing that showed some CV disease less, but apart from that, we don't have any consistent improvement of macrovascular of a stroke or a cardiovascular endpoint. But if the same thing applies, I think the intensive glycemic control, if you do a meta-analysis, it doesn't show that there is no improvement of heart failure or type 2 leading to heart disease. That is not prevented by just glucose alone. So that is the point. So in my feeling, what can you do? I've shown you a slide 2 slides ago. There is a continuum. So we got drugs. Dr. Sanjay Kalra has explained how practically to use all these drugs. They all got a glucose lowering potential, but where to use when? He explained it, practical approach. But if you look at the metabolic thing, glycemic, hypoglycemia, weight loss, and blood pressure, the SGLT2 molecule that I want to talk about today, specifically with in terms of empagliflozin. So if you look at the EMPA drug as SGLT2 class, it has got a huge vast evidence from the day it got introduced, and that's the first drug it got introduced with proper evidence. So if you look at the 10 milligram and 25 milligram, it's just 24-hour CGM, and Dr. Kalra has mentioned about time in range. So that time in range is also maintained. When you compare to the commonly used drug, which is a glimepiride, you can see the brown line with the glimepiride of there on the top, and then EMPA with 25, showing a weight loss consistent over 4 years. And that is the big thing. So if you look at the other effects, so I mentioned about the weight loss, the anti-inflammatory effect, how do you measure it? You do a highly sensitive CRP or insulin resistance, you can see 42% and 54% reduction with empagliflozin. And how about the NASH and NAFLD, which is the biggest challenge that we face up in our women population and men population throughout the world, especially in India? E-Lift, one of the studies, showed extreme benefit in reducing the hepatic fat content. So how about the NASH? Again, I mentioned it shows the reduction in the hepatic fat. Therefore, the NASH improvement is there in 24 weeks with empagliflozin. This is the data that is published in the recent AD8 concluded 2020, the new onset of OSA, which is, you know, that OSA and diabetes and OSA and heart disease, and the science has been evolving with the OSA being the primary place. If you take the respiratory disease as a whole, so with the people getting tummy wise bigger, and the OSA is getting an obstructive sleep apnea as a big challenge that we face up. Improvement of glycemia alone won't help, but in a people with OSA, the CVD improvement is also a major with empagliflozin. How about nocturnal uncontrolled hypertension, nighttime, daytime, and 24-hour BP? All are improved with empagliflozin as a primary molecule. So I went through an anti-inflammatory effect. I went through about the blood pressure one, and then about the hepatic fat content, and about the OSA. So these are all the extra effects, if you like, with empagliflozin. So this is the background that I've given you. Now, if you go for the main cardiorenal implications that I've shown you as a second slide, as the cardiac thing, starting with the atherosclerosis and going to cardiac and renal implications of this thing, and if you make sure that SGLT2 inhibition is there, and what is the advantage, I'll just cover across in the next 10 slides or so. In a patient with type 2 and increased cardiovascular disease, you can see this is the landmark trial that has given us hope about 10 years ago with EMPA-REG outcome. It's a meaningful early sustain. The thing that attracted me is the early benefit. You can see the graph. Out of the graph, the early rise that showed EMPA treatment has showed a benefit even with the early stage, and that proven to be showing the end result of 38% of relative risk reduction. So this is a cartoon that showed every single aspect of the heart reduction: fatal MI, fatal stroke, heart failure related death, sudden death, and presumed CV death, all are benefited in that 38% of risk reduction. So you'll compare all the CVOTs. The one good thing FDA has done for us is the CVOT trials come in, and these SGLT2, even before the launch, they have to come up with all this. And if you look at the EMPA-REG and the Vertis, both are exactly the same. The one thing about EMPA-REG, I would say, is 100% of the people who are enrolled in that is established CV disease. But I mean, you take a Declare-TIMI or a Credence, they've got a primary prevention patients as well. But if you want to identically match the trials, then it has to be Vertis CV with the recently concluded empagliflozin trial. But the benefits are mainly shown with the empagliflozin with the relative risk reduction CV death. It's not shown in empagliflozin, even though the class effect of heart failure has been shown to be benefited with empagliflozin. People come up with some sort of theories or why it is not got benefited. But however, I think the end result is the EMPA is the one which is the exact same cohort of patient, but the benefits are there with empagliflozin. So again, to show the top half of it is the ASCVD, which is the people who got CVD, established CVD, but no ASCVD. The EMPA won't come in this group because all 100% of the patients are all established CVD. So the MACE outcomes in SGLT2, it clearly shows most of the drugs have consistently shown benefit, but the effects are not consistently absorbed across the trials or across the patient with ASCVD, and that is the big challenge. So whoever has got a data for clearly ASCVD patients, it's mainly, I think, EMPA who's got almost 100% of ASCVD patients. So again, just to say, you cannot compare all these trials directly, but as I mentioned, with a p-value quite significant, statistically significant reduction, 38% relative risk reduction in all-cause mortality and also cardiac CVD and CVD death. So just to say, when you come to these group of drugs, each drug has got a specialized action. But I think for hospitalization for heart failure in SGLT2, there is a consistent improvement of heart failure outcome across all these SGLT2 trial, and that's quite reassuring. And also that made us these molecules to be used by cardiologists extensively now, even for people who has got no established heart failure or no established diabetes, if you like. They are starting the patients on SGLT2 inhibitors. So that is a good news. And again, the good news is all these group of drugs have got kidney outcomes in SGLT2 generally consistent with improvement in renal across the SGLT2. So you can, previous days that we will be worried where to use this group of drugs, but I think it is quite reassuring to know these group of drugs can be used even in the renal patients. So you can ask, okay, you are talking about all randomized or RCTs so far, and you compared with the meta-analysis and other things, but how about the real world data? You know very well know with all these recent meetings, the Scandinavia and Europe are the gold dust for getting the data when it comes to the real world, because the registries are maintained. And where I worked in UK, all the general practitioners have got a data of the patient. So the data what you want is real world. If that is, then the Scandinavian data is the best one. Out of that, you shows that the reassuring things, almost 60% of lower risk of serious kidney events with SGLT2 compared with the DPP4 inhibitors. And again, the large veteran affairs cohort study showed EMPA as reduced risk of major adverse kidney events compared to other drugs that is being used for treating diabetes as a disease as a whole. So I want to come back with the same point that in a patient with heart failure with a reduced ejection fraction or all established people, the robust evidence for 2 RCT suggests that SGLT2 consistently reduce with CV deaths or heart failure, regardless whether type 2 there or not. As I mentioned, cardiologists started using for people who are not even diabetics. That tells you how much recent evidence has come in that made them to get assurance that these group of drugs will be useful to reduce heart failure for people who are not even diabetics. So the 2 main bang-on trials are DAPA-HF and Emperor Reduced. Both are brand new trials that showed huge benefit, and the recent one is published only. Emperor Reduced is published in August 2020 in the Lancet. So we showed clear benefit. And again, I come to that my graph of my slide of the second slide that I mentioned about atherosclerosis, microalbuminuria, macroalbuminuric kidney disease, end-stage disease, and CV death. All these areas should be addressed. That is where all the big guidelines like EASD, ADA, and also other European Society Cardiology guidelines all come in, and they say you should not just go for glucocentric approach alone. You have to go with all these areas, and that's where the benefit is going to be. And the guidelines, if you look at it from 2016, they are not focused in glucocentric alone. Previous days, I think Dr. Venkatraman and Dr. Kalra was mentioning that the days have changed with the treatment. So they have focused mainly in GLP-1 and SGLT2. And if you look at the ADA standards of care in 2020, also showed clearly SGLT2 usage and GLP should be increased. And ESC and EASD, almost SGLT2 should be used as the level A evidence is available, so as a class 1 drug, which is like next to metformin. So or you can use along with metformin as a first group of drug if you according to all the other guidelines. So just to treat an algorithm lifestyle, first line you can add on SGLT2. I'm not here to say because it is a company related talk, but it is the drugs of currently in diabetes and endocrine world has been a hot drug to be talked about. So just pearls of wisdom very quickly before my last slide. So where not to use it, e.g. for below 45, pregnant and breastfeeding, stressful condition, and mainly the insulinopenic conditions you should not use, and risk of volume depletion. I would say inpatient who are going for surgery or all negative catabolic states and repeated UTIs and GU patients, and also concomitant use of insulin is the practice I would do, or I would use with some sulfonylurea. Just the last slide on my 14th minute. So if you look at it, the cardiovascular, renal, metabolic progress, the risk modification, the second slide I showed you that areas you should attack in each areas rather than just being glucocentric. And SGLT2 provides a holistic approach of the CV metabolic risk modification, and there is no doubt about it. And the preferential use of SGLT2 agents with the risk of CVD and heart failure and CKD in diabetes, amazing group of drugs. And to be specific, EMPA showed meaningful, significant people response in risk reduction of CVD, almost 36%, and the early benefits I showed you with the graph, and also the mortality in type 2 with the established CVD. It's an amazing news we've been practicing for almost 10 years. And then I mentioned about the real world evidence with Scandinavian trial, and that reassured what we are doing is the right thing. And when compared with the gliptin, it is less kidney damaging. And also there is each benefit from each diabetic therapy, but as Dr. Kalra summarized very nicely, we have to use group of drugs specifically with each condition. I stopped there, but in the last 15 minutes or so, I just went through with areas of cardiometabolic continuum, and also mentioned about the empagliflozin benefits, extra benefits about sleep apnea, and also inflammatory effects, and also about benefits in various other inflammatory markers. And I went through all the CVOT trial and meta-analysis, and also just specifically mentioning about EMPA benefits with EMPA-REG. I stop that. Thanks.
Thank you, Suresh. I think from the time that Sanjay finished his lecture, giving an array of options with justification for each set of molecule or each combination in dual or triple therapy, I think you did focus quite justifiably on the SGLT2 inhibitors in general and EMPA in particular. And it was very impressive that a molecule which is going to have a lot of metabolic benefits as comparable to a sulfonylurea, and which could be a molecule of consideration in the early part of the disease, and which is durable as well, and which has got attendant benefits of weight loss, etc., has an effect on the BP. Especially your slide on the nocturnal dip was quite pertinent, because absence nocturnal dipping is a physiological phenomenon. This is last in diabetics, and previously used to say that diuretics restore the nocturnal dipping. I think when you have a molecule like EMPA, which restores the nocturnal dip, at the same time with attendant benefits, I think the choice is much more, you really emphasize that point. And then when you have a dedicated cardiovascular outcome trial, even though it was exploratory as one of the components of the primary MACE, the cardiovascular death has not been witnessed with any other molecule. The primary MACE has been there in the atherosclerotic population with canagliflozin. And again, even though it was exploratory, in the case of EMPA-REG outcome, the renal endpoints were as much robust as with the primary endpoint in the credence. In other words, we have a class of molecules which have got a class effect with respect to heart failure and the kidney protection. And with the molecule in question about the EMPA, which you nicely highlighted as one of the initiating options, because it has proven its worth in the early part of the disease, has the potential to modify the disease, has had a telltale effect with respect to endpoints, the primary MACE, as well as one of the components of the primary MACE, even though it was exploratory, CV death. I think with this, you justified that this could be a good worthy option. I think we are running short of time. Maybe a question or two. Is it allowed? Already we are, I think, 15 minutes behind schedule. I think if there are no questions or comments, we will conclude this session. And I would profoundly thank Sanjay and Suresh. As Sanjay, just to sum it up, it was wonderful the way your perception and your interpretation of the truth, as you projected the molecules in a very, very, what shall we say, without a bias, just the science behind it, and also integrate the various aspects which are very relevant in the clinical practice. And subsequently, Suresh took up the aspect of the cardio-renal metabolic conundrum, and then highlighted the data that was very, very compelling evidence to position this molecule probably in comparison with other contemporary molecules, even in the early part of the disease, and continue them for the attendant benefits. I thank both the speakers, and then thank you all for staying with us. I hope it was a good learning exercise in the last 45 minutes with respect to the therapeutic journey that Sanjay and Suresh attempted to deliver in the last 45 minutes. Thank you so much.
Thank you so much, sir.
Thank you.
So the next session will be food for thought. To chair the sessions, I invite Dr. R.S. Hariharan and Dr. S.S. Lakshmanan. And may I have their slides, please? Yes, Dr. R.S. Hariharan is a leading diabetologist and physician in Chennai, and I'm not able to get their slides. And Dr. S.S. Lakshmanan is also a senior consultant, a physician and diabetologist. So I invite both of them to chair the session. Over to you, sir.
Dr. Hariharan, are you there?
Hariharan?
Professor Hariharan, are you there? So I think there has been some connection loss.
Am I audible?
Lakshman, yes,
Yeah,
sir.
you're audible, sir. You're audible.
I'm audible, yeah. Venkatraman, I'm audible now?
Yes, sir, you are, sir.
Yeah, very good.
Kindly start the show, sir. Please, you can start with Raji Goyal.
Yeah, good afternoon, ladies and gentlemen. In fact, at the outset, I would like to thank Dr. Vijay Kumar for giving me this opportunity this afternoon and also organizing such a beautiful program. As always, there's been a yearly program from his side and well represented. And I've been, this particular session, there are two speakers. One is Dr. Rajiv Goyal, and the second one is my friend, Dr. A.K. Das. And my co-chairperson is Dr. S.S. Lakshmanan. Now, regarding Dr. Rajiv Goyal, he's the director of the Dr. Kovil's Diabetes Care Center and also a consultant in most of the major hospitals in Bombay, such as Nanavati, S.L. Raheja, Bharati Arogyam Nidhi Hospital, Global Hospital, and KLS Memorial Hospital. He is an invited faculty in Diabetes Fellowship Program at Patel Medical College. And he is going to talk to us on a new normal of diabetes management or gliptin's best fit. I think we have been listening to gliptins even during a couple of lectures earlier by Shashank Joshi. Now, he is going to focus this on the new norm of COVID era. I invite Dr. Rajiv Goyal to present this talk. Dr. Rajiv Goyal.
Thank you so much, Dr. Hariharan. Thank you, Dr. Lakshmanan. Thank you, Dr. Venkatraman, and thank you, GVK boss, for having me here. I'm here to speak on, one minute, I always get stuck here because the necessity is the mother of invention, and we all were technologically geek or naive before this whole pandemic came in, and this threatened not only our lives, also our livelihood. And that's how we have become now really like engineers. So the new normal, how do different gliptins fit in is, I also would like to thank MSD and BG Nair for supporting this talk. This is the agenda that I'm looking at, where I'm going to discuss the challenges that we are facing in treating patients, with patients and HCPs as well, discuss the role of gliptins in managing this period of new normal. We all know that the COVID-19 virus hijacked one of the endocrine pathways, which is ACE2, and there is speculation that probably also the DPP4 pathway, because ACE and DPP4 substrates are seen in the heart, in your cardiac muscle, in your pancreas, and everywhere. I'm also discussing easier options how to adopt and how we could incorporate the state of the care in gliptin, sitagliptin in our day-to-day approach. So I don't know how many waves we are going to have, but as far as today, we have 91.95 lakhs people affected. That is almost more than 9 million affected in India, with almost 1.3 lakh deaths. So we are looking at a huge population. And as the waves come in, we are going to get into a lot of trauma. We are not only facing dangers to lives, to livelihood, to disability payment, to so many things. So there's going to be trauma, mental, psychological, economic, and burnout. So now probably it's time to gear up and probably accept this new normal. And I believe hygiene will be the next biggest domain when it comes to, and we need to kind of gear up to face these challenges with our healthcare delivery. So what has been the key challenges between patients and HCPs? Again, we have frequency of visits have gone down, and we as physicians actually depend upon the number of patients, reduce access to monitoring. Some patients may be at higher risk for infections, as we have seen that till now we knew that diabetes drives the global cardiovascular and chronic kidney disease epidemic, but now we know that infections is also a huge
disorder or a complication of diabetes, and especially influenza-like illness like COVID. Resource restriction for chronic disease management, stress both for patients and HCPs, and telemedicine seems to be one of the most feasible possible solutions that we are seeing. And telemedicine basically means delivery of healthcare services where distance is a critical factor. And today, RMP using telemedicine shall uphold the same professional and ethical norms. This came in the telemedicine and online consultation as a routine came in the end of March and updated in the first week of April. The Ministry of Health is also going to come up with an online program. In the next 3 years, we all are supposed to apply and get this online mandatory program updated on our CV so that we can progress to telemedicine in the future as well. What are the certain prescribing guidelines? We have list O, list A, and list B. Certain prohibited list also cannot be prescribed. Like when it started, it said that injectables could not be prescribed, but fill up prescriptions, follow up medication, especially chronic care, diabetes, skin, has been, and where you may not actually need to physically examine a patient, has really picked up on the telemedicine platform. What could be some of the key characteristics of medications used for remote consultation? Again, we should have minimum or no impact on possible infections or interactions. So the first golden rule for any clinician, whether you do telemedicine or face-to-face consultation, is first, do no harm to the patient. Give advice as simple as possible. Give drugs with the least amount of drug-to-drug interaction and adverse drug effects. Give them clear-cut guidelines about sick day management, easy dosage regimen. Diabetes is always doing simple things right. Drugs which are well tolerated, efficacy which has the broadest range in patients, and again, drugs which have a longer durability and low glycemic fluctuations. If we look at the consideration of the potentially metabolic drugs that we are using, insulin therapy, if it's on, should not be stopped. Patients should at least monitor pre-meal. Careful, adjust regular therapy if appropriate, reach therapeutic goal according to diabetes type. Metformin has shown a lot of wonder during this pandemic, but again, if the patient is in a storm or in a shock or pre-renal or dehydration or lactic acidosis, you need to stop it. Patient is vomiting, having diarrhea, you should stop it to prevent the risk of acute kidney injury and also the theoretical risk of lactic acidosis. SGLT2 inhibitors in mild to moderate COVID times, no problems, you could continue the drugs. But again, if the patient is in hospital and would have probably a respiratory illness or dehydration, prevent it to prevent any kind of kidney injury. GLP-1s, most of my patients who have encountered COVID and are on GLP-1, I have removed it just because you don't want their appetite to be further suppressed, and the upper GI effects of GLP-1 may sometimes be masked because of COVID. And so I have put all of them on insulin. DPP-4 inhibitors have emerged as the drug of choice, though there is no specific guideline coming from any particular agencies or associations globally, but a lot of food for thought that probably DPP-4 inhibitors seem to be an agent which may not interact and may actually reduce the viral replications of COVID-19. If we go back to the MERS epidemic, that was Middle Eastern Respiratory Syndrome, and where the intermediate host was camels, and it was mainly in Jeddah and Middle East. Somehow it did not pick up, the virus did not spread in Africa, where there's a huge amount of camel being used, and ideally people thought that the whole pandemic would spread into Africa. One of the reasons given was the DPP polymorphism in African people, because the MERS COVID virus looked at DPP-4 as an entry into humans. There is a lot of speculation that probably even during COVID, apart from ACE2, there may be other modes of entry, and therefore DPP-4 inhibitors may have a possible boon kind of a role in this pandemic. Key advantages of gliptins: generally effective across type 2 diabetes spectrum. Again, irrespective of renal health, age, gender. Efficacy is also observed in long-standing diabetes. Regimen is very, very simple administration. 99% of our patients do well, so we're not going to get side effects, or we're not going to get hypoglycemia because they are insulinotropic, very durable drugs, minimum failure, and I don't remember failure with DPP-4 inhibitors. Now, what are the key determinants or the flowchart in our minds when we actually look at prescribing a gliptin in this new normal, where you may not actually see patients face to face? You need to give simple guidelines to patients. You need to make sure that the patient does not develop a drug to drug interactions. Most important thing is tolerability. Different gliptins have different PK/PD and may exert different effects. That's a very important thing that one should consider. All AC inhibitors are not the same. There's a lot of differences. All ARBs are not the same. There are differences. We know which one to use to prevent kidney disease, which one to use in LV remodeling. Similarly, all SGLT2 inhibitors are not the same. We know which one to use to prevent diabetic kidney disease or progression of kidney disease, and which one to use in heart failure. Similarly, there's a lot of differences in gliptins. We should look on possible drug-to-drug interactions, especially when we are doing remote consultation. We make sure that the patient gets a good efficacious drug and is durable. Access to treatment and availability is also extremely important in these times. Now, if you look at all the drugs which are available today in India in the gliptin domain, you look at sitagliptin, which is the standard of care as far as DPP-4 inhibitors go. Again, minimally metabolized, primarily renal route, no hepatobiliary involvement. If you look at Vildal, largely renal route; Saxa, primary renal route; Lina uses the hepatobiliary route, and Teneli uses hepatobiliary as well as the renal route. Now, if you look at how the metabolism occurs, sitagliptin again is unchanged in renal excretion. Again, no clinically relevant drug interaction. Saxa is a strong cytochrome 3A4 inhibitor, and it can have drug-to-drug interactions. Therefore, if you're prescribing a digoxin, ketoconazole, or a diltiazem, always look at reducing the dose. Linagliptin is excreted through the hepatobiliary route. Again, use of alternative treatment is strongly recommended when administered with strong B-glycoprotein inducers, example rifampicin. So these are certain parameters we need to keep in our mind. Another important thing that we need to keep in our mind, which teneligliptin has opened our eyes to, is QTC prolongation. Almost 30 to 40% of our patients have some form of QTC prolongation. Cardiac autonomic neuropathy is a reality, but we do not check or diagnose cardiac autonomic neuropathy, and a lot of our patients go into sudden cardiac death and arrhythmic deaths without realizing. And the pharmacovigilance in our country is so poor that drug-to-drug interactions is something which we cannot pick up. There are so many patients who go into arrhythmia, serotonin syndrome, and we may not be able to pick them. So it's extremely important that we prescribe drugs which do not prolong the QTC at all. This is a data which got published almost a decade back, and it looked at the cardiovascular safety of gliptins versus patients who are exposed to sitagliptin versus non-sitagliptin users. It's a pooled analysis of 25 blind studies and double-blind studies, out of which 22 of them looked directly at sitagliptin versus placebo, and the other ones looked at sitagliptin versus SU users. So the cardiovascular safety of gliptins have not been analyzed in a large scale real world evidence, and here this is a pooled analysis which looked at 25 double blind studies, and if you look at the number of patients is almost 15,000. If you look at the exposure and incidence rate of cardiovascular events as compared to sitagliptin users versus non-sitagliptin users, it's very much in favor of sitagliptin. So again, there's no cardiovascular signal towards on sitagliptin usage to any cardiovascular signal which shows that there is some effect. when we compare the cohort of sitagliptin users versus SU users or SU initiators, you see that sitagliptin is superior to SU in terms of cardiovascular safety. So two big takeaways: one, as compared to placebo, sitagliptin is CV neutral, and as compared to SU in this kind of a pooled analysis where they have two cohorts, sitagliptin is better. If you look at a similar kind of analysis of pooled events from linagliptin from 19 clinical trials, you can see that the safety analysis again shows that linagliptin is safe in patients with type 2 diabetes and coronary artery disease. This publication, which was a meta-analysis which looked at 67 randomized controlled trial, and this came on the back of two of those studies which were the SEVOR-TIMI and the EXAMINE, which said that there were increased hospitalization for heart failure in patients who were at high risk for heart failure. And this came on the background of that you had a meta-analysis of 67 RCTs where 20 belonged to sitagliptin, 27 to Vilda, 8 to Lina, 8 to Allo. And if you look at it, a trend for an elevated risk of cardiac disorders with gliptins was noted, though it did not reach statistically significant. Again, a significant elevated risk of vascular disorders was noted for linagliptin. So when you see this, there is no uniform trend which comes in. Gliptins are different. Their drug interactions are different. Their pharmacokinetic and pharmacodynamic variability is different, and hence they are different. So if you compare the cardiovascular outcome studies of all of them and you put them into perspective, you can see that the TCOS had an upper bound of confidence interval never crossed 1.3, which was the mandate by the US FDA in 2008 when they came up with the ruling. But if you look at the other red signs, which you can see on the slide, a lot of times it has almost got close or has exceeded the confidence interval of 1.3 in many of the parameters which were assessed in cardiovascular outcome trials with other gliptins as such. And if you look very, very closely or you dissect the data from Carmelina, which looked at linagliptin versus placebo, the upper bound of hazard ratio crossed 1.3 in the age groups of less than 65, and again it crossed when the eGFR was between 30 to 60, and again in patients whose HbA1c was 8%. So there was no uniformity when it came to linagliptin in the Carmelina trial. And if you compare that to TCOS, it's a very, very straight trial done by the Oxford group, headed by Rory Holman, who also gave us the UKPDS study. So again, very, very straightforward trial, no variations in any of its parameters or any of the elements which make up the 3-point maze. If you look at the impact on kidney, the Marlina 2D trial, which actually was a trial very similar to the Credence, which looked at patients with an eGFR about 30 and urinary albumin excretion rate between 300 to 3000. And you looked at and whether linagliptin, because of its pharmacokinetic safety as compared to renals, would have beneficial effects in reduction or progression of chronic kidney disease, and it did not show anything. When you compare it to TCOS, again, there was no difference in eGFR between placebo and the sitagliptin arm, again showing neutrality of sitagliptin when introduced in patients with chronic kidney disease. Carmelina, on the other hand, there were patients who had a sustained increase in eGFR, decrease approximately 0.2% absolute difference between linagliptin and placebo. Again, didn't reach statistical significance, but there were some variability in the results as such. If you look at this cohort study that included initiators of DPP4 versus non-DPP4 treatment, again, this comes on the background of the SEVOR-TIMI and the EXAMINE study, that a lot of eyebrows were raised on gliptins and you got a complete black box warning on heart failure. You look at this cohort study, where 83% of patients were on sitagliptin, and it was primarily driven by sitagliptin. If you look at all the components of cardiovascular disease, whether there is cardiovascular death, MI, stroke, heart failure, and all-cause death, all are towards the left side of Unity, again showing that the cardiovascular neutrality of sitagliptin. And if you look at why did some of the gliptins have their role in heart failure, probably the answer, see, it could be a play of chance. It could be related to the non-specificity of some DPP4 inhibitors. So there is DPP9 expression in human tissues, in heart, liver, and skeletal muscle. SAXA was associated with a 27% increase in hospitalization of heart failure. It was mainly seen in patients with a lower EGFR, long-standing diabetes, and higher HbA1c. Saxagliptin was found to impair cardiac muscle contractility by reducing calcium content in the sarcoplasmic reticulum and diastolic calcium overload, as well as prolonging the action potential duration and consequently the QTc interval. SAXA, but not SITA, was found to impair the calcium ATPase axis in the cardiac myocytes via DPP9 inhibition. The VIVID study, which finally got published in 2017, again looked at the smaller group of patients, but again what VIVID was with vildagliptin in ventricular dysfunction in diabetes trial, very similar to the DAPA-HF, where you had patients with reduced ejection fraction. But what it showed, that there was a non-significant increase in the end diastolic volume. How much clinical implications it has, it was not a long study for it to actually bring about the clinical difference, but a non-significant greater number of patients in the Wilda group died from cardiovascular causes and from any cause. So if you look at in vitro selectivity of DPP4, you will see that sitagliptin is far, far more selective to DPP4 as compared to DPP9. That's probably the reason that there is neutrality in all components of the maze when it comes to sitagliptin in the TCOS study. And when we talk about QTc prolongation and type 2 diabetes, the normal QTc is less than 430 in men and 450 milliseconds in women. And you can see, we call it as QTc prolongation when it's more than 450 and more than 470 in women. QTc prolongation is seen in 44 to 51% of diabetics. QTc gets prolonged again when we have a drug-to-drug interaction, mainly with many antipsychotics, long-standing diabetes. And this is something which we normally cannot pick up in our day-to-day practice. And it's very important that we do not have the kind of pharmacovigilance in our country. That's why we prescribe safer drugs to our patients with lesser drug-to-drug interactions, so that they do not face the burden of a sudden cardiac death. So there is a huge reason that we should be prescribing drugs which do not prolong QTc. And if you look at cardiac autonomic neuropathies, this is a study which said that the prevalence is more than 90%. And if you look at the QTc dispersion between type 2 diabetes with autonomic neuropathy versus type 2 diabetics without autonomic neuropathy and control, there's a 25.5 millisecond difference. And that's something which normally we cannot pick up in a clinical practice as such. So if you look at the QTc study of SITA versus teneligliptin, SITA at the highest dose, that's 8 times the dose which is prescribed, could not prolong the QTc, while Teneli at 4 times the dose that it is prescribed is able to prolong the QTc quite a bit. And the active comparator was moxifloxacin. As you can see, moxifloxacin is known to prolong the QTc much, much higher. Now, again, in the COVID pandemic, we have realized there are a lot of drugs which can actually interact with our anti-diabetic therapy. Insulin is the safest. When it comes to the OAD, it's metformin and DPP4 inhibitors, because of a lot of drugs, I'm not going into details, which can actually interact and cause a lot of vascular burden on our patients with diabetes. If you look at the DPP4 inhibition over 24 hours, how much DPP4 stays inhibited over 24 hours, lesser the DPP4 inhibition, higher the DPP4 activity. Only sitagliptin has demonstrated more than 90% trough DPP4 inhibition among DPP4 emitters available in India. Thus, it will have more effect on the beta and alpha cells, and thus it would be much, much efficacious as comparable to other class. If you look at the comparative efficacy in HbA1c, very similar. Indians are supposed to be having a higher incretin defect. If you look at comparison to the other oral anti-diabetic drugs, very similar efficacy, whether we compare it to an SGLT2 inhibitor or a TZD or a voglibose or metformin. Again, even head-to-head, gliptins almost have numerically the similar amount of HbA1c reduction, whether we use it as monotherapy or as combination therapy. Again, when it comes to diabetic kidney disease or CKD, we know that we can use gliptins even in the stage of an EGFR less than 15. We need to just tweak the dosages. Again, the only drug which has been seen to be durable and efficacious at 3 doses of gliptin without any affection on the EGFR has been sitagliptin in this study, where patients were followed up for at least 4 years. And again, in patients with peritoneal dialysis or on hemodialysis, sitagliptin has been shown to be efficacious as such. Again, better treatment adherence than conventional treatment when we look at gliptins, because they are easy to use, no hypoglycemia, no drug-to-drug interactions. Patient will not call you with adverse events, and hence the durability is much, much better. I would like to conclude saying that gliptins, especially in this pneumonia new normal, continues to be a viable option. Among the gliptins, sitagliptin stands quite tall as compared to the other gliptin. While choosing a gliptin, is important to employ careful selection criteria and individualization to ensure that the patient gets an effective and safe agent. Thank you so much. Over to you, Dr. Lakshmanan.
Thank you. Thank you very much, Dr. Kovil, for a very nice, I should say, an exhaustive presentation. In fact, an overview of gliptins with a special emphasis on the COVID times. We'll move on to the next speaker. I'll request Dr. Lakshmanan to introduce the speaker and the topic. Dr. Lakshmanan.
Thank you, sir. Thanks, Dr. Vijay Kumar and the 3D team for giving this opportunity. It's my pleasure to introduce Dr. A.K. Das, a good friend of mine. He is presently the Professor of Medicine, Professor and Head of the Endocrinology, Pondicherry Institute of Medical Sciences. He was former Senior Professor of Medicine, Endocrinology, Head of the Department of Endocrinology and Dean, and Medical Superintendent of Jawaharlal Institute of Postgraduate Medical Education and Research in Pondicherry. Dr. Das has taught the medical undergraduates and postgraduates in medicine and diabetology for more than 33 years. He is the member of Physicians Research Foundation and Association of Physicians of India. He is a patron of RSSDI. So, stage is yours, A.K. Das. Please welcome.
Thank you. Thank you. My esteemed chairpersons, Professor Hariharan and Professor Lakshmanan, and my thanks to G. Vijay Kumar and the entire team of 3D for inviting me. Dear friends, I'm going to I think I must tell you that I'm going to speak about something which is very close to my heart, and it's about how do we protect our kidneys. Dear friends, I have timed it. I'll speak for about 18 minutes, and I'll be done away with that. Then we can have some question answer. Dear friends, in the beginning, I must say that the kidneys are the most important component of diabetes care. If you take 422 million of diabetes, you find about 30 to 40% of them will develop chronic kidney disease. And you see in the other side, the number of deaths due to the kidney failure has increased in certain population by 94%. Now, if take from the side of the kidney disease, the diabetic kidney disease is the most important contributory challenge even for the chronic kidney disease. Now, one of the Indian document, the Indian Chronic Kidney Disease and the Transplant Dialysis Registry has shown that amongst all the patients for 10 years, the prevalence of diabetic nephropathy was the highest at 31% for the transplant and dialysis. Now, therefore, the diabetic kidney disease has contributed to the increase in dialysis and the transplant. And to make a long story short, I must show here that the early CKD brings down the life by 6 years, the diabetes by 10 years, and both together by 16 years. That's the importance of the kidney disease. And that's the reason for this talk, how do I protect my kidneys? Dear friend, I must also mention that people with diabetes is 6 to 12 times more likely to be hospitalized for either for the chronic kidney disease or for the ESRD compared to anything else, heart failure, IHD, AMI, CVD, only second people to be hospitalized for the diabetic foot disease. It is number one cause for the incidental disease in the transplant program. And if you take heart failure, the heart failure occurs on a fertile soil of diabetic kidney disease. And you see that heart failure by age groups with diabetes and no diabetes. With diabetes, see it is much higher, no diabetes much lower. And if you see the mortality with diabetes, mortality is higher than without diabetes. And about the various causes of death in diabetes, when the CVD we say it responds to 70% of the death, majority of them has become the chronic kidney disease. Now, let us examine how do the proposed mechanism of diabetic kidney disease, both from the diabetes mellitus point of view and from the CKD point of view. Now, diabetes mellitus gives rise to chronic kidney disease because of the hypertension, atherogenic dyslipidemia, endothelial dysfunction, hypercoagulability, chronic inflammation, and oxidative stress. The CKD gives rise to chronic kidney disease, the perpetuous chronic kidney disease because of the volume overload, calcium phosphorus derangements, hormonal imbalance, anemia, uremic toxins, and also alteration in the RAS and the nervous system and its overactivity. This cartoon shows the risk of mortality, cardiovascular, and renal outcomes in the kidney disease. You see the USCR less than 30. See the hazard ratio. Now you see the incidental disease at the cardiovascular mortality is higher, and you look to the all-cause mortality is higher. So this cartoon depicts that as the creatinine, the albumin excretion rate rises, the mortality increases. And the kidney disease has been classified according to the eGFR, normal being 90 and ESRD being 15. And this is an indication how do we treat our kidney disease. Here is most important fact, how do we protect our kidney disease? Most important is the glycemic control and what drug we use. There are many drugs that can be used. The control is important, I do agree, but there are certain drugs which gives a lot of benefits. We will discuss in this talk, and the prominent among them is the SGLT2 inhibitor. Now, you may ask me whether all SGLT2 inhibitors give the similar benefit. The answer, yes, there is a class effect. The DAPA kidney, the EMPA kidney studies have shown their beneficial. However, the canagliflozin through its canvas and the Credence trial have shown some extra benefit, but I won't deny the fact there is a class effect. The other benefits, the way you can protect your kidney is definitely by the RAS blockade, by the blood pressure control, the lipid management, a good lifestyle and good physical activity, smoking cessation, appropriate nutrition, and aspirin for the cardiovascular disease. So my dear friends, as you already know, I cannot overemphasize the fact that from RAS blockade to nutrition is as important as using a molecule like SGLT2. This we cannot forget. Few 4-5 slides, I'll be driving home the point. Therefore, the cream of kidney protection, the cream de la cream on 4 factors: optimal glycemic control, optimal BP control, use of ACE inhibitors or ARBs or SGLT2, and optimal protein intake, which cannot overemphasize. Dear friends, if you come to the glycemic control, this is the famous EDIC trial. It has shown that early glycemic control has reduced the long-term risk of impaired GFR almost up to 50%. See the conventional therapy and the intensive therapy, there's a 50% risk reduction with intensive therapy. I've just taken one prototype. Similar thing was shown in the UKPDS, shown in the STENO2 trial. Therefore, glycemic control is of paramount importance to control or to protect your kidneys. ACE inhibitors in type 1 with microalbumin reduction showed that it reduced also the progression of the clinical proteinuria. Therefore, compared to placebo, we find that the ACE inhibitor, namely captopril, reduced the progress of the kidney disease. Similar thing was observed in type 1 diabetes with the as regards the renal outcome. The renal outcome also were shown to be reduced compared to placebo with the captopril-DS inhibitors. As per type 2 is concerned, similar thing was observed in type 2 diabetes with macroalbuminuria. It was observed that the ARBs compared to placebo reduced the macroalbuminuria, and not only that, it also reduced the renal outcome. Therefore, ACIs and type 1s, ARBs in the type 2 are of paramount importance. Now this also again shows the ARBs in the type 2 diabetes mellitus reduced macroalbuminuria and improved the outcome. Then comes the drug that we have to focus today about the SGLT2 inhibitors. Dear friends, SGLT2 inhibitors produces a host of benefits, and I'll describe them very briefly to say that it produces benefit in the ways that we see today, that you will find that it produces glycemic control, it gives rise to hemodynamic control, it produces weight loss, and also it gives rise to it also gives rise to antioxidant effect, anti-inflammatory effect, anti-fibrotic effect, hyperuricemic effect, and RAS inhibition, and anti-natriuretic effect. So dear friends, this myriads effect, most important glycemic control and the hemodynamic control, anti-inflammatory, antioxidant, and the anti-fibrotic, minimal RAS inhibition gives rise to much beneficial effect of this molecule. This is a very key slide. I have shown here how the renoprotection in type 2 diabetes occurs with the risk factors. Look at the secondary prevention. You find that the progression to albuminuria as far as secondary prevention was confirmed was much less in the patients who were given canagliflozin compared to people who were given placebo. Look at the primary prevention. The canagliflozin produced much less albuminuria compared to the placebo. And if you take the overall population, you find that also was 90 compared to almost 130 in the placebo. So progression to albuminuria was much less, both in the secondary prevention, primary prevention, and overall population by giving this molecule canagliflozin. If you come to the issue of the renal replacement therapy or reduction of the renal death and 40% reduction in the eGFR together as composite, you find that with canagliflozin in the secondary prevention, it was 6.4. It was much higher in the case of placebo. That means there are more RRT, more renal deaths. Compared to primary, it was 4 versus 6.6, and overall 5.5 versus 9, showing that these three elements also are much better with the canagliflozin. Come to only 40% reduction, you again find that both in the secondary prevention, primary prevention, overall population, the canagliflozin was much better. Therefore, if you go back to the Fresnel chart, you will find that the drug canagliflozin is favored to reduce the DKD's progression, and one can protect the kidneys. Now, if you look to the reduction in the progression of the diabetic kidney disease and the induced reduction of the albuminuria, which is one of the most important facets of knowing what's happening with the canagliflozin, you will find that there was 27% reduction compared to placebo in canagliflozin. We could reduce the progressive albuminuria in about 27%, say almost about 1/4 to 1/3 cases. Now, if you look to the regression of albuminuria, you will find compared to placebo, it was 1.7 times higher. That means you could reduce the regression of albuminuria by instituting this drug 1.7 times more than the placebo. Now, dear friends, therefore, an article published described that there's a big win for the diabetic kidney disease with the CREDENCE trial, and the JDI also published saying that CREDENCE is a silver lining in the clouded sky of the diabetic kidney disease. dear friends, I like to crave your indulgence for this most important trial, which establishes molecule in the diabetic kidney disease protection and diabetic kidney protection. This is the CREDENCE trial. I put a different way to emphasize some points. The canagliflozin and the renal outcome in type 2 diabetes and nephropathy trial. Now, it included about 4,400 patients of type 2 diabetes with a greater than 300 urinary albumin excretion. The age was about 62 years, and you find that the eGFR was 57. I'll come back to this point. And the albumin excretion median was about 927. And it was these people were already stabilized on the ACE inhibitors or ARBs for at least 4 weeks. So this drug was given over and above these ARBs and ACIs. There was a crossover study between canagliflozin and placebo, and see the primary outcome, that is doubling of the serum creatinine, very important parameter, end-stage kidney disease or death due to cerebrovascular disease or kidney disease. You will find the hazard ratio was 0.7. And I must hasten to add, the number needed to treat to achieve this was 21. If you treat 21 patients, you get at least in one patient this huge benefit. And of course, the ESRD hazard ratio was 0.68. Therefore, in either way, in the primary outcome and in the ESRD, this drug was very beneficial. NNT for the ESKD was about 42, and there was the hazard ratio for the amputation and the fracture were much less. Therefore, dear friends, it has been also today established that the canagliflozin is a safe drug. Now, in the pre-CANVAS trial, we did not have any signal of amputation risk in more than 8,000 patients. In the CANVAS trial, there was some signal, but the CREDENCE trial, there was no significant increased risk of amputation as compared to placebo. Therefore, in the latest update in the August this year, August 2020, the FDA has removed boxed warning about the risk of amputation for the canagliflozin. So, dear friends, I want to emphasize there is no increased risk of amputation with this molecule. Now, coming to the various other facets of the primary outcome, you will find that that there is a 30% reduction with the canagliflozin in the ESKD, doubling of serum creatinine, renal and cardiovascular deaths. Now, I'll show it more emphatically when I said that if you give a baseline and placebo, you find the eGFR decline by about minus 4.5 ml per year. Whereas this drug, canagliflozin, the eGFR reduction was about minus 1.5. That means this drug was very beneficial. The 60% reduction in the rate of eGFR decline was very beneficial. So eGFR decline reduced by 60%. Now if you look at the major cardiovascular events, CV death, MI, and the stroke, you will find here that there is a 20% reduction in this. Dear friends, as some time back Rajiv said about the DP4 inhibitors, it depends upon how the various molecules have described their benefits. If you come to the dapagliflozin, they have said from the previous declared TB to the DAPA-HF trial, they said that this is primarily for the heart failure. Other benefits came with the DAPA kidney trial. Empagliflozin as also shows that it is for the longevity and effect. But EMPA kidney has said it has also effect on the kidneys. Both the molecules said they have effect on the heart. Now coming to canagliflozin, I'll hasten to add that there are about 10 lakh patients where this study also has shown equally good cardiac benefit. So I allude to the fact that this is a class effect. Now all the benefits are listed here: doubling of the serum creatinine, ESKD of the eGFR less than 15, and dialysis initiation or the transplant requirement, renal death or the CV death, hospitalized heart failure, and other vascular events. And you find the ESKD, doubling of the serum renal death. The canagliflozin was favored in this trial, meaning thereby the great benefit of this drug. Now coming to the heart failure benefits, you will find the great benefit was there. You find if you take 46 patients, there was benefit in the heart failure. So the in all aspects, primary composite outcome, end-stage renal disease, doubling of the serum creatinine and renal death, and also a very advanced end-stage renal disease or the severe death, MI and stroke, this drug was very beneficial, equal to the other SGLT inhibitors, a little better possibly. I'll come to it in the kidney disease, and the number needed to treat were very small to get the benefit. Now here, if you compare the CANVAS and the CREDENCE trial with the DECLARE and the EMPEREC trial, you see the patients here had much lower eGFR compared to the other trials, and the albumin excretion was much higher. And if you look to the RRT that were required in these patients, DECLARE did not report, but you see the CREDENCE patients had already undergone higher RRT requirement. That means there was a much sicker patient as far as kidney was concerned. Now, canagliflozin reduced the eGFR decline and the need for dialysis, and you find now it's a beautiful projection from the statistics. You will find minus 1.85 ml per year, contrast to minus 4.59, and you will see here the life gain by this was almost 15.1 years. Therefore, average patient would delay development of the eGFR 10 by over 15 years by taking canagliflozin. So you can give a 15.1 years of extra life. Coming to the last part, I have got 3 minutes left. I'll just give the ADA guidance on the CREDENCE. It is clearly said very simply, for patients with type 2 diabetes and diabetic kidney disease, consider use of an SGLT inhibitor in patients with eGFR more than 30 ml per minute, and particularly in those with albumin excretion more than 200 milligram, and to reduce the risk of CKD progression, cardiovascular events, or both. Dear friends, I want to make it clear, we did not start the drug below eGFR of 30, but if it is already there, it can be continued even with 30. That's the distinct advantage of this drug compared to others. Now, in August 2009, the ASC guideline updated to recommend this drug as the first line treatment. I'm talking SGLT2 as a class. This drug should be recommended in patients with type 2 diabetes mellitus to prevent CVD or very high severe risk, such as those who have target organ damage and where the treatment naive or already metformin. The treatment naive, drug naive patients with higher atherosclerotic cardiovascular disease risk, you can give SGLT inhibitor. We have metformin monotherapy, but this guideline recommended this drug, the SGLT inhibitor, as the first line drug. In the people are already on the monotherapy and they have higher ASCVD, atherosclerotic cardiovascular disease, or severe risk, very high risk, then you can add SGLT2 to the existing therapy. Now, in September 2019, it also said that indication to reduce the risk of ESRD, doubling of serum creatinine, severe death, and hospitalization for the heart failure in adults with type 2 diabetes mellitus and diabetic nephropathy patients with albuminuria more than 200 milligram per day. This drug is wonderful, and you must continue the therapy in patients with eGFR equivalent to or less than 30, equivalent or to more than 30, and even until initial dialysis, but it can be given up to 30 ml of the EDSR. American Society of Nephrology in the Kidney Week in November 2009 and said that impact of canagliflozin on eGFR slope in people with optimized glucose control, it showed that CREDENCE delivered a great benefit. And the effect of canagliflozin on the eGFR over time, you take two groups of patients where the HbA1c was more than 7 or it was less than 7, you find in both the groups the benefits of the SGLT2 inhibitors, namely here canagliflozin in this trial was sustained. That means the beneficial effects of canagliflozin was irrespective of the baseline HbA1c. Therefore, the great news. And also, if you take the patient, there were some patients who had eGFR of 30 ml. To name, there were only 4 patients in the entire trial. In that 4 patients, it was also shown the reduction in the rate of eGFR decline, even it was given at less than 30, because in the 4 patients in the entire trial, it showed reduction in the eGFR of 43%. Dear friends, I must add here, the CREDENCE trial also showed the effect on the albuminuria. You find that the albuminuria reduced and declined, and this durability of the albumin reduction was seen up to 3.5 years, 42 months. Like we say, glycemic durability, the albumin reduction was manifest up to 3.5 years. Now DCGI, Government of India, has approved that to reduce the risk of ESRD, doubling of serum creatinine, severe death, and hospitalization because of the heart failure in adults with type 2 diabetes mellitus with diabetic nephropathy with albuminuria of more than 300 milligrams per day, this drug is indicated. And that is the end of my projection. And you see, I've just given a small seed here about the protein that you will allow for the patient, 0.6 to 0.8 gram per kg body weight, to emphasize that this drug needs to be also supplemented by the other things I showed at the beginning: good lifestyle, nutrition, physical activities, air big, of course, good BP control, good glycemic control, and reduced protein intake. Dear friends, that's my message, that we have the drug of this class, SGLT2 inhibitors, which are wonderful for the kidney protection, in addition to the heart protection and the glycemic control. Therefore, dear friends, I just took for example the canagliflozin and the CREDENCE trial, which has shown a very special position for the canagliflozin for protecting the kidney, but this similar effect is also found with the DAPA and EMPA, little better possibly with the CREDENCE trial. Thank you very much for a patient hearing.
Thank you, Dr. A.K. Das. I think you have brought a very wonderful evidence of how to protect the kidneys in diabetics, especially the overall protection with your lifestyle management, the ARBS, lipid control, especially the SGLT2 inhibitor, specifically the canagliflozin, as per the CREDENCE, how it exactly much better in preventing the progression of the chronic kidney disease. Thank you very much. Are there any questions from the floor? We can ask Dr. A.K. Das.
And Dr. Rajiv Goel.
Das, I have a question for you.
Yes, yes. Please.
I have started a patient on SGLT inhibitor. Suppose the patient developed a severe urinary tract infection, say like to extra pyelonephritis. Can I start the patient again after the treatment of the pyelonephritis?
Yeah. Patient will get treated pyelonephritis. It does not become a contraindication. We can keep a tab on the infection, and also keep a tab on the, during infection, proteinuria will go higher. It is because of the infection, but this drug is not contraindicated. If the repeated urinary infection, drug need not be given. And it occurs at the maximum in the 9%, but with persistence, it comes down to 4%.
Govil, what's your experience?
Can I just add a point, Professor Das, to
yes.
this interesting question? I think beautifully answered. What I thought was, if there is a background of an obstructive uropathy, then I think till such time that is being addressed, whether it is a calculus or a prostatic surgery, any form of even atonic bladder resulting in stasis and all. Of course,
I think that's a good point.
It is understood. I thought you definitely implied it. Just elaborate.
I think one has to keep in mind, if there is any risk factor for UTI, Professor Lakshmanan and Professor Venki, I must tell you that has to be addressed first. Otherwise, we'll be perpetuating infection.
So till such time, I think.
Of course, yes.
I
Absolutely.
think 1 out of 10 gets.
One question, one important observation is, you start a patient with the eGFR of 48. Now, what the CREDENCE, the message, I think I get it is, when it comes to around 28, don't stop it, don't panic.
Yeah, that's right.
Yeah,
up to 15.
This is different from the other SGLT2 inhibitors.
That's what I said.
The trial population, of course, eGFR of more than 30. But down the line, in the follow-up, because the benefit was much more seen in the CKD3A and 3B rather than in CKD2. So I think that is an important message.
Yes, that's what I said, that you did not
monitor the potassium and the creatinine.
Yeah, I think, Professor Venki, as you rightly said, as I emphasize that you need not start with the eGFR of less than 30. But when you started at 32, 48, 40, even if it comes down up to 15, it can be continued and gives a beneficial effect.
You said the class effect of these drugs, but I think the reason etroglyphosine did not show the benefit. It was a neutral drug.
Yeah, I must tell you, there is a new trial which not yet unveiled, Professor Lakshmanan, called EMPA kidney. We have seen the DAPA kidney, EMPA kidney.
No, I'm talking about the etroglyphosine, the new molecule.
No, etroglyphosine, you see,
did not show benefit.
I do not include that in the class effect. Even though in the ADA presentation, they said, I don't think ER2 has to be included in the class, because nowhere they came close proximity to the other molecules.
So I don't think we can quantify all the SGLT
You see,
inhibitors.
I will also say that the drugs, 3 drugs that have stood the test of time as the class effect are only 3: DAPA, EMPA, and CANA. And I think also REMO is undergoing the trial. There are some benefits shown, but it has not yet completely shown. You are absolutely correct. ER2 did not show the benefit. I will hasten to add that.
Correct. I think even for CANA and DAPA, if you go by the first 2 trials, it was more of exploratory analysis.
Yes.
Only in the CREDENCE trial, I think
It was
the primary endpoint, even in empiric outcome, it was exploratory. Of course, even the endpoints were robust. I think CREDENCE is a great trial in the sense that the endpoints were defined and they got it, and then the benefits were really proven. I think in that aspect, it stands as a molecule.
That's why.
As a class.
That's why I said, as Lion says, everybody is equal. Somebody is more equal. So all the 3 molecules are equal, but CREDENCE has established CANA as more equal. I'll tell you one more point also, that all these benefits were achieved with 100 milligram of CANA. Only in CREDENCE, CANVAS R, they use 300 in 1 arm to negate whether there was any amputation or not, and there is no amputation. But with 100 milligram of canafiglozine, CREDENCE has shown this huge benefits. Absolutely correct. Therefore, it is said in a jocular vein that all the 3 molecules are equal, but some is more equal.
Rajiv, we spoke about the DPP4s. I think wonderful molecules with a very great safety, especially the elderly population, and among which you made the star, the sitagliptin, wonderful molecule, safety in the liver, in the kidney aspect, and doesn't harm the patient. May not do much good like SGLT inhibitors. But what about the combination of DPP4 and SGLT2 in your practice?
Thank you, Dr. Lakshman, for that specific question. So the fairy tale of SGLT2 inhibitors has actually made us wonder that we need more things from our diabetic drugs than just getting HbA1c. So since you asked me about the combination, in the month of August 2020, we have a paper with me as the first author, and it's called as GRID, that's Glixambi's real world evidence from India. And we have published it in JAPI of 251 patients who have been put on this combination of Empalina. And what we did is that we either put patients who are on one of the drugs, we upgraded them to an FDC of Empalina, or we switched patients who were already on an SGLT2 plus DPP4 to this combination. So when we added a drug, we had a 0.7% reduction in HbA1c. Most important part is that when we just switched from an existing SGLT2 plus DPP4 to a fixed drug combination of Empalina, we had a 0.4% reduction in HbA1c. Just saying that just compliance of an FDC improves a lot of HbA1c. So this is a published study 3 months back in JAPI. So my experience with the combination has been very, very good. Whether the combination reduces the risk of UTI, as some of the trials have shown, I think it is a figment of imagination, which may not be true in a real life scenario. But the dual benefit of an SGLT2 plus DPP4 has a lot of synergy in action, and it really helps the end user patients. Durability is much, much better.
The A1C reduction is 1+1. It's not 1 plus 0.5.
I think can we just close this, because there is one more session.
Sure.
Okay.
Nice to see all of you all, and hope see you all soon face to face.
Thank you so much.
Bye-bye. Thank you,
Thank you, Rajiv.
Thank you, Rajiv.
Rajiv, thank you very much. Thank you, Lakshman.
Nice one,
GVK boss,
Thank you, Dr.
bye-bye.
Rajiv.
Thank you, Professor RSH, Lakshmanan for moderating, Professor Ekedas.
Thank you.
Rajiv. I think we come to the last session, a very, very interesting session. Meet the experts. I think the format has been familiar to you. I think it will be a very, very brief presentation. And before we go on to the program, I'm happy to say that I'm being joined by my good friends, Dr. Rajesh and Gauri, as co-chairpersons. So it will be a brief introduction and brief presentations for about 5 or 6 slides and some questions and clarifications with each person there. So without wasting much time, let us go on to the first presentation. It will be by Dr. Anjana, Physical Inactivity and Metabolic Sequelae. There's a slight change. I believe Anjana wanted to finish early because of some commitment. Can I have the introductory slide of Dr. Anjana? Anjana is there. She is already connected. Anjana?
Yes, she's there.
So, Anjana, good afternoon. And I would say the same introduction for Nandita and Anjana, because you've got the same genetic and environmental factors which you are molded to make yourself a diabetologist par excellence, and have been associated with enormous academic clinical activities in your center, which you have been part of it. And I was really impressed with the way you, I think you coordinated a program with a professional dancer, and then how you translated it.
Very good.
Physical activity. I was a witness to that video, and it was really impressive.
Fantastic.
Really interested in that, and then I think we have rightly chosen the right person for this particular topic of physical inactivity, the metabolic sequelae. Dr. Anjana.
Thank you very much. It's very sweet of you to talk about Tandav. Thank you very much, sir. It is one of the ways in which we try to combine physical activity, especially for women. So I've been asked to just share a couple of slides, and then there's more discussion I'm given to understand. So can I screen share, sir?
Sure.
Yeah, do I have the, just 1 second.
Sharing right.
Can you see my screen?
Yeah, it is. You have to make it full screen.
Yeah. Can you see, sir?
Yes, visible. Make it full screen, Anjana.
Yeah.
Slides so.
Yeah. Is it okay?
Yeah, perfect.
Yeah. So thank you very much, sir, again for that introduction, and a special thank you to Vijay Kumar, sir, for inviting me for this lecture here today. I apologize for this switch. When sir asked me, I'm committed to another talk at 4:30. I'm so terribly sorry. That is why. So he's asked me to speak about physical inactivity. What are the metabolic sequelae? So I don't have to tell you that we have a problem of physical inactivity worldwide. So we have a pandemic of COVID, but we had a pandemic of physical inactivity much before we had the pandemic of COVID. And surprisingly, no one is talking about it so much. And the reason for that is that it leads to metabolic consequences that you do not see immediately. It puts people in hospital, people may die of it, but not immediately. And thus, you don't see the emergency in the problem that we have. But worldwide, this is a problem. And what about in India? From the ICMR INDIAB study, we have data to show that the percentage of inactive subjects in the population is really, really high. So the red bars here, and this is across 15 states in the country, and you can see the red bars are the urban areas, green bars are rural areas. So obviously there's a lot of inactivity in urban India, some at 80% of the population being inactive, but surprisingly, look at the rural graphs. This is the 50% mark, and look at the number of states, which even in rural areas where you think people are very, very active, there you see plenty of inactivity. Now, what about men and women? The inactivity levels are clearly higher in women compared to men, and that is the kind of genesis of Tandav, where we're trying to push more activity among women specifically, because clearly it is high. Wherever you go, urban, rural, the women are more inactive than the men. And thus what happens? Well, these are all the things that can happen. And I'm not really going to go into all of these simply because we know most of this, right? You can get insulin resistance, metabolic syndrome, obesity, diabetes, a whole host of cardiorespiratory illnesses. There's muscle problems, there's nerve problems, digestive problems, rheumatoid arthritis, bone. So these are all the whole list of metabolic sequelae, all of which that come from physical inactivity. But also what is not very much stressed is usually the kind of mental depression and anxiety and things like that that are not stressed about so much, as well as premature mortality and morbidity. So all of this together are the consequences of being physically inactive. Now, oftentimes I get the question, physical, I'm just going to touch upon that briefly. So what is, activity versus sedentary behavior? Is someone sedentary? Is someone active? Well, just to let you know that these are not really opposites of each other. Now, in a 24-hour period, sedentary behavior only means the time spent sitting. That's what it means. So everybody has sedentary time. So you don't make a person sedentary or active. That's not how you do it. Everybody has 8 hours, 12 hours of sedentary behavior. And then you have an exercise time, which is a kind of physical activity where it's repetitive, done for health. So this is like half an hour, 1 hour, depending on the person. And the rest of the time is active time. So you have exercise time, you have active time, and you have sedentary time for everybody. So the aim should be to decrease the sedentary time and improve the active time. So that is the way you look for everybody. And that's how you decide whether someone is active enough for metabolic benefit. And that's how you, oftentimes people give me the thing, I'm a sedentary person. Everybody has sedentary time in their daily life, and how much of that you bring down is what counts. So what are the exercise recommendations? World over, people agree upon this, whether it's the ADA, whether it's the ACSM, whether it's the WHO, whoever it is, a combination of aerobic activity, and aerobic activity is anything that makes you consume oxygen. So all the exercises, the walking, the running, the aerobics, the swimming, the dancing, or all of this is aerobic activity, and resistance training, in other words, is muscle strength. So a combination of this at an intensity that is moderate to vigorous intensity for 150 minutes per week is what will give you metabolic health. So the recommendation is 150. So that's 30 minutes, about 5 times a day, 5 times a week, with a moderate intensity. So that is what the recommendation is, with 2 to 3 times a week of resistance training. So you follow what is called the FIT principle when you give an exercise prescription. F standing for frequency, at least 5 days a week. Intensity, moderate. And I think in our population, this is the most important thing. The small percentage of people who claim to be doing exercise also do not do enough intensity, and thus do not gain any metabolic benefit from this. The type should be aerobic plus resistance, and the time for 30 to 45 minutes at a stretch, usually safer to say 1 hour in our population. So I'm just going to take you through various age groups of recommendations. So for children, it is double. You need to do 60 minutes of MVPA, which is moderate to vigorous, bordering on the vigorous more than the thing. Just to let you know, we have studies that show us that our children don't even meet half of this. And as they reach adolescent age groups, it becomes very bad, especially among girls. So we have accelerometer data to show this. So most of the physical activity in a child should be aerobic, and the more vigorous intensity it is, the better. Now, in the normal course of events, this never used to be a recommendation. It just used to happen. But with our children becoming more and more sedentary, being locked up in homes, this is becoming something that one should be looking at. For adults, elderly adults, again, now age is only a number. So if you have a healthy adult who is able to functionally do everything, then it's the same recommendation. It doesn't change. However, if we're talking about those who have diabetes, have associated visual problems, there are bone and joint problems, or there are sensory neuropathy, etc., then one has to start making changes in the recommendations. So for an elderly adult, as much as possible is what we recommend. We start with 10 minutes. So even 10 minutes 3 times a day, twice a day, whatever they can do. And then, of course, depending on the condition, the recommendations keep changing. But if they are not able to meet the recommendation, then as much as possible in terms of frail adults. So that's it. My kind of 2 minutes on physical activity and exercise guidelines. So I suppose we can now.
Thank you, Anjana. I think, yeah, the difference is, yeah, when you talk about activity,
yes,
when you promote physical activity, it is beneficial.
yes,
Being sedentary is detrimental. I think there are two aspects to it. And it is interesting that just like you have the acute as well as chronic benefits of exercise, you
yes,
have the acute detrimental effects of being sedentary, and the chronic, you know about it. So I think maybe a comment or a question from the audience. I think it was very nice because you have done some lot of original work and you're enthusiastic. That's why I think.
I think Vicky, allow me 1 minute left for the interest of time. I must tell you, Anjana, you have been one of the champions, and we congratulate you. I come from a city where there is a Sri Aurobindo ashram, and the motto here is that one can miss the classes, but one cannot miss in the evening the group. Group means physical activity. And I personally believe that what makes diabetics live longer, get a better control with minimal drugs, what Mohan always speaks about, maximizing treatment benefit, living longer, and if possible, reversal of diabetes is possible through what Anjana has presented. Thank you.
Thank you, Professor Das. Nice input.
Venkatraman, I think we should also emphasize the muscle mass improvement.
Absolutely.
Improve the receptors in the muscles.
Absolutely.
I think 10 minutes should go for the muscle building exercise, strengthening exercises.
In fact, last time we had a talk on sarcopenia.
Yeah.
After the age of 40, there is a progressive decline in the lean body mass for everybody, accentuated by diabetes mellitus. And this makes a significant contribution to the perpetuation of diabetes per se. I think that point is very well taken. Besides that, I think incorporating dynamic exercises probably can retard the natural pattern of sarcopenia which occurs at the age of 40. And after the age of 60 or 70, it's something like 15% per year, which is very, very pertinent. So thank you, Anjana. I think good presentation, neat as usual. Thank you so much. My best wishes to you.
Thank you, sir.
So the next is, whenever we treat diabetes for complications. But all diabetics do not go in for complications. In fact, there are various theories. In fact, Professor R.S. Hariharan will remember when we were in the department, we always used to think this was Doxasia's pet topic, that is the rate of glycosylation. Given the same ambience and given the same environment and the hyperglycemia, not everybody goes in for the complications. That's at one end of the story. Second is, nowadays we have the phenotypic classification wherein we have been able to cluster, even though diabetes is a genetic component as well as an environmental component, it is more easier to study the phenotypes of diabetes rather than the genotypes. So the phenotypes or the clustering of the diabetes from the Swedish registry, if I remember right, or the Scandinavian study, and by Mohan, I think it has given a lot of credibility. Now, extrapolating from these things, Dr. Lakshmi will talk to us whether there is a low-risk diabetic. Lakshmi is the Associate Director of Professor Hariharan's Institute of Diabetes, eminent physician, and an oratorial skill par excellence. I've always been impressed with the presentation, for the language that she incorporates, and the message that is being shared in such a clear-cut manner. Lakshmi, it's your time now. I think, can Lakshmi share the slide?
Yeah, yes, sir. Very good afternoon to one and all present here. And at the outset, I would like to thank the chairpersons and Dr. Vijay Kumar for the wonderful opportunity. It is indeed a very humbling experience to be sharing this podium with all eminent people in the field of cardiology and diabetology today. And the topic that I will be zipping through in the next 10 minutes or so is there a low-risk diabetic? Now, all of you would agree with me that diabetes today has become a household name. We have a family which invariably has one of them who is a diabetic. So much so people have enough knowledge about diabetes, but what is very sad is that most of what they know is only the bad side or the gloomier side of diabetes. So my job in the next 10 minutes is probably to highlight the lighter side of things. So when you ask me, is there a low risk diabetic? I would say yes. So I will just support this with some experience and evidence-based statistics, and also help to identify a low-risk diabetic. Now, this particular experience was shared to me by Professor Hariharan, who told me that one Dr. Ajkonkar of All India Institute of Diabetes in Mumbai had instituted a victory over diabetes gold medal for diabetics that lived over 25 years of age, 25 years from the time of diagnosis without any complication. But obviously, he had to discontinue this award sometime later when he found that quite a few people actually fit the bill. So probably he was not able to shell out for so many gold medals. And looking at that, complications are what defines somebody as a low risk or a high risk diabetic. So going by the numbers, roughly 20% of our type 2 diabetics can develop retinopathy, 20%, or even we listened to the previous speaker who said 30% of them can reach ESRD in their lifetime. Diabetic neuropathy can happen in 50% of our diabetic patients. Cardiovascular diseases can happen in 26 to 35%. So all this, what does it say is that there is definitely a good number of people who escape without these complications, which is why Tattersall was very wise in stating that diabetes can be termed mild or severe only at the end. One who dies without any complications of diabetes can said to have had a mild form of the disease. But I'm sure all of us in clinical practice who have been dealing with diabetic patients completely agree with the fact that there are a subset of patients who walk away scot-free without complications, whereas we always get stuck with this one patient who ends up having every complication in the book in spite of being extremely compliant to everything. So why is this? So we have a lot of retrospective data, experience-based data, but what are the prospective or evidence-based studies to support this? Now, that is what the current cluster analysis, like how Professor Venkatraman was saying, that is an attempt at precision medicine in diabetes. Now, let's look at what it is. Now, this basically started out from the Scandinavian study, which was conducted over adult onset diabetes and looked at their association with the outcomes. It was published in the Lancet in 2018. And what they practically did was to look at roughly 9,000 patients of type 2 diabetes and looked at 6 variables. Age of diagnosis, BMI, HbA1c, GAD antibodies, HOMA2B and the HOMA2IR indices. And they looked at the fasting blood sugars, HbA1cs, C-peptide, GAD antibodies, and the zinc transporter antibodies. And with this, they were able to identify 5 clusters. The first cluster being the severe autoimmune diabetes. Next was the severe insulin deficient diabetes. Third was the severe insulin resistant diabetes. Fourth was mild obesity-related diabetes, and the 5th cluster was mild age-related diabetes. So what this kind of tells you is that clusters 4 and 5 are mild forms of the disease, and that amounts to 60.7% of the total population that was studied. So when you looked at the phenotypic characteristics of these clusters, what they found was that in the first cluster, which was the autoimmune diabetes, it kind of resembled a type 1 where they had earlier range of onset, they had a lower BMI, poor metabolic control, they had insulin deficiency, GAD positivity. So therefore, they had more frequent occurrence of decay and they were kind of difficult to control with respect to diabetic outcomes were concerned. Whereas the second cluster behaved extremely similar to the first one, but they did not produce a GAD positivity. And the incidence of retinopathy was more frequent in the first and the second clusters. The third cluster, which is the severe insulin resistant diabetic cluster, as the name suggests, were people who had a high BMI, high insulin resistance. Therefore, the observation was that they had more reports of NAFLD and renal progression. Now, we all know that insulin resistance is the first kingpin which tilts the balance towards nephropathy in a type 2 diabetic. The fourth and the fifth clusters, as the name suggests, were milder form of the disease with lower risk of complications. So to just give a pictorial view, when you moved from cluster 1 to cluster 5, the age of onset kept increasing as you reached cluster 5. The BMI was again lower in the first 2 clusters and kept climbing up as you went on to the other end of the spectrum. The metabolic control, however, was worse in the cluster 1 and 2 and was probably better in the farther end of the spectrum. Secretion and insulin resistance, as you have seen, and the GAD antibodies. Retinopathy and neuropathy occurred more with insulin deficiency, whereas nephropathy and NAFLD happened more in the resistant category. The same thing was extrapolated in the German diabetes study. I don't want to go into details because of lack of time. But a very interesting observation that was noted in the Italian study, which was done in the University of Pisa, was that 23% of these people who were put in a cluster had a tendency to switch clusters over a 5-year follow-up. I think that is a very interesting observation, very practically sound observation, which I think all of you would agree with me on that. So another observation that was made was by Dennis et al., who kind of looked at it at a different angle. What they tried to do was only simple clinical features. Now, what they tried to say was that simple clinical features are probably enough to just identify these people, and they're even probably better than clustering diabetics in order to look at the progression of disease and to personalize therapy. So what they claimed was they used only 4 simple clinical measures: age, sex, baseline HbA1c, and BMI. And with that, they were able to look at the response of the progression of diabetes. So what they observed was that age at diagnosis for glycemic progression and baseline renal function for nephropathy progression predicted as well as or even better than clusters as far as the risk of complications were concerned. So all this was with respect to the Scandinavian and the Caucasian population. Closer home, we have the Asian Indian phenotypic population, and this was done by the INSPIRED study by Mohans et al. And they looked at 8 variables. In fact, a very robust number of around 20,000 people were studied. And what they looked at was age, BMI, waist circumference, HbA1c, triglycerides, HDL, C-peptide, both fasting and stimulated. And what they found was 4 clusters. The first one was similar to the Scandinavian study of the one of insulin deficient diabetes. The second cluster was insulin resistant obese diabetics. The third was a combination of 1 and 2. They had both deficiency as well as resistance. And the last cluster was the mild age-related diabetes. So practically cluster 1 and 4 were similar to the Scandinavian study, whereas 2 and 3 were completely novel to the Indian population. So when you looked at the phenotypic characteristics, again, I will just spend time only with the mild age-related diabetics here. When you look at their manifestation, the age of diagnosis was obviously on the older side. They had a reasonably good BMI, they were not obese, the waist circumference, A1Cs, the cholesterol levels, the C-peptide levels, everything was acceptable. And when you compared it with the other groups, you find a marked world of difference in the 4th cluster. So which is why when you have to qualitatively look at all the characteristics, the first insulin deficient cluster had all signs of insulin deficiency with very poor C-peptide reserve, and they had to receive very intensive insulin treatment for good glycemic control. Whereas the second cluster were the ones with insulin resistance, so thereby probably they responded better to metformin and the rates of nephropathy were high. The combination cluster was probably the worst of the lot because they had the worst of both worlds. But the only good part was that it represented only a minority of 12.1%. And this was the most aggressive form of diabetes that was studied. And the 4th cluster was the mild age-related diabetes, where they had a very, very easy presentation and good control over a period of time. So to summarize, a subgroup of low-risk diabetics exists. The following phenotypic and biochemical characteristics help to identify such subjects. One is the higher age of onset, a near normal or marginally elevated BMI, near normal waist circumference, preserved C-peptide levels, acceptable HOMA2B and HOMA2IR indices, and normal cholesterol levels and easy to control hyperglycemia. The role of negative family history of complications of diabetes probably needs to be analyzed further. And in order to gain more knowledge on these areas, we probably require a lot of genotypic studies and genetic risk scores, etc. But above all, a long-term follow-up is probably the trump card to label one as a low-risk diabetic, because after all, diabetes is a disease which has multiple phases. It never is a heterogeneous presentation. And what I have tried to do in the last 10 minutes is to give an overview of only the good side of the disease or the low-risk diabetics. Thank you very much for the patience.
Thank you, Lakshmi. I think beautiful. As usual, you just excelled. I think the sum and substance is, if you analyze the phenotypic pattern of the diabetic subjects, we know type 2 diabetes is a combination of insulin resistance as well as insulin secretory defect. When there is insulinopenia, there's a predominant retinopathy and neuropathy. When there is insulin resistance, you have a more predilection for kidney disease, NAFLD, maybe cardiovascular disease. And this probably enables us to probably focus, maybe you have to have a much more stricter follow-up and the criterion, of course, with other comorbids into consideration in such of those who are prone for these complications, and probably have a closer look at the comorbid conditions in patients who have got insulin resistance, I think, which is what we are doing. I think these sort of data give impedance or give some more extra mileage or to our perception of the disease in general, and then focus the treatment in particular. Thank you so much. I think it was so good. I don't think there's any scope for any questions. Thank you so much once again.
Thank you. Thank you, sir.
Now we go on to the next topic. Vijay is sitting next behind me and then asking me to finish another 20 minutes. So HbA1c in an 80-year-old diabetic. To be very frank with you, till about a couple of years back, I thought Sanjay Reddy was always a silent performer, because whenever the primer team was there with Krishna, Prasanna and Arvind, Sanjay used to perform everything, but we used to meet him only in the evenings. I had an opportunity to do a meeting with him. I was really amazed at his skills of oration and his skills of communication. Yes, I was really, you remember we did a meeting about a few months back, and I was really impressed. I think Krishna or somebody goes to the background and then makes
I prefer to stay that
much more, so that we know the other side. We would like to know the other side of Sanjay Reddy, who is a diabetologist from Bangalore, and then he consults in Fortis Hospital, and he has been the principal investigator for so many trials. Sanjay, I would like to listen to you again in HbA1c in an 80-year-old diabetic.
Sir, thanks, sir. I'll share my screen. Can you see? Thank you, Dr. Venkatraman. It's usually a pleasure interacting with all of you. And Dr. Vijay Kumar always picks up a topic which probably nobody wants to talk, or nobody says it's nothing with it. Then when I looked at this topic, first thing I said is, let me look at how many patients I have more than 80 years. So I looked at my database and said, how many patients do I have above 80 years? And what can I do and interpret this into practical knowledge. Now look at this. The HbA1c was established, and the importance of HbA1c was way back at the DCCT trial. And if you look back at the DCCT trial and look at the number of people who are more than 80 years, I don't think it was the average age of the inclusion criteria in a DCCT trial where A1c established its importance was between 13 and 39 years. Even though they completed the EDIC trial, the maximum the patient's age was 55. Now I looked at other trials. Now what does HbA1c tell us? For patients, it's a main glycemic metric, main meter for rating the quality of diabetes care. For physicians, main diagnostic criteria, standard marker to assess risk of complication, target standard used in diabetes algorithms to modify therapy and set up new clinical trials, main health outcome parameter in terms of glycemia and its complications. Now, this is for regulators or reasons for this. Now, if you have an 80-year-old patient, are we looking at all these three? Is it used for diagnosis? Is this used for to assess glycemic control and quality? Or it is used for therapeutic decision making? These were three questions which I have to ask myself if I have an 80-year-old patient in front of me, and I looked at my data, hardly around 8 or 9 of my patients are 80-year-old. Then I went back to Dr. President and asked him, what's wrong? Say, you're young, you're seeing younger patients. You get older than me, older like me, you'll see older patients. And we know the average age or the average lifespan, which is going to go up, is to 72 years in India. Lucky if you're born in England, the average age will be 82 is the average lifespan. So we don't know what lifespans could be. We are a 40% population less than 30. We're going to go back to 60% of the population more than 60 in the next 2 decades. So that's a huge shift. So I looked at other trials. Now, these are all the treatment algorithms which are based on A1C. Now, for an 80-year individual, do they stand for diagnosis? Do they stand for treatment outcomes? Do they have any benefit? These are the questions which I wanted to ask myself. Now, I looked at A1C as a surrogate marker. Using A1C alone to improve glycemic target has not been optimal. We all know. Does not identify hypoglycemia. It has various physiological and pathological conditions. Wide range of glucose profiles can be associated with a given A1C level. And we all know what are the changes that can happen. Now look at A1C and look at all the confounding factors which can influence A1C. If you look at physiological states, only aging and pregnancy. If you look at aging, look towards your left. Anything which changes RBC turnover. This is very common with aging, if you know the physiology of aging. Number of drugs, number of comorbidities, the quality of the test, and all the other things which are associated with aging. All of them are confounding or contributing factors to A1C and what happens in the elderly. Now, looking at A1C as a surrogate marker for hypoglycemia, we all know it is not a marker for hypoglycemia. Even if the A1C is low, you can have a similar hypoglycemia with A1C of 9.4, and we may not have hypoglycemia with A1C of 6. This is shown in the study. Now, what are we trying to do is trying to see. I picked up 3 papers to tell you A1C may not be a diagnostic marker. You have an 80-year or an elderly patient. This is all elderly and A1C studies. I picked up only 3 studies. One is the Singapore study to show that ethnicity of A1C and age are very important factors where you can't use the same diagnostic criteria of A1C of 6.5 for the diagnosis of elderly diabetic patient or above 80 years or above 70 years. This is what this paper said. Now I looked at a bigger cohort, which was a huge, it was published at the Lancet, and I picked up only 3 points. Both low and high levels of glycemic control were associated with increased mortality risk. Level of variability also, the level of A1C variability is an important factor as you age, suggests that a stable glycemic level in the middle range is associated with lower risk. Glycemic variability as assessed by variability is over time may be a more important factor in understanding mortality risk. Now, these are the 3 things I picked up. And another one also, this is an BMC recent open access paper. The purpose of the study was the present study aimed to evaluate A1C in different age-specific levels. And what they found was it doesn't, as a consequence, this doesn't have as a consequence, age-dependent reference values become a very important factor in the implementation in daily practice and improve patient care and diagnosis of treatment, reduce the risk of misdiagnosis and subsequent overtreatment of patients in the. Now, what my question I had was a couple of them. Now, probably time in range and quality of A1C can be very different. We all know A1C at 7, but different glycemic variability. Is that becoming more important? I don't know. I have an 80-year-old patient at the clinic. Is he required? I have newly diagnosed. 30 years duration of diabetes, no complications. Do I want to do an A1C with him? And what do I imply? He has multiple comorbidities. He doesn't have any complaints. What do I do? Are no comorbidities. These are some questions. And what is your A1C? I will stop here and put it for discussion because I thought more interest to discuss. I can share some nice anecdotes with the same. Yes, sir. Thank you very much. Sir, you're muted. Sir, you're muted.
Muted.
You're muted, sir.
I think everybody will agree the way you presented the introduction was justified. Now, as you rightly said, with aging and the other comorbids being added, HbA1c may not be a reliable marker both for diagnosis as well as for management. And you really assured us that when you encounter an elderly diabetic with a low HbA1c, don't get worried because it cannot capture hypoglycemia. But still, at the end of the day, when I encounter an 80-year-old man with HbA1c 6.8, I will go all out to find out whether there are episodes of suspected, especially when the molecule on board is a secretagogue or an insulin. Certainly, I think you're reassuring and the science is absolutely good that HbA1c cannot pick up hypo. So the HbA1c in the context of an 80-year-old is more on the lower range to be avoided, in spite of the fact that the science is assuring us, and especially with the availability of molecules like DP4 inhibitors and other molecules, you can arrive for a HbA1c. I think it's a very good topic. I thought it was a very, very vague topic. You did justice to it. and then you
just wanted to
highlighted the limitations of HbA1c. You highlighted the factors that can be responsible for these erroneous values, and also in monitoring. Any comment or a question?
Venkatraman, I have a comment to make. I believe the number of articles show even in non-diabetic elderly, the A1C is high.
Yes, sir. Yes, sir.
Hyperglycemia.
You can't use it. Suppose you take diagnosis.
So please don't take A1C as an account of diagnosis in elderly. I think that's a carry message for
That is why I showed the Singapore study which said 6. Don't take that as the diagnosis. It should be age-specific diagnosis. This whole cohort, which was analyzed at Lancet, also they found there's a variability on the A1C. You can't take 6.5 as diagnosis. So more rely on the glycemic, on glucose as well as the A1C. Both you need to take into criteria, but keep it on the higher. As age increases, A1C does increase.
And the article 4,500 people, the above 80, the A1C, even a normal person is 7.3.
Yes, good way. We don't have specifics for our country. I looked at all the papers looking at complications in A1C. Even in the VADT trial, only 47 patients, the average age was 60. Only 47 of them were more than 79 years. So it's a very interesting, thought-provoking question. What do we know? You know longevity of A1 of diabetes nowadays. What should be cutoffs after 80? I think it's individualistic. That's all I can say.
And I think you did make a mention about the time in range. I think normally it is about 70% of 17 hours of the 24 hours time. Whereas in the elderly with around 80 years of age, I think it's around 50% or so, because 50%. You're more likely to avoid hypoglycemia rather than talk about good glycemic control. So when you quantify the glycemia, I think even the parameters, metrics like the TIR and the time below range has to be avoided. In fact, it should be 0. TBR should be 0 or even very insignificant contribution. So beautiful talk. I think I've done justice. Thank you so much. Keep talking, and then I would like to listen to you. As
no, I keep talking, but you're not there in the frame.
And the way you put it, I enjoy it. Thank you so much. So next we go on to isolated systolic hypertension in the elderly. I think Mahadevan is connected. Yeah. Now, loss of elasticity in the proximal blood vessels, because once there is systolic ejection of blood, the proximal airway, the proximal blood vessels have to accommodate it. Once that resilience is lost, this is the correct word, then that is manifested as isolated systolic hypertension. And to do it, I think, can I have the Mahadevan's, can I have, thank you. Yeah, there is a jump. So Mahadevan has probably the distinction of being a diabetologist and a cardiologist. In fact, cardiodiabetology is one specialty which was the favorite of many of us, because Dr. Professor Moses always used to, and Professor Hariharan followed that to a larger extent. And he was a self-made cardiologist. Probably he has excelled in cardiology as much as any cardiologist in contemporary practice I could think of. I think Mahadevan was inspired by him. So he has gone to acquire the qualification of a cardiologist and a diabetologist. And right now, he is the senior assistant professor in Department of Cardiology, Stanley Medical College. He is the director and his own center in Virugambakam, associate cardiologist in Vanagaram Apollo Hospital, and recipient of the Diabetes Awareness Award and the recipient of appreciation certificate. I think at this young age, he has achieved so much, quite justifiably. I think your appetite for qualification is there, and I have seen him make beautiful presentations. And one more opportunity for you, Mahadevan, with respect to ISH in elderly. Please go ahead.
Can I share my slide, sir?
Yeah, please. And the sharing option.
So I thank Dr. Vijay Kumar sir as well as my professor, Dr. Venkatraman, about the prologue about me, and thank for the opportunity. My topic is also the same as like the elderly populations, where we are moving away from the glycemic parameter to the systolic hypertension. We all commonly see isolated systolic hypertension. Only the systolic BP is in the higher range with a normal diastolic BP, or you want to treat it or you want to live it. If you want to treat it, what the guidelines, what the target you are going to set will be the talk of the day. And why you want to treat hypertension? Yes, we have to. It is not the number what you are going to treat. It is the organ which you are going to good benefit for the patients. By reducing the BP to the target range, you can reduce the stroke by 40%. You can reduce the myocardial infarction by 25%. And the heart failure reduction is significant, about 50%. Mere BP reduction of 10 milligram of mercury can be translated in so much of beneficial aspect in terms of vascular that supplies brain and heart and so on. And it is there is an interrelationship between the systolic BP and diastolic BP and the cardiovascular death. There's a relay correlations between the escalation of the systolic BP and the incidence of CV death. You can see as the BP matches systolic BP increases more than the 140 or 160, the incidence of CV events also increases, but these linear correlations cannot be extrapolated for the diastolic BPs. And what is the difference between the hypertension happening in young or old peoples? So BP, in terms of BP, the young peoples have both high range of systolic and diastolic, what we termed as essential hypertension. Both the parameters of BP increases, we call it as essential hypertension, which is very common in young individual. The major reason is the hormonal metabolism mechanisms. Kidney may be involved and sympathetic overactivity can be involved. Maybe the reason for the underlying pathophysiology aspect of young hypertensions. Whereas in the case of a mechanical, what we are going to see in next slides, the hemodynamic change, there is increased peripheral resistance is a surrogate marker of hypertension happening in the young individuals. Where here is arterial stiffness that may be due to a deposition of excess collagen or atheromatosis changes happening in the tunica media can be the reasons for the isolated systolic hypertension in the old age peoples. And the contribution of sleep apnea, thereby increasing the hormonal milieu that predisposed for hypertension is very common in young individuals rather than that of old peoples. And for criteria to label a patient as isolated systolic hypertension, the age of the patient should be more than 55 years, and the systolic BP should be more than or equal to 140 millimeters of mercury with the diastolic component less than 90. This results in white pulse pressure, which may be due to atherosclerotic changes or stiffening of the arterioles can be common. This isolated systolic hypertension is very commonly seen in female patients and elderly females, and it also may be associated or can lead to a heart failure with the preserved dissection. These are the things which we commonly should be noted in isolated systolic hypertension. How the age changes the BP spectrum. So when the patient marches from over the both of 30 years, both there is increase in systolic and the diastolic BP. Until the patient reaches the 50 years, after the 50 years, the diastolic BP drops. It can be called as burned out diastolic hypertension. But the systolic component is started to rise. There is no deepening or there is no decline in the systolic BP pressure as the age advances. This change in the systolic and diastolic BP is seen both in a female and a male populations. There is no sex difference. There is no hormonal benefit or hormonal influence on that the systolic parameter or diastolic parameters. So as age advances, there is an increase in the systolic BP with a drop in the diastolic BP, what we call as isolated systolic hypertensions. What is the main reason? As told by Dr. Venkatraman, the compliance of the large arteries, especially in the aorta, is been dampened. So it may be due to deposition of atherosclerotic changes that are happening in the tunica media or excess collagen. So collagen leads to poor disensitivity of the greater vessels. Elastin, young people have more elastin that can produce a more distensibility of aorta. Because of this non-compliant, the percussion wave which is generated in the ascending aorta and the tidal wave, which is deflection of the upper limbs arteries, has been augmented. That results in the high systolic component, thereby dampening of the diastolic component, maybe due to loss of peripheral resistance. So this results, the percussion in toto, the augmentation or exaggeration of the percussion and tidal wave results in the high BP with the dampening of the diastolic component. So this is a pathophysiology. There is exaggeration of the age-dependent stiffening. The age-dependent stiffening occurs everywhere. Even the EGFR comes down, the diastolic fraction of the heart declines, everything happens. The same amount of stiffening also happens in the great vessels, especially in aorta. In nutshell, it is a percussion in the tidal wave that results in augmentation of the BP that translate in isolated systolic hypertension. Excess collagen as well as atherosclerotic changes are major pathophysiological aspect of isolated systolic hypertension. And regarding the management, from the desk of evidence-based medicine, there are so much of trials conducted, high-weight trials, scope trial, stop trial, everything. They included many number of drugs. You can see ACE inhibitors and combination with the diuretic, beta blocker with the diuretic, and calcium channel blocker. Everything shared. You must have a good BP control to reduce the CV events, even the elderly populations. So there is no compromise of not starting any BP medications if the BP is more than that, or if you're diagnosed isolated systolic hypertension. So it has clearly opened eyes. That is unequal proof of BP lowering regimen. It will reduce the CV events in these elderly populations. Thereby reducing the BP, you can prevent strokes, you can prevent heart failure and death in these elderly populations. And antihypertensive therapies are safe in elderly as in terms of another counterpart, the younger populations in terms of CV reductions. And the intensity of BP reduction, you must weigh, because what is the difference of starting an antihypertensive in a younger age and the older age means there is a risk of hypotension is very, very common, because underlying autonomic neuropathy, underlying fluid disturbance, electrolyte imbalance can provoke for a risk of hypotension. And the elderly populations are also more prone for postprandial hypotension. So for that reason, all the guidelines, the registry from 11 countries have clearly enrolled the importance of ambulatory or home monitoring BP in this elderly population who are vulnerable for postprandial as well as orthostatic hypotension. If you treat the patient based on your conventional BP recording, that is office recorded BP, there's a possibility of over or under treatment in out of 3 people coming to a clinic. So white coat hypertension and mask hypertension, which is very commonly, can also be underwhelmed if you go for an ambulatory and home monitoring of BPs. And regarding the treatment guidelines, there is no much difference between the age spectrum of 65 to 80 years. Is at par as that of younger individuals. Whenever the BP crosses, whenever the systolic BP crosses more than 140, these candidates are more prone to start antihypertensive therapy and along with the lifestyle modifications. If the patients have diabetes or CKD, anything with the BP is more than 140 in the age group of 65 to 80, you can safely start any antihypertensive therapy if the lifestyle modification fails. If the patients comes to an age of more than 80 years, the guidelines recommends to start antihypertensive therapy if it is crosses the systolic BP crosses more than 160. So this is the thing: age more than 80 years, you have to start double the age. That is 160. More than 160, you start the patient on antihypertensive therapy if lifestyle modification doesn't fail. ESI guidelines are clearly endorsed. That is, fitter patient even the age of 80 years, you can start antihypertensive therapy, class 1A indications. And age more than 65 years but not 80 years, you can start antihypertensive therapy if the systolic BP crosses more than 140. But at the same time, antihypertensive therapy should be considered in all frail older patients if they are able to tolerate, that is class 2B. And not starting an antihypertensive therapy on the depending the basis on the age of the patient is not recommended. You have to give the benefit of antihypertensive therapy even elderly populations if they are not able to, if they are well tolerated. And regarding drug therapy, there is no much difference between starting an antihypertensive therapy for elderly populations and compared to the younger population. We recommend dual combination therapy if the BP is more than 160. You can start either ACE inhibitor or a diuretic or ACE inhibitor or CCB. Commonly used because we have more data on diuretic. So initially we start with the diuretic, but whenever you start diuretic in old age populations, you have to take into consideration of the neurological disease. Patients may have an underlying autonomic neuropathy or Parkinson's disease that can be in danger. And also electrolyte abnormalities, which may be gone unnoticed. Patients may develop lethargy or confusion due to hyponatremia. That may be a reason for diuretic, which may be easily stopped and easily preventable. And consideration of monotherapy should be given if any systolic BP less than 150 in elderly population more than 8 years. So more than 8 years, don't start with the dual therapy, start with the monotherapy. If there is a need, you can up-titrate the dosage or you can add any other group of drugs. And step 2, triple drug combinations, you can use ACE inhibitor, CCB and diuretic or ARB, CCB inhibitors. Resistant hypertension, you can add spinal electrodes. Beta blocker, as like in young individuals, it has mandated only when the patients develop heart failure or angina or atrial fibrillation or planning for pregnancy and so on. And treatment guidelines, what target you want to keep for 60 to 8 years, you have to keep BP around 130 to 190. Even for 8 years, the same BP can be targeted if they are able to tolerate the BP, whether they tolerate the side effects of the medications. So in treatment target, above 65 years, you can keep BP around 130, systolic BP around 130 to 139 and diastolic BP less than 80. And you can titrate the dosage as per the need, take into consideration of side effect profile of the drugs. Thank you for the patient listening.
Thanks, Madhyam. I think you have done justice to the topic as usual. I think why we included this was we clinicians tend to have a soft attitude. Supposing somebody is around 65, 70 years and the systole is 160, 162, we say that it's age related. I think this is some of the misconceptions that we had, even though there's been a proven association, especially with stroke and cardiac failure, and not maybe for the cardiac events. So there is a cause. I think you nicely highlighted the cutoff levels for initiating hypertension at the various age groups, the molecules that have to be used, and of course, a word of caution. We have seen so many times diuretics being used and then the hyponatremia especially. I think that goes unrecognized that you have nicely highlighted. and you kept on harping about the target. I think even though the age is there, still the risk is there, especially for the stroke and cardiac failure. And this entity of ISH has to be treated. I think we are running short of time as I keep on repeating it. Anyway, it was such a concise presentation, a lucid presentation. I don't think there is any scope for any doubt or clarification. Thank you so much. And we move on to the last presentation for this entire 3D 2020, and that is going to be on PCOS with euglycemia, normal GTT, who planning a pregnancy. And to do this, I am very, very happy to invite Dr. Ram Mohan, consultant endocrinologist in his endocrine clinic in Pogata, Nellore. In fact, Dr. Murthy is a very good friend of ours, and I have always, he has been introduced quite a few times. I've listened to Ram Mohan quite a few times. He also consults in Apollo Speciality, Nellore, and ISRO, Sriharikota, Nellore, and his credentials are there, and a very lucid speaker. And we look forward, Ram Mohan, the next 10 minutes is yours. PCOS with normal GTT, planning pregnancy.
Yeah. Yeah. Thank you so much, Venkatraman sir. It was indeed a pleasure to be with you all. Thank you so much, Dr. Vijay sir, for not missing 3D this year. And it's fantastic to be with all the senior faculty, Dr. Sanjay sir, and all of you. So that every day is a learning process for us. And thank you, Dr. Vijay sir, for encouraging and always giving opportunity. Thank you so much, sir. Today, my topic is PCOS, normal OGTT, planning pregnancy. What I want to say is that I'll be presenting this in a case scenario. This is a case of 23 years female with a BMI of 28, sedentary lifestyle, with a software engineer with history of weight gain recently, with a married life of 2 years, planning pregnancy. She was unable to conceive, and the age of menarche was at 2 years, and with oligomenorrhea for last 3 years duration, with a history of acanthosis, skin tags, and mild hirsutism with FG score, Ferriman-Galway score of around 14/36, and had a family history of diabetes. So, and on examination, she has an investigation showed euthyroid, OGTT was normal, ultrasound pelvis shown PCOS morphology with mild elevation of LH and prolactin was. This is a classic case of PCOS coming to our OPDs, endocrine OPDs. And what are the what I want to highlight is that this patient is married. Recently, she is obese. She has polycystic ovary syndrome with signs of insulin resistance, but her sugars were normal at the presentation. So what would be your plan of action to this patient? What are the things which you are going to do with this patient, and what are the things which you are going to or not supposed to miss in this patient are important. So coming to the diagnosis, we know that polycystic ovary syndrome criteria is that we should have clinical or biochemical signs of hyperandrogenism, ovarian dysfunction with oligomenorrhea, or anovulation with exclusion of other causes. That this is the PCOS is a syndrome of exclusion after excluding others like CAH, hypothyroidism, all the other syndromes which should be causing this. Then what are the goals of the therapy in a PCOS girl coming to you? Mainly the amelioration of hyperandrogenic features, then management of metabolic abnormalities like reduction of type 2 diabetes risk factors and cardiovascular disease, because all these patients with PCOS who are obese with metabolic syndrome are at risk for diabetes in the future. Most of them are pre-diabetics at presentation, and they may go into over diabetes or cardiovascular disease in the future. Then comes the prevention of endometrial hyperplasia and history of the risk for endometrial carcinoma because of oligomenorrhea, and also results as a result of chronic anovulation. And contraception for those not pursuing pregnancy, and ovulation induction for those who are pursuing pregnancy. Coming to the combination contraceptive pills, these are the mainstay of treatment in PCOD patients, because these contraceptives will suppress the hypothalamic pituitary ovarian axis and suppress the androgen production from the ovary, so that there will be improvement in menstrual regularity, decreasing anovulatory, uterine bleeding, hirsutism, and acne. So the mainstay of treatment are OC pills. Then progestin component also inhibits the endometrial proliferation, preventing the hyperplasia associated risk of carcinoma. The only thing is that the estrogen part of this COC are the danger to the patient. You should weigh the risks and benefits before starting COC to all the patients. Then what are the common drugs available in the medications available for polycystic ovary? As I told you, we have OC pills, POP, progesterone only pills. Then you have cell cycle inhibitors, GnRH agonists, glucocorticoids, and then for anti-androgens, like we use spironolactone in these patients, cyproterone estrade, glutamide, and finasteride. These are common anti-androgens we use in these patients. And other medications like metformin. Metformin looks crazy, looks so much of gynec prescriptions of metformin we see in PCOS, but really the data shows that metformin works well only where the patient is pre-diabetic or patient is diabetic with PCOS. Otherwise, metformin doesn't going to work well. But in some studies have shown that metformin can be used associated with clomiphene citrate for the induction of ovulation in these patients. And then we have other studies from thiazolidines. Then for pregnancy planning, we have the first line of therapy in PCOS is weight loss, weight loss, weight loss. Why means most of the patient, around 30 to 40% of PCOS patients gain normal cycles or come back to normal cycles with the 10 to 15% of the weight loss. So for example, if the girl comes with 80 kgs, around 8 kgs of weight loss will lead to normal ovulation or normal cycle. This is the first line of therapy, and the most difficult thing to tell to the patient is the weight loss. You plan weight loss means all the married ladies, newly married ladies, all the adolescent girls who are obese. The most difficult thing is about weight loss. We know about all these things, the metabolic syndrome and all the how the Indian population, young Indian population, are becoming obese. There is everywhere fast food, there is everywhere inactivity. And this is the first line of therapy. Then comes the treatment. Multi-step approach to treatment of anovulatory infertility is that first line is weight loss, as I told you. Then comes the letrozole or clomiphene. This is low cost and low effective. Then comes the FSH injections, which are high cost and high multiple pregnancy risk is there. The second line is ovarian drilling, and then comes the in vitro fertilization. These are the status by which we go forward to a patient who is planning pregnancy. And the most important thing is about the follow-up of this patient. For example, look for, at present, the patient's data shows that patient is OGTT normal, but patient is obese. We should look forward, keep the patient on follow-up, keep her weight under control, ask her to go for good physical activity and diet planning so that she doesn't go forward for pre-diabetes or diabetes in future. Then is look for metabolic syndrome, look for dyslipidemia, look for hypertension, then look for obstructive sleep apnea, and all the PCOS patients are at risk for cardiovascular risk. Look for all these risks. Look for NAFLD, non-alcoholic fatty liver disease, most common thing. And one more commonly missed thing is depression and anxiety disorders among the adolescent and young ladies who are having PCOS, because they don't find a solution in a near future. They'll be very much frustrated. They'll be very much frustrated to get to conceive, and this infertility problem is not going to end soon in this patient. So that the main concept of PCOS treatment lies in how to plan with the patient, how to counsel the patient about the present day risk and future risk, and how to tell them about this is not a single disease which you are having. This is a complex situation where you have multiple problems, and we need to, there is no a single drug available for PCOS. It is changes in your lifestyle, changes in your weight, changes in your diabetes control or pre-diabetes control, which is going to benefit you. So this is how you should explain your patient about PCOS so that the patient will be benefiting at the end. So thank you, 3D. Thank you, Dr. Vijay sir.
Thank you, Ramon. I think it was excellent. It was an excellent presentation and quite learning. I think why we really included this topic was quite often we encounter a lot of PCOS patients, as you rightly pointed out. I think many of the girls are in the IT profession, a sedentary lifestyle and free access to junk food and all. I think from the time they graduate till they get married, they easily gain about 10 to 15 kgs without realizing the implications of such a sudden increase in the weight. And you start the treatment for the weight loss as well as for the promoting ovulation and then planning for pregnancy. They become pregnant and they are at high risk for both pre-diabetes and diabetes. So initial screening would have made them euglycemic. Whereas even the first trimester, the HbA1c is around 6.9 or 7.1 in some of them, and they are surprised. No, I was always evaluated. How can the values can be wrong? In such a situation, I think it's always worthwhile to increase the monitoring as frequently as possible. I'm not too sure about the guidelines. And from the endocrine aspect, I think how to promote ovulation and how the metformin is being overused, especially in the absence of a pre-diabetes, because I think even though we know about the advantages of metformin, still it has got its own limitations, even in the context of PCOS, especially in the absence of pre-diabetes or diabetes. You nicely alluded to the fact. And I think Vijay and I are so happy that in your background, we see the diabetes dialysis and discussions, the 3D logo. So I think reminding everybody that you are part of this program. And maybe it's a message to your family as well, Ramavan, that you are there connecting only with. So thank you so much. It was so nice. And
thank you, sir. Thank you so much, sir. Thank you for the opportunity. And we are physically missing Venkatraman sir and Vijay sir at Nellore, sir, this year. Sanjay sir also. Next year.
There are no questions. I think it's
one question, sir.
Ramanan,
Yeah,
yes.
please.
How about the use of SGLT2 in a patient, in a diabetic patient with PCOD? Will it help introduce? Definitely, it will help in reducing weight.
Absolutely.
Patient
without diabetes. Without diabetes.
With
diabetes.
With diabetes. Okay.
See, young diabetic patients who are obese, PCOS coming to our OPD, we use GLP-1 agonists and SGLT2 inhibitors to promote weight loss in addition to any orlistat if they are comfortable with this. Any weight loss regimen is going to help your PCOS patient. Nothing wrong, and it is very help to the patient to lose weight. They are tolerating well without any UTIs. If they are comfortable with it, you go ahead with SGLT2 inhibitors in young diabetic patients with PCOS. Absolutely.
With the advice that they should stop it before planning pregnancy.
Yeah, absolutely. When they conceive, the pre-conceptional counseling is very important. You should be very careful when your patient is on anti-diabetic drugs, and about the thyroid management also pre-conceptional. These two things are important in PCOS patients.
So thank you so much. I think we had an excellent session. This session, I think everybody enjoyed.
Thank you so much, sir. Thank you.
Thanks, Anjana, Lakshmi, Sanjay, Mahadevan, and Ram Mohan for, in such a limited span of time, maximum information has been shared, which is very, very relevant for the clinicians. I hope
nice to see Rajesh sir.
Learning exercise for all of us. I'm sure everybody enjoyed it. Thank you all so much, and stay safe. Now, hand over to
Thank you.
Thank you.
Concluding remarks.
Thank you, sir.
Thank you.
Hi.
Thank you, sir.
Thank you, sir.
Thank you so much. This is one of the my favorite actually. In fact, Venkatraman was telling, I think you were stretching too much, he told me, but I said, no, this session is going to be one of the best sessions. In fact, then I said, yeah, I think so. But Venkatraman is basically, the main part of the scientific committee. So we had a discussion about this program actually. It's really, as I predicted, it was fantastic. Thanks to all of you.
Okay, sir. I think two big days. Okay. I'm sitting
all
in front of the.
Sorry?
I'm sitting from 9 in front of the laptop. I think I'm going to get toxicity if I sit anymore. One meeting after the other, RSSD, after this.
Yes, sir.
Talk about something some other time. Okay, nice meeting all of you. Bye.
Now, all good things have to come to an end, so that even these 2 days of fantastic deliberations have come to an end. I would like to thank all the faculty members for their excellent active participation. Not only for every faculty member was in. In fact, I have seen Ramanan, Lakshmi, Kannan. They have been there from yesterday and today also. I've seen that. Excellent. Thank you very much for that.
Thank you, sir.
And I would like to thank my group, Dr. Venkatraman, Dr. Anand Moses, for their scientific inputs. Krishna, the scientific inputs, they have made this program so excellent. And I would like to say that this program has been well accepted all over the country. Very good number of delegates. And in fact, neighboring countries have also participated in this program. So all that is because of, basically because of the good scientific program, and as well as the excellent speakers that we had so far. That's the main reason. So, and I would like to thank the organizing committee as well, like Gauri, Dr. RP, Dr. Sela Pandian, Dr. Mohan, and everybody, Kannan, and all of you have contributed to the success of this particular meeting. I would say it's a fairly good success. This is in spite of, we had holidays for 5 days in Diwali season. In spite of that, we had a good response from the delegate. And also, I would like to thank the RX events, Hardik, Prashant, Gaurav, and everybody from the RX events team for helping me. And then I've been disturbing them for quite often, almost 3 times, 4 times a day. They have been very patient to me, and they have tolerated me rather. And it was possible, this good uninterrupted scientific session for 2 days was possible only because of the team. And also, we are in a business center here in a hotel, and I would like to thank hotel people also. And thank you. Stay safe. God bless you.
Thank you, sir. Thank you so much, sir. Thank you.
For the opportunity.
Thank you,
Thank
everybody.
you.
Thank you, sir. Thank you for the opportunity, sir. Thank you.
Thank you, sir. Thank you, sir.